Good morning, Dr. Bischoff. How are you? Good morning, Dr. Bischoff. How are you?
Good morning, Ray. Can you hear me?
Yes, I can. Can you hear me? Can you hear me?
Good morning, Ray. Can you hear me?
I can hear you.
Yes, I can. Can you hear me? Okay, now I can.
Okay. There's an echo going on.
For me?
Yeah.
Good morning, Ray. Can you hear me?
Hear that?
Yes, I can. Can you hear me? Okay, now I can.
Okay. There's an echo going on.
For me?
Yeah.
Good morning, Ray. Can you hear me?
Hear that?
Yes, I can. Can you hear me? Okay, now I can. So I don't have anything on, just this computer. So I don't think the echo is from my side.
Okay, let me see what's going on over here then. I think I got it.
Okay, and is Greg Ryan on or no?
Not yet, no. He's
Ooh,
coming in any minute. He wanted to come in like 20 minutes ahead of time.
okay,
I'll send him an email to remind him.
okay. Then Cindy and Laura, I know them very well, so let me text Dan Wood.
He just got off his bicycle. So we have 624 registered as of just a couple seconds ago through the Hendron project.
That's
Plus
awesome.
whoever did through the Colorado one.
No, I don't think the Colorado will have any. The things, as you know, it has to be just the way you did. Like you have to keep advertising and then people get in. If you don't advertise, nobody get in. I'm gonna send my presentation. I'm gonna send my presentation in Alberto to you just in case.
Okay, thank you.
Okay, you should have received. I'm gonna contact Greg Ryan. The only strange thing is that it asked for a password today as I was logging in. I can't hear you now.
You shouldn't be doing that. Let me just go check. What did you use as the password?
Whatever password, and it accepted, but it asked for a password.
Okay, let me see what's going on there. Hold on.
Do you have Greg Ryan's WhatsApp?
Yes, I sent him an email. I don't have his WhatsApp. No. But he had the right time yesterday and everything, so he understood that. It's like 11 o'clock in Australia.
Hmm. And do we have anyone else besides you and me? Because I just see you, right?
Yes. I don't know if, well, we have two. No, let me see. I'm gonna start the webinar, and that'll allow attendees to come on in. There's one.
Hello.
Hey, Greg.
Good morning, Greg.
Good evening. How are we?
Very good. We'll be starting in 6 minutes.
No worries at all. So I just got my screen up. Just let me know if you need me to double check anything, sir.
Okay, do you want to double check things?
Yep. Okay,
Okay, I'm
just a
gonna
moment.
stop. Let me turn this off.
Yep.
So Ray, just so you know, apparently in the live stream, everybody can hear us.
Yes. We're now live.
Okay, so I've got my screen. So I just need to share that screen.
That's correct. Yep.
Okay. Does that come up okay?
Perfectly, and you didn't want to do the full display mode.
Yep.
Here we go. Perfect.
All right, so I'll just wait until it all happens and then I'll start. I hope I don't sound too bad.
Do you want to, would you like to stop your sharing right now? Your voice sounds wonderful, actually. So
Yeah,
you sound much
I'll
better
stop this.
today.
Yeah, it was yeah, I didn't sound too good the other night. I must admit. I'm sorry about that.
So Ray, I think some people are having trouble with the login because of the password. So Dr. Dan Wood is unable to log in.
Okay. What password did you use? Did you just use the number, or? I can't hear you.
I'm just concerned that this might be a problem for presenters because I put something and it worked, but.
The password thing is turned off, so I'm not sure why that's asking for that. And if it does ask for a password, the password should be, hold on, let me look, hold on.
Greg, when you joined, did it ask you for a password or no? No? Okay, you're muted, but I understood no.
No, I just clicked on the link that Ray sent me and I just got straight in.
Okay, mine asked for a password. Yeah, Dr. Wood cannot log in. I see Dr. Rink, so that's a plus. So Ray, I'm gonna start the meeting. If you can work with Dr. Wood, I'll share his contact just to make sure he can log in.
Let me ask Dr. Rink a quick question.
Sure.
Dr. Rink, did they ask for a password when you logged in? Dr. Rink, can you unmute for 1 second? I guess not.
Yeah, can you hear me?
Yes. Did they ask you for a password when you logged in?
They did ask me for a password, and I did not have one. I've never had to use a password for Zoom, so I just had to reset my password.
Okay.
So I just wanted to make sure my slides were going to show. I think we could share the screen and get that done.
Yeah, Ray. So I think it's asking for password for all presenters.
Yeah, let me see what
And
I
I
can
got
do.
on just through the regular Zoom connection, not through the one you sent that was unique to me. But it does allow you to reset your password.
Actually, that's what happened with me. I had to reset my password. I thought it was just a Zoom thing for me, but when I went in, which I
It
did.
happened to me too.
I didn't have to provide a
Maybe if you
specific.
want to send an email to all presenters and just let them know if it asks for a password, please reset your password, because otherwise I think everybody will have trouble. Okay, I think in trying to respect our time, we're going to start. Is that okay, Ray?
Yep, go ahead.
Good morning, everyone, and welcome to the International Colorectal and Urogenital Transition of Care meeting. We have a busy agenda, but everybody that is presenting today feels that this is an extremely important topic that we should all take action to move and provide our patients with proper care as they transition to their adult life. So every time we host a course, we try to start with a patient testimony, because that is the real reason why we're all here today. And no one better than Greg Ryan. He's an extremely active adult patient that has benefited the community of patients with anorectal malformation tremendously, not only by his example, by connecting people, by sharing stories. He has published book, he has created a foundation, and I know he will share more of his journey with you today. So as the first testimony, I would like to welcome Greg Ryan. Thank you, Greg.
Thank you, Dr. Bischoff, and welcome from evening in Australia, late evening. I'm sorry if I sound a bit croaky. I'm still getting over COVID, so hopefully if I cough a little bit, just bear with me, okay? So I'll just start. I'll share my screen now. Okay, so I'd like to talk about my patient testimony. I was born with imperfect anus anorectal malformation 58 years ago in the Royal Children's Hospital in Melbourne, Australia. I was born with no internal or external sphincter. I was born with high imperfect anus without a fistula. Both my testicles were undescended. I had a penile abnormality. 2 toes were joined on both my feet, and I had an extra vertebrae, which hence I qualified for the Rectal Association, which at the time wasn't Rectal because it didn't existed. And I was very fortunate at the time where I was born that the surgeons were looking after me were Dr. Douglas Stevens and Dr. Justin Cully, who were back in those days were the pioneers of ARM surgery, especially Dr. Stevens. And I have a special connection to Dr. Pena because Dr. Cully went to America and he showed Dr. Pena the Dr. Stevens procedure, which I had, which eventually turned into the PSAP. So I have a special connection with Dr. Pena through Dr. Cully. What I'd like to talk about is as far as transition of care is concerned is, as you will see, these are my records from my time in paediatric care at the Royal Children's Hospital. I was there for 18 years. And as you could see, I had surgeries right from the day I was born through to when I was 9 years old. But that didn't stop my care at the Children's Hospital. I would still need to go back and have yearly checkups, etc., with Dr. Kelly or Dr. Stevens at the time. But unfortunately, what happened back in those days was there was no transitional care plan at all in focus for us, for adults like myself. And what I'd like to show you now is the difference between what all my surgeries I had as a pediatric care. Now look at the surgeries I have had in adult care. So between 1985 and 2021 last year, as you can see, I've had twice as many hospital admissions and surgeries to do with my IA-ARM as an adult that I have as a child. And the unfortunate part for me and majority of adults of my vintage is that there was never any transition of care available, and the adult colorectal surgeons, to be honest, really had no idea what to do with us because they looked at us as a pediatric problem. So as you can see, it's pretty stark there by looking at all the surgeries I've had, and I'm still having issues to this day. So the discussion points that I like to raise is the transition of care plans to adult care, which have been virtually non-existent for IA-ARM patients until the last 10 years, the last decade. The mental health of IA-ARM patients is a significant issue due to the lack of the transition of care plans in the past. The lack of knowledge and awareness of IA-ARM by adult colorectal surgeon and adult gastroenterologists is a major factor in the impacts of the quality of life for adult patients. And part of my passion for raising awareness is that about 6 years ago, I started a online Facebook group called Adults Living with IA-ARM, which is a secret group because people still need to protect their privacy. And we've just got under 400 adult members worldwide now, which is wonderful. And I can tell you that every one of those adult members who joins that group has never met anyone else. And it changes their life when they join the group. But because I was doing this talk on transitional care, I thought I'd ask a couple of questions in the group. And these are the questions I asked. The first one was, it was very simple. Did you have a transitional care plan from pediatric to adult care? Have a look at the answer. Yes, 3%, no, 97%. And that's over 100 responses. So if that's not the most stark statistic that you'll find over the next 2 days, I don't know what is. And these are from adult patients. So this is right from the cohort that you need to hear from. And just a couple of the comments that I picked out when the adults showed me. I'm 40 now and no doctor has any idea what to do to help. I have a consult next week with a surgeon at a colorectal centre. I'm so excited. I received the most amazing pediatric care in Bristol, UK, where I was given the most amazing treatment for my lifestyle. Since transitioning to adult care 2 years ago, I haven't had any support and no one understands my condition or how to help me when complications arise. It is really so hard to keep positive and hopeful. I'm just so used to it now. The next one is the word transition would apply that there was care there in the first place. For me, it was simply, I went from no care as a child beyond my parents' feeble attempts for using psychologists since it was all in my head to now being smarter and seeing a proper GI. And the last one was, my answer is no. There was no transition of care, and that has been my goal to change for the younger generation. I was cared for at a children's hospital. I was 23 years old and then just left to my own devices. And as well, we all knows, as all we know, GI doctors don't know a thing about IARM. It's time to educate them. But this is not a criticism of the adult colorectal surgeons or the gastroenterologists, but this is just an absolute reality check for all those who are listening in on this seminar to see how much of an issue it is for the lack of transition of care for IARM patients. Now, as you can see from this, we had 90% of the patients had no transition of care. The next question I asked was, have you consulted with a specialist, colorectal or gastroenterologist for your IARM since you left pediatric care? And this is where it's really stark. So you've got 97% of patients had said that they didn't have a care, but 78% have had to seek care through an adult colorectal or a gastroenterologist. So it just goes to show how incredibly important it is to have some sort of transition of care in place. Once again, the answers. I've tried 3 times since my mid-20s. I'm now 38, and the last one seemed like all would be good, saying, I need to get this right as we don't transition from peds well. And he was going to do some research. Went back to a second appointment. He said he can't help me, but do come back if it gets worse. He also added that I keep up going to the gym because if I lose tone, I'll end up in a lot more trouble in my old age. Easier said than done when constantly having to trek to the toilet. Next one, I've seen a colorectal pediatric specialist, but the doctor I'm seeing seems uncomfortable treating me as his only adult patient. I don't blame him after he spent his whole career so far treating children. It's so frustrating to have a struggle to be able to get the quality of care that we need as we get older with our condition. I've responded with a yes, but each time I've either not been listened to, ignored, patronised, told there's nothing wrong, and generally considered as a time waster. Hence why IA no longer have any faith in the medical profession regarding my IA. Once again, this is not to be seen to be a criticism of the medical profession, the adults, but this is just the reality of what we face. Now, I'd just like to a bit about what I do with my 1 in 5,000 foundation. In 2021, I published a book which is called the Rare and Resilient 1 in 5,000 Anthology, which was a collection of stories from the global IARM community. We had 133 contributors, kids, teens, adults, parents, and family members from 26 countries. So if you'd like to know more about people's own personal circumstances, and which will include transitional care for adults, etc., you can just get the book on Amazon. All the funds go directly to our 1 in 5,000 foundation. And also, I've, in the last 12 months, done a podcast. We're currently up to 34 episodes, which we broadcast to over 60 countries, where we interview teens, adults, parents, as well as leading colorectal pediatric surgeons. And I've been very fortunate to have Dr. Bischoff and Dr. Pena as my guests. So once again, if you'd like to hear from a patient or parent perspective, I would encourage you to have a look on the podcast. Now, bear in mind the time's nearly up, so I just wanted to, the key takeouts is that the transition of care plans for IARM patients are absolutely essential. And to educate the colorectal surgeons, GIs, and family doctors on IARM. IARM is a lifelong condition requiring access to medical care as a child and adult. We are just not a pediatric condition. The mental health for IARM patients, especially for adults, is a major concern and probably the most pressing concern that adults deal with. And I'm sure you'll hear about a survey that was done through Children's Colorado by other speakers soon about the impacts from the psychological side of things. And I'd just like to thank the Hendren Project, Dr. Bischoff, Dr. Wood from Children's Hospital Colorado for inviting me and giving me the opportunity to present today on such an intensely personal topic for me. And if anyone would like to contact me directly, by all means, you can contact me on the email provided there. So I got through without coughing too much, which is great. So I hope I all made sense to you all. So thanks, Dr. Bischoff.
Thank you so much, Greg. I just want to emphasize that you are all an inspiration for you all, for us all. And I encourage everyone, if you have a patient with anorectal malformation, contact them with Greg Ryan. I think the new generation is lucky that they are able to find each other and not feel isolated. But for many years, our patients felt isolated. And I think this is one of the merits of Greg Ryan, to unite everyone so they share their stories, they feel connected, and they guide each other for the proper help too. So he properly emphasized the problem of transition of care, that it's lacking for many of our patients. And I think that's the main goal of today's meeting. I'm going to invite thank you, Greg. I'm going to invite Dr. Dan Wood to now introduce our guest speaker. And I will ask you, Greg, to stop sharing your screen. Thank you so much, Greg.
Thank you, Dr. Bischoff. Bye-bye.
I can't help but agree, Greg, a wonderful presentation, really highlighting some of the important issues, and thank you so much for giving that. I'm delighted to introduce my friend and colleague, Dr. Rink. Dr. Rink has worked for many years in Indiana, providing complex pediatric care for congenital or patients with congenital anomalies. I really wanted to hear from him, and I hope we will do shortly, about his experience in understanding the complexity of those conditions and learning through his vast experience about the experience of a pediatric surgeon in that realm and what he's learned over a career. Rick, I'm so grateful for you joining us. Thank you very much.
Thank you, Dan. I appreciate it. Everyone can see my slides?
Yes.
So good morning or afternoon or evening, wherever you are in the world. I bring you greetings from Indianapolis. For those of you who have absolutely no clue where that is, that's a map of the United States, and there's Indianapolis in the middle of the state of Indiana. Dan asked me to talk about lessons that I've learned in lower urinary reconstruction. So we won't be talking about anorectal malformations at this point, but it's a huge pleasure for me to have the opportunity to talk at your transition of care meeting. I don't have transition of care expertise, but I was smart enough to recognize this early in my career, and I've hired Rosalia Masseri and Josh Roth. So we have two transition of care physicians that are outstanding in our department. The data that I'm going to talk about today is not only from me, but it's from our whole department that's currently there, and those who have been there previously at Indiana University. And as you can see, there's certainly some internationally recognized names there. But this is 42 years of experience with 14 surgeons, and you can see that we've had a huge reconstruction. It's the largest reconstructive or lower urinary reconstructive group in the world, really. The problems that we face, though, haven't changed. These are the same kids that have severe neurologic problems like these myelomeningocele patients versus the severe anatomic problems like extrophy, or those who have destroyed their urinary tract by lower urinary obstruction. And what I'd like to stress in this talk is that term results. So you can make anything look pretty in the short term, but it's the long term, and it's those patients in transition of care that you're going to get that we've reconstructed in childhood. So I want to try to relay today what you guys are going to see as these patients enter your care. The goals haven't changed. When I first started, we wanted to normalize renal function and prevent urinary infections, but these issues came later. And as you know, 30 years ago, we basically thought the problem was too difficult, so we just diverted the lower urinary tract.
Rick, I'm so sorry to interrupt you. Your sound keeps coming and going, so we're getting intermittent voice intermittently. I don't know if there's anything you can do, but it
sounds like something scraping over the microphone, maybe a tie or part of your jacket.
Oh, I'm not touching anything.
That sounds
Okay.
really good now. So I don't know if there's anything to do, but
Okay. We'll try to keep going.
I'm sorry to interrupt.
Okay.
Can you hear me? No, thanks for interrupting.
Yep,
Everybody's got to hear. So that you think it's better now? I am losing my voice a little bit here.
No,
All right,
much better. Thank you.
If you can't hear, I apologize. So I do want to share that my basic bias has been that I had the belief that all children had the right to be dry. But I can tell you at this point in my career, I'm not certain that all children should be dry. So the single most important event that ever happened with lower urinary reconstruction was intermittent catheterization. So rather than collect the urine in an outside bag, we could now form an internal storage tank that could be emptied. And this led to this era of reconstruction, trying to protect kidneys. But in reality, what we found was many of these kids were dry. And so this led to an era of continence reconstruction. And that's really when lower urinary reconstruction in kids just exploded. So what I want to show you again is kind of our beliefs in the beginning and what we think now. This is a picture of me 18 years ago presenting at the American Academy of Pediatrics. And I would have told you at that time that all intestinal segments worked for augmentation, that bladder stones were always infection stones. If you crushed a stone, it increased the recurrence, that cathing through a catheterizable channel increased the risk. The need to augment was about 10%. I would have said at this lecture that B12 deficiency was rare and you could easily treat it orally. Malignancy was a big concern. I would have said that it didn't make any difference what kind of catheterizable channel you used. The risks were all the same. I thought anteriorly placed channels were better. And I would have said how often someone wets is the most important, and the quantity of stool leakage was most important. But as you're going to find in this, I didn't really know what I was talking about. So I was always told that a new idea was worth 3 trips around the world, one to tell people how you do it, one to tell them how you modified it, and one to tell them why you no longer do it. And we're not quite at that stage of 3, but I'm hopeful to let you know a little bit here in the next 25 minutes about our experience at Indiana. So let's just start back with the basics that I thought any segment would work. Well, when I first started, we used ileocecal segments for everything. It's the basis of the Indiana pouch. We then went to sigmoid segments where we would close the 2 ends and augment the bladder. And we even used stomach for a period of time. And you guys all know, I don't need to tell you what the risk of putting bowel into the urinary tract is. But we thought it would be really great to use stomach for a while because the acid would help with urinary infections. We could help get rid of the acid load in those patients with renal insufficiency. But what we found was about 25% of our patients had rather profound hematuria, dysuria. But even more important than that was just like your stomach's probably churning right now, it does the same thing when you put it in the urinary tract. So you can see these rhythmic contractions. And that led to a problem of needing to go back and augment them. The same thing occurred with sigmoid, where we closed the 2 ends and opened it. You had these terrible rhythmic contractions in those patients. So if you look at how many of these patients went on to re-augmentation, it was about 6% in the beginning, but most of these were in the sigmoid and gastric segments. We then presented a paper of 500 patients. Our first 500 augmentations became known as the Indy 500, and that incidence of needing re-augmentation was up to about 9%. So does it work? The answer is yes, but it has to be detubularized and reconfigured, as you're seeing here. And there's no question that ileum's the best. There's no question that augmentation protects kidneys, and no one would argue with augmentation in children with a hostile bladder. However, what's the cost of doing this to the child? In our original Indy 500 patients, we had this group of patients that had multiple complications, and we had about 2/3 that didn't have any problems. And we were not really sure why we had this group that had no problems and this other group that tended to have many problems. So what are the real risks of this? If we look at our 1,233 spina bifida patients at that time, we're going to talk about this group down here in this augmentation group. So the real risk here of needing or getting rid of your augmentation. Is this durable? Will it last? The answer to that is yes. We did have about 2.7% of our patients that had to be diverted after they had been reconstructed. But overall, that's a pretty low risk in the detubularized reconfiguration era. And if we look at the reaugmentation rate in the detubularized reconfigured era, it was about 5.3%. And you can see the reasons why that was done. So again, this is reliable, it's durable, and not too bad. Now, I told you in the beginning that with bladder stones, they were all struvite, and crushing them increased their recurrence. Well, let's look at what's happened over time. In 1999, we presented a paper that had 10% of our 286 augmentations having stones, all of which were stones of infection. Well, let's see what happened in long-term data. When we got to our first 500 patients, that incidence of stone formation had gone up to 15%, of which a third of them needed more than one intervention. We then presented a paper of what really was the risk of recurrence and was it impacted by the treatment modality. So if you look at our patients in our group, about a third of them had endoscopic removal of the stones, about a third had an open cystolithotomy, and about a third had a percutaneous removal, of which half of them had their stones fragmented. Well, what we found was that the type of stone or fragmentation did not affect the recurrence, that the recurrence occurred in about half of the patients at 10 years, and it didn't make any difference whether you had a catheterizable channel or the stone composition. But even more importantly, the stones really aren't what we thought. A third of our patients had non-infectious stones or bladder stones. And even if you had an infection stone, your recurrence rate may be with a non-infection stone. So there's clearly metabolic factors that you guys are going to have to recognize as these patients enter into their transition of care. And the real risk of bladder stones now at 10 years is up to 28% in our group. So really a significant problem in the augmentation group. And the 10-year recurrence of that is about half of them. And the only thing that's ever been shown to limit stone formation is the amount of volume used in lavage. This is from Doug Hoosman's work. But the larger the volume that those patients are irrigating with, and they should be doing that every single day, the less risk of stone formation. Sorry, I can't see some of my own slides here. So what about bowel obstruction? If we're going to do all of this, what's the risk of that? As it turns out, having a VP shunt or the number of channels, like if you had a May Santa Monte channel, the age of reconstruction, none of that made any difference. The risk of obstruction is about 6%, or, pardon me, the risk of needing laparotomy for a bowel obstruction is less than 5%. And that's actually better than a meta-analysis in bowel obstruction in children. So we don't really seem to have any increased risk over any other procedure. Now, B12 is really important because if they get to levels where they start to get CNS problems like dementia, those are not correctable. So again, I would have told you 18 years ago that it was rare and it's easily treated. Well, let's look at that. It's not so rare. 21% of our patients had low B12 levels and another 41% had low normal levels. We thought we could treat it orally. And this is one of our papers where we did oral treatment and 97% of our patients normalized their B12 level by 4 months. But again, the value of long-term data and what you guys are going to see, at 49 months out after oral therapy, only a third of our patients had normal B12 levels. So it doesn't work long-term, and some of those patients are going to need injection therapy for low B12 levels. What about the two lethal complications of perforation and malignancy? Any patient that's had a bladder augmentation that presents with abdominal pain has to be considered to have an augment because that's a lethal problem or a perforation until proven otherwise. And I use this slide just to say that I would not get a standard cystogram. They all need CT cystograms. This is a big urinoma and the bladder's compressed way over here. The 10-year risk of having a perforation in the detubularized reconfigured group is almost 10%. So 1 out of 10 of our patients that we've augmented have a potentially lethal complication at some point. Without question, the greatest risk of having a perforation is having had a prior perforation. 1/3 of our patients that were detubularized and reconfigured went on to a second perforation. So these are things you have to know in your transition if you're going to take care of these kids. We had a huge concern about malignancy. I even presented at the plenary session at the American Urologic Association about tumor risks. But as it turns out, in the current era, our 10-year risk of doing excision for a bladder tumor was about 2%, and all of them were benign tumors. But you guys are going to see a regrowth of these. So almost half of them had a recurrence of nephrogenic adenomas. Our risk of bladder cancer in the last huge couple of decades has been none. We've not had any malignancies. Now, I don't mean to imply that that's not a risk, though. This is something that you need to know about. We have stopped doing annual cystoscopies in all of our patients, which we did for over a decade. It just wasn't cost effective. But we do follow the Mayo Clinic's group. Anybody with gross hematuria, pelvic pain, new onset hydronephrosis needs cystoscopy. But the 3 high-risk groups you need to know about are those who have had a colon augmentation, are immunosuppressed, or have a gastrocystoplasty. And those patients should all have annual cystoscopy starting at about 10 years. So here we are with all of these complications that you guys are going to have to take care of. And if we look at it, at a median follow-up of 11.2 years, 41% of our patients had 370 additional operations. So even at an institution where we're reconstructing constantly, you would think we had this all worked out. We still have this significant problem, and these go on throughout life. And you can see that even 2 or more operations in 17% of our patients. So this is not trivial, and there's definitely things that you're going to face in transition. So what I can tell you about augmentation is it's durable. It will increase capacity and compliance and decrease contractility. It, without question, protects kidneys and improves continence, but you've got a high risk of needing further surgery.
Dr. Rink, excuse me, we're having that microphone problem again right now.
Okay, I may put my hand over it. Did I do it? Is it better now?
Yes, it is. Thank you.
Probably me putting my hand over it. So if you look at these risks, you can see how everything has changed from that original pie graph. And we're now up to nearly half of our patients needing surgery at some point. So let's switch gears looking at catheterizable channels. The second most important thing for reconstruction ever was Paul Mitrofanoff's catheterizable channel. And everybody knows that the appendix works great because it's durable and it's tubular and it has a good blood supply, but a lot of kids don't have an appendix. They've had it removed or it's been used for a MACE procedure. And if you don't have one, you can do a Monty channel where you use a very small piece of intestine and reconfigure it to have a catheterizable channel. And then you have the whole group of patients that are contorted or obese, which is a huge problem in the United States. And so if you need a longer channel, we would never recommend a double Monty. That's fraught with complications. We don't do that. We would use a spiral Monty. In that procedure, you take a segment about 4 centimeters, you open it up like this, and then open it on the 2 sides, and it unfolds. This is Tony Casal's procedure. And you have a Monty channel that's twice as long. Now, interestingly, if you look at our experience at Indiana, we have a huge volume that we're going to get this data from of total catheterizable channels nearing 1,000 patients. We generally put these in the umbilicus or in the right lower quadrant. So let's look at that experience long-term. This was our first 100 patients with an appendicovesicostomy and Monty. And if anything, our complication rate was greater with appendicovesicostomies. But here we looked at this, and I'll never forget Jeff Leslie, our fellow coming in. We're now looking at 297 patients, and he said, "Oh my gosh, you're not going to believe this. We have the exact same complication rate in appendicovesicostomies and Monty channels. 1 in 4 patients are going to have a problem." We were at some meetings and people were saying, "We're not having such luck with Monties. We don't understand why you guys are having good results." So we went back as a group and talked about what we really didn't know. And we didn't really know long-term results with these. We didn't know if it made a difference where you put the stoma. We didn't know if it made a difference if you split the appendix or how you implanted it. So let's look at some of that. Whether you take this channel and implant it intravesically or make an incision into the bladder down to the urothelium and put that in the bladder, it turns out that there's absolutely no difference in how you implant it. So that was not a factor in this. We divided our complications into stomal problems or subfascial problems. And this is the critical part, subfascial, and I'll show you why. If you look at the continence rates for an appendix versus a Monty, they're virtually identical. If you look at the stomal stenosis rate, but what we found was that there was a pretty significant increase in subfascial revisions in the Monty channels. And these are the reasons that that happened. You got elongation or angulation of the channel. You would get perforation or fistula or diverticulum. To summarize all of this in multiple papers, if you look at the 10-year risk of needing further surgery for an appendicovesicostomy versus a Monty versus a spiral Monty, it's really significant. Our Monty channels had 2 times the increased risk of needing further surgery, and the spiral to the umbilicus had another 2 times or 4 times that of an appendicovesicostomy. So there's no question that appendicovesicostomy is our best choice. Or if you like looking at Kaplan-Meier curves of complications, this is appendix, this is Monty, this is spiral Monty to the umbilicus. Huge difference. These channels are durable. We didn't see any difference in the stomal complication rates, we've also shown that these complications occur over the lifetime of the patient's channel. So that's critical for transition to care. And if you think these don't occur late, we have some of these complications out here up to 15 years out, still having problems with their channels. So just the thoughts on technique, that channel, that extravesical component has to be absolutely as short as possible. You don't want this tube that can get floppy and have outpouchings and things. This has to be secured up to the abdominal wall. Now I proposed doing this anteriorly. The catheter ends up in the same place and I could fix the bladder further and keep this as short as possible. But did it really make a difference? We looked at this with a South American group. And the answer is no, it doesn't make any difference as long as they're secured and fixed and the extravesical component is short. So another thing we learned, does it make a difference if you use a split appendix? For those who aren't doing this type of surgery, if the appendix is long enough, we can take a portion of it and use that as a catheterizable channel and bring this out as an appendicocecostomy. Did that make a difference? This is work from Cyrus Adams, our fellow last year, looking at all this. And just to summarize this, basically, it didn't make any difference whether you used a split appendix or a standard appendicovesicostomy. There was no statistical significant difference in this. Did obesity make a difference? You would think it would. It actually didn't in our hands. So that wasn't a risk, although it did change the type of channel you used. And I think you should try your best to limit stomal problems. We went through a period of time where we tried to actually hide every one of these so they wouldn't be seen on the abdomen. But I have no question that using some sort of flap or a ZQ or Z flap here, or showing some urothelium, intestinal mucosa, is incredibly beneficial to limiting your complication rate. And lastly, we thought teens were more at risk, but in fact, they weren't. There's no age group that was at greater risk for complications. So the take-home message is these channels are durable, no difference in stomal complications. It didn't make any difference where you put the stoma, but your Monty channels are going to have twice the problems of your appendicovesicostomies in our hands. So the bottom line is, have we helped these children, which is the most critical thing. Remember, the diversion rates had complication rates of at least 50%. Well, let's look at mortality in the spina bifida patients in the bladder augmentation era. The incidence of death from urinary problems was about 30 to 50%. Overwhelmingly, the most common cause of death was a urinary tract problem after the advent of the VP shunt. Well, in our hands, we had a 7.6% die, but they did not die from urinary tract problems. They died from these issues. And the two that did have renal failure had pre-existing renal insufficiency and were totally non-adherent with their care. So we've lowered the death rate in the spina bifida augmentation era from about 30 to 50% down to less than 1%. And the deaths are non-urologic. So have we helped these patients? I don't think there's any question. But this is not trivial surgery. So does this surgery really matter? Does continence matter? Believe it or not, there's no good data showing that continence really makes a difference until Konrad Zemansky and our group in validated questionnaires showed, and this is from patients all over the world. So you can see where the patients were in this study. But as it turns out, this paper did show that if you were incontinent, it lowered your health-related quality of life. And it also showed that the larger the amount of leakage you have, the more, the greater the risk. So it wasn't just that you leaked, it's that the more wet you are, the worse effect it had on your quality of life. What about fecal continence? Do those without fecal continence have a higher related quality of life? The answer to that is yes. Did it make a difference if you had a clean interval for a week? The answer was no. What kind of incontinence affected it? Any. So as opposed to urinary, where volume was important, any stool leakage is important to these patients. So anything we can do to help with that. So regardless of whether you have incontinence or not, if you wear an undergarment, your quality of life goes down. So basically, we would say this is great, everything's perfect, everybody's happy. So here we are in 2022, and our gold standard is interocystoplasty, and half of those patients are needing further surgery at 20 years. We didn't have opportunity to talk about bladder neck reconstructions, but you're going to do a major operation of which only about 70 to 80% of them are dry. And our catheterizable channels have a 25% chance of needing further surgery. So would I continue to do it? Absolutely. Because I think we've improved the quality of life in these patients. We've protected their kidneys. We've stopped renal death. We've helped them achieve dryness. We've improved their quality of life. But what would you do to be dry? You're sitting there now. What would you do to be dry? Would you be willing to go through all of this? And I'll just end with two things. These are critical things that you need to know if you're going to do this reconstruction. Who is it that wants the child to be dry? Is it the child or is it the parents? Do they want to be bone dry, or are they willing to accept some leakage? If so, how much? The commitment and adherence to the care of the family is critical to this, and they have to buy in before they go through this. And I would tell you that you cannot do this unless the family's committed to this. Everyone in the family knows how to care, has to know how to care for this child. And you have to have a team around you. You can't do this without outstanding nursing care and nurse practitioners to help with this. What do we do if they lose their bladder privileges? Currently, we're doing ileal chimneys. We've had about 44 of those in our institutions, 8 of which were previously augmented. But we don't know if that's any better either. So I appreciate the opportunity to share this data with you. I'm sorry we had some sound problems. We still have a lot to do. There's so much to strive for. It's been a great honor to talk with you people, and I appreciate the opportunity to do so.
Rick, thank you so much. That was an extraordinary display of data and of lessons learned. I don't know if there are any questions. If people would be very kind and put those on the chat, I'm happy to pass those through to Dr. Rink. Myself,
I just want to say one thing. I really appreciate the transition of care. I mean, I think this is critical. It was Greg gave a wonderful talk here in the beginning about the importance to the patient. And for us in the pediatric world, we can do all of these things, but someone has to, it's critical to have the care. And I think this is a wonderful meeting that you guys are doing. And I appreciate it, the whole world basically starting to commit to transition of care.
Really kind words. I don't know if you can see the chat, but there are a whole raft of very complimentary comments about your talk. I just wanted to ask one fairly specific question that's plagued my mind about particularly about Mitrofanoff channels that you talked about. You talked about the difference between an appendicovesicostomy versus a Monty versus a spiral Monty, which are very understandable data. But one question I had was, do you think that there's any kind of selection bias in that? So I know in my own practice that I would not, for instance, be doing a spiral Monty in somebody for whom there was an appendix available. And it's more likely that in a situation where I'm using a spiral Monty, it's going to be a revision surgery, which kind of ups the whole ante. Do you think that there's anything in your data that relates to the fact that there is just a complex revision context to those patients or not?
The answer is yes, I think there is. There's no question that, for example, obesity, you're not likely to do a standard appendicovesicostomy, and certainly not a split appendix in someone who's obese, because you just don't have a long enough tube to do it with. So if you've got 3 inches of adipose tissue that you have to bring a catheterizable channel through, you're more likely to use a spiral Monty. The question I've always had that we don't really have an answer for, if you put an appendix, a Monty, and a spiral Monty in the exact same location on the abdomen with the same length of extravesical component to that, or subfascial component to that, would those patients have less of a risk? And the answer is, I don't know, which again goes back to your, is there some sort of bias or patient selection that makes those data look worse than they are? I presume that there is, but we do not have the data to give an exact. We don't have all of these channels in the exact same place with the exact same amount of subfascial component to it.
And I think the other question that I wanted to ask was about obesity. We often talk about obesity and the risks associated with surgery in patients who are obese. I've not found an easy solution, particularly for those patients who are, for instance, wheelchair bound and for whom weight management is a real challenge. I don't know if your group has come across anything that helps with those patients, but I think it's a really difficult problem.
I think it's incredibly difficult. I think overall they're going to have more complications with their surgery. We surprisingly didn't, most data has shown that it affects it. In our hands at Indiana, we did not really show that in our catheterizable channels, but it affects your it clearly affected the selection of type of channel we use, which by definition we've just shown is going to increase your complication rate. And I think the other thing about obesity is what happens if they lose a lot of weight, or what happens if they gain even more weight? Is that going to affect this reconstruction? The answer is we don't have a solution. It's a huge problem in the state of Indiana. I just saw a magazine article that said that we were the 12th fattest state in the United States. So that's a problem. And I think anything we can do to help the children, particularly wheelchair-bound patients where their activity is much less, anything we could do to help them would be beneficial, but we certainly don't have the answers.
So there is another question, Dr. Ring. What would be your recommendation as the best age for bladder augmentation?
I think the best age for a bladder augmentation is when the family is ready to commit to the care of it. We certainly try to limit reconstructions in kids less than 5. It's been shown that they're not going to be compliant with, particularly like MACE irrigations. They have to be able to sit on the toilet. We didn't have time to talk about MACE, but most of our patients end up with 2 channels. So it's very difficult to get them to sit on the commode for 45 minutes afterwards. Generally, there's not much commitment up to that point. The more we do of this, the longer we've done this, with all this data I just presented is wonderful, but you could have the greatest surgeons in the world, and if you don't have a family that's committed and you don't have a team around you, you're going to have disasters. So I think the best time to do it is when the family says, we want this reconstruction, and they are committed to it. And that in some families may be 6 or 7 years of age, and another family it may be 12. So I don't think there's an exact age to answer the question.
There are a couple of other questions that have come up in the chat.
Sure.
One is about tissue engineering and the possibilities of, if you like, auto augmentation using tissue engineering. Do you have any views on where that might be in the future?
Well, 2 questions. Auto augmentation, I didn't have time to talk about. Auto augmentation is effective in lowering contractile activity in the bladder. It is not effective in increasing capacity. So if you have a patient that has a really big bladder, but has a lot of contractile activity, and auto augmentation is good. Otherwise, it's not. And unfortunately, most of the patients need both capacity and compliance. And therefore, it's a limited population that would ever be treated by auto augmentation. The second part of that is tissue engineering. And, we've been waiting forever for Tony Atala's work and those around, and Great Ormond Street's work to have a reliable means of tissue engineering to create bladders. To date, while there have been tremendous advances in tissue engineering, Tony Atala just this last week or so just received the highest award from the American College of Surgeons for his work. They have 450 people in their lab working at this, but as yet we don't have a reliable means of tissue engineering to create an adequately compliant bladder. But do I think this will happen someday? Yes, I do. And I think there'll be much more manipulation of neural reconstructions and things that will maybe limit some of the need for these operations.
Thank you very much, Dr. Rink, for this wonderful presentation. And I think it highlights that many of these reconstructions, the main goal is improving quality of life and keeping in mind that the quality of life should not be determined by the surgeon, but by the family and their patients. So I think the more we can make families and patients aware of all the needs. I always say, after a urinary, when you have a patient with leakage, the child is usually happy and they are playing. Once we do the reconstruction, yes, they are dry, but they will need to commit and catheterize. So we really need the buy-in from the family and from the patient. So I think the more we can inform them about what they are embarked themselves, the better it is. So thank you very much. This was a wonderful, wonderful presentation. And I see that our next speakers were able to join. So I will introduce now Dr. Cindy Buchanan. She is the psychologist with the urology and colorectal team also. And together with Dr. Laura Judy Glossy, who is the psychologist for the colorectal team. So welcome, Cindy. You can go ahead and share your screen.
Morning, everyone. Can you hear me okay? So for the next hour, we are going to discuss the patient experience in transition of care. And we are going to definitely leave some time at the end. So feel free to put in your questions in the chat and we'll be happy to answer them after we finish all three of our presentations. So I'll get us started. I'll hand it off to Laura, and then probably the one that you're looking forward to the most, Taylor Heap, one of our patient advocates and volunteers at the hospital, is going to share a little bit about her lived experience with transition. I'm going to start us off. I am the psychologist that works in urology and adolescent gynecology. I use she, her pronouns, and I'm also a faculty member in both the Department of Psychiatry and the Department of Surgery. And one of my many roles at the hospital is to facilitate patient and parent support groups. And so today, during my lecture, I'm going to share some of the relevant literature related to parenting anxiety associated with transition, but I'm also going to share some lessons learned from parents and caregivers in the context of our support groups, as we've discussed this topic of transition multiple times with our many parenting groups. Today, I'm going to use the term parents during my presentation. However, I know our patients have a wide variety of family environments and come together in many different ways, have a variety of caregivers and supports involved in their care, but I'm going to use parents during the course of this presentation. So here's a brief overview of some of the topics that I hope that I can share during our time together. First, I'm going to define kind of how we've conceptualized for our presentation healthcare transition. Then I'll address some overarching goals of transition. As the positive psychologist that I am, I'll cover some of the ideal aspects that we hope to have in transition as well. And then I will discuss some of the family factors that can contribute to a successful transition. We'll also get into some of the barriers and challenges during the transition from the point of view of parents and caregivers. And then finally, we're going to discuss some strategies for engaging parents during the transition process. So for our presentation, and probably this will be similar for many others, when we think about healthcare transition, it's the establishment of adolescents and young adults as independent stakeholders in their own healthcare. And then the other side of that is it's also the process moving from maybe a child or more a family-centered model of healthcare to a patient or in a more adult-centered model of healthcare. This can be with or without transferring to a new clinician or medical team, but it's more that transition of the kind of model of the care. And what are our goals when we're thinking about healthcare transition? Well, the first goal is to improve the ability of adolescents and young adults with and without special healthcare needs to manage their own healthcare and effectively use healthcare services. The second major goal is to ensure an organized process in pediatric and adult healthcare practices to facilitate transition preparation, transfer of care, and integration into adult-centered healthcare settings. So when I'm dreaming big and imagining what an ideal transition would look like, from the psychological perspective, I would say in an ideal transition situation, an adolescent and young adult continues to have positive health outcomes. They continue to demonstrate positive health behaviors and adherence to their treatment plans as recommended by their medical team. During this ideal transition, the hope would be that adolescents can gain independence and enhancement of their self-management skills. And then super important is that the adolescent or young adult will continue to attend their medical visits, engage meaningfully with their healthcare team, and really feel like they have autonomy and control over their healthcare. But where does this leave our parents and caregivers? Think about the parents and caregivers that have been managing their child's chronic healthcare condition since their child was born. They're connected with the medical team. Many parents talk about how they had to basically get a nursing degree to be able to care for their child. And honestly, some actually do in the process. The parents have been the primary communicators with the medical team. They've worked tirelessly and advocated for their child. They have engaged in meaningful activities and healthcare practices to keep their children healthy and hopefully happy. They've been key in their child's development and health outcomes. And so, as you can imagine, this is a huge shift for parents as we start thinking about transition. This time can be incredibly stressful and overwhelming for parents and caregivers. However, the engagement, participation, and buy-in from parents is really vital to the success of the transition planning and the process. So we need to think through some factors that may contribute to success during this important time. So there are a variety of factors that are family factors that can impact transition success. So, one of them is, supporting parental mental health. So if parents are struggling with their own mental health concerns, you can imagine how then thinking about having their child or supporting their child and taking on a more active role can feel really overwhelming. Calm and relaxed parents do a better job of teaching their adolescents and young adults about how to actively engage with their healthcare. They can talk to their children and with ease about different ways to connect and ways to improve their skills around their transitional readiness. However, we have to do a job of supporting the parents during this time as well to make sure that they're feeling that they have the support they need to be able to manage any stress or worry that they have. Parenting stress and parent-child conflict can reduce the ability of those involved to follow a medical treatment plan. So it can also impact the ability to support the children as they're learning about their healthcare needs with their medical team. Another factor that can impact transition success is having multiple caregivers that are not really on the same page in terms of their acceptance of the child's medical condition or healthcare needs. And this can obviously cause a challenge and confusion for adolescents when they're deciding about how to manage their healthcare and how to manage some of the recommendations given to them by the medical team if they're hearing different commentary from different caregivers or supports in their life. Sometimes, our children and adolescents can experience their parents as being annoyed or overwhelmed. And this can cause children to internalize their parents' annoyance, which can lead to feelings of guilt or lowered self-esteem. So, especially important during this transitional time when there are going to be things that will be overwhelming or frustrating for caregivers as the children are trying to take on a more active role in their healthcare. It's important for caregivers to maintain a positive attitude and try to have their own outlets to handle any frustration or annoyance that they may be feeling. Parental annoyance has been shown to be related to drop-off from medical treatment plans, whether that's medication, reinforcement programming, medical visits, and challenges during the transition process when teens need a little bit of that balance of support. They need the support, but they also need a little bit of wiggle room to make their own mistakes and to embark on their own journey related to their healthcare. Flexibility is obviously a key factor that can improve transition success. Parents often have to be very flexible with their teen as they're taking on a more active role in their communication with providers or their medical teams. So teens might forget or omit some information. They might miss a dose of their medication or a flush. This can be a challenging part of the journey for parents as they're supporting their child and gaining more independence and having a bit more autonomy. And so these are things that we need to prepare families for to support their kind of readiness for this transitional stage. There's also, this is a challenging one with our adolescents and young adults. So there's evidence to support that lack of parental supervision, even in adolescence, is associated with difficulty following a medical treatment plan. The challenging part is that during this time, adolescents are striving for increased independence and autonomy during these formative years. And so figuring out what that right balance of supervision, oversight, support, collaboration can often be a tricky one that we have to work through as we're supporting families in our clinics as they're gearing up for transition. So what are some of the common challenges during transition? So these are the things that parents have shared with us. You know, they say, are they really, is my child really ready to take all of this on? You know, my adolescent is gradually becoming more active participant in their healthcare and in their decision-making, but like, ultimately, are they going to make the right decisions? And, you know, these kinds of conversations can be really, you know, helpful for caregivers to have with each other, as well as they're supporting, you know, the progress for their adolescent or young adult taking a more active role. And these are also things that you might hear as providers when they're coming into clinic, talking about, you know, how are we going to support, you know, the patient to be able to kind of learn the things that they need gradually over time so that they can do all of the things that the parents and caregivers have been doing over the years. You know, in chronic healthcare conditions, parents need to take the control and all of the roles initially related to healthcare management, but now they have to share that role. And, you know, some parents may reflect, well, what is my role now as a parent or caregiver as my child is getting older? You know, maybe they have shifted their priorities and, you know, shifted their lives even to be able to provide the support that they need for their child. And now the child is starting to take on more of those responsibilities. So what really is that role definition look like? You know, in transition, and the topic can be new and could present as an opportunity, or I like to see it as a, you know, just, you know, an opportunity for continued growth, but knowing that there's going to be some challenges along the way. You know, we've all likely experienced, or you've experienced personally, like parents, you know, attending to their child's needs really above their own needs. And, you know, sometimes that's even at the exclusion of their own goals, vocational pursuits, or health as well. And so that role shift can be really challenging as we're working through and supporting the transitional stage. You know, typically, you know, for the parents out there, you know, you feel like you know what's best for your child, and you're concerned that maybe during a transitional period when these roles are changing, that your child may not be ready to make the decisions that are in their best interest. And, you know, rightfully so, like adolescents and young adults are still developing their executive functioning skills. So these are things like organization, follow through, and that can be super challenging for parents to see their children use maybe less effective strategies or systems, or, you know, maybe forgetting something or doing something in a different steps or orders than maybe the parents or caregivers would do on their own. And then, you know, finally, one of the challenges that we often see is this sort of all or nothing approach. So, you know, parents will, you know, give all of the responsibility to their adolescent to take on more roles, but maybe aren't providing the support or the education or the training that they're needing during this transitional period. So what can we do to reduce some of these challenges? Maybe this. So this cartoon, if people can't see, it says Westdale Obedient School, and it shows two parents and their dog waving at their teenager to have them walk off. But no, really, in reality, we need to start to engage parents early on in this transition process. You know, and reiterate that the goal is for the adolescent to be able to successfully manage their healthcare needs with greater and greater independence over time. And this is really a gradual process. starting these discussions early about transition, the need for some level of patient autonomy, and strategies for fostering communication within the family are really a great place to start. Reiterating with parents and caregivers that adolescents tend to learn better when they're tasked with paying attention and engaging with their medical team. We've probably all experienced this when adolescents or young adults might fall into some old patterns of relying on their parents to do the talking or asking questions if their parents are in the room. So we need to work on setting the expectation for parents. Like, when are they going to be in the room? When will the adolescent be with the provider independently? Who will the team contact initially? What are some skills or strategies that the family can start working on at home to support their adolescent with taking on more and more of these self-management tasks? And then I think I mentioned this a little bit before, but I think one of the other things that can be really vital during this stressful and also important stage of transition is having parents connect with other parents through support groups or national organizations, and getting some support and some perspective from maybe some other caregivers that have gone through a similar path, and helping them to frame this as an exciting time, even though there might be some challenges along the way. And then I think one of the things that, in our role as psychologists on the team is we really talk to parents a lot about adolescent development and understanding some of the key concepts, and common experiences that caregivers may experience as their child is transitioning into adolescence. So on this cartoon, it says that it's an example of the teenage brain, but I joke, this is not really the kind of development we're talking about here. What happens during adolescence is really a key milestone is that striving for more autonomy and independence, that shift of separating from parent and maybe more toward peers. During adolescence, really that development of these abstract thinking skills and executive functioning skills. And, yes, adolescents can have unrealistic perspectives of their uniqueness and maybe that like no one could possibly understand what they're going through. Adolescence is also a time when, there's some feelings of invulnerability, which can lead to risk taking, which obviously in the context of healthcare is we want to encourage our teens to take risks maybe in other aspects of their life that are safe. But these are all normal aspects of adolescence, and really important for the emerging adult. So a few kind of take-home strategies before I hand it over to Laura. These are some strategies that, can really help to reduce parental anxiety in the context of healthcare transition. So like I mentioned before, begin the transition preparation early. Start talking about these things early on in clinic visits. Encourage parents to and their child to have kind of one homework assignment or task that they can work on related to transition, starting, even in earlier childhood. Start providing education on transition responsibility. What's the role of the patient? What's the role of the caregiver? What's the role of the medical team? Let's differentiate that and figure out how we can work together on some of these common goals. We can also, all of us collectively can encourage independent visits with the adolescent and young adult with their medical team, throughout their different various stages of development, having some period of time where they can meet independently with the provider and discuss important topics. Obviously, the use of technology to target disease knowledge and self-management skills can be really vital. Medication tracking apps, technology where they can communicate with their medical team, technology or educational videos where they can learn more about their health. These things can all be really helpful to support the transition readiness. The other component that we can all continue to commit to is to regularly assess and discuss transition readiness on a consistent interval during healthcare visits. And then, working on improving that coordination of care between medical teams, if they're transitioning from different centers or hospitals or different care teams to support these optimal health outcomes. So thank you for letting me share a few of these perspectives, and I'm going to hand it over to Dr. Jaglossi.
Thank you so much, Cindy. I'll just get my, start sharing my screen. All right. As Cindy mentioned, I and Dr. Bischoff, I'm Laura Jaglossi. I am the psychologist that works with the colorectal team and have the privilege of working with our colorectal patients from very early childhood through adulthood. So I feel like I've had the opportunity to support a number of patients around some of these transitions. My presentation today has two main goals. First, to share recent research on supporting adults with anorectal malformations, because we know as we learn more about the adult experience, it assists us with adolescence and transition. Oops, excuse me. Sorry, this. And secondly, to also discuss effective strategies for transition of care. So our adult survey, we decided to evaluate the psychosocial functioning of adults with anorectal malformations several years ago. We partnered with Greg Ryan, who you heard from earlier today, and a private online support group that he runs through social media. Our study participants included 70 respondents who ranged in age from 18 to 75 years. So as you can imagine, they had many different experiences, being different ranges within adulthood. They were primarily female, as you can see, primarily Caucasian, and about 2/3 of them were from the US. We did have 11 other countries represented, but as you can see, this was not a particularly very diverse sample from our study. I will be sharing some quotes that were taken from our study that really help represent some of the perspectives of these patients. In high school and in my 20s, I suffered from depression, anxiety, anger issues, shame, embarrassment, and planned my own suicide due to the shame and embarrassment of living with the condition. I felt I would never get married or have children, that no one would love me or find me attractive. I had many accidents over the years, which caused me great mental anguish. So one of the first things we were interested in getting more information about was the mental health functioning of these adult patients. According to our survey, over 50% of them endorsed a history of some mental health concern. The most common ones were anxiety and depression, followed by post-traumatic stress disorder, or PTSD. This is quite notable because the WHO and other national and worldwide organizations indicate an average of about 2 to 4% of adults have anxiety or depression. So obviously this is quite a bit more. 65% of our participants had participated in some type of therapy, and about 50 of them had used a medication to address a mental health concern, typically a medication to address that anxiety or depression. We also wanted to look at their experience in work. So here's a quote from another patient. "Work is stressful and my management team isn't helping me. I feel as if I have to walk on eggshells just to do anything and hide the fact," oops, excuse me, I think my slides are advancing a little early, I apologize, "and hide the fact that I have to use the restroom so much. My family tries to help as much as they can." So we asked our adult patients about their experiences, both when they were in the school setting as well as in the work setting. One of the things we were particularly interested in is whether they received any accommodations. And so by accommodations, what I mean are extra supports that are relevant for their medical condition. So about 1/3 of the patients reported that they had some kind of accommodations while they were in the school setting. So this could be elementary all the way up through either high school or even the university setting. And interestingly, nearly 50% of them were unaware that they could have these accommodations. Within the workplace setting, the numbers were quite similar, where about 1/4 of them received some kind of accommodations within the work setting. And again, almost 50% were unaware that they could receive these accommodations. Interestingly, about 1/3 of our patients in the survey indicated that their level of employment, meaning whether they were employed part-time or full-time, was related to their medical condition. So we feel like there's certainly a need for increased education about school and workplace accommodations. And this is, of course, very relevant for transition as well. So within a school setting, we would often recommend that patients, really regardless of age, have access to the bathroom whenever they need to, have ideally a private bathroom. For younger kids, maybe the access to extra clothes. Nope, excuse me. And really be excused for any medical appointments. When we think about adults in the workplace, I think the biggest accommodation that could be helpful is perhaps an opportunity to work from home if they're having more physical symptoms that day. I honestly wish I didn't have this problem. It's embarrassing and hard to get close to people. So when we think about some of the common emotional challenges related to having a colorectal condition or urological condition, there's a few themes that come up. First, there's often the challenge of trying to gain support. We heard this both within our survey as well as within the patients that we see in clinic, that there's this challenge of trying to balance their privacy while also gaining support. Many of these patients have shared with us that they feel like if they had a condition that perhaps was less stigmatized, that wasn't associated perhaps with incontinence or things like that, they may feel like they could be more open with family members or friends or neighbors or coworkers. But often, given the nature of this condition, it can be challenging for patients to feel like they can open up or to know how much information to give other people around them. As a result of this, sometimes it can feel very isolating, or there can be a high level of emotional distress that goes along with these conditions. Because some of our colorectal conditions often are also seen as an invisible condition, meaning you may not be able to look at someone and tell that they have a medical condition, that can also lead to more isolation. And then in terms of relationships, as Cindy mentioned, sometimes there are poor relationships between the patient and family members, which certainly impact their psychosocial functioning, whether it's that annoyance that she mentioned or misunderstanding, the parent's own mental health concerns. We also know that these conditions can impact a child or adolescent's relationship with peers, within their school environment, their ability to participate in kind of typical activities for their age, like sleepovers or camps or things like that. My parents gave me the love and support I needed as a child and made me feel normal. My surgeon tried to give me a normal, healthy life, and I'm grateful for these things. So how can providers, the providers that are on the call, support their patients and families? So we know that knowledge is power, and the more that patients and families are aware of their medical condition, are aware of their prognosis for things like bowel and bladder control, are aware of potential common comorbidities from a medical standpoint, we know that they can be more prepared. This is particularly relevant and important for our children and adolescents as they transition to adult care or taking on more of that independence themselves. So the more they're aware that the patients and families are, the more prepared they can be for how their medical condition will affect their life. It's also really important to partner with patients and families. So this looks like several different things. First, taking time to listen to their concerns, helping patients and families brainstorm strategies to make a treatment program work for them. This could be helping patients think about a motivator to keep up with their daily medication or flushes or cathing. And then also thinking about when to reach out to a psychosocial provider or partner for support. Finally, we always want our providers to be asking patients and families about how they're doing in multiple ways. How they're doing physically with their bowel or bladder control, how they're doing physically with their bowel or bladder functioning, how they're doing socially and emotionally, connecting with peers, with family members, how their mood is. So that way they can really get the support they need. And if they are having difficulties, being aware of what those resources are to provide them support is very important. I wish I opened up to a doctor and asked more questions about my condition when I was younger. I wish children had a say in the medical treatment we experienced. So in thinking about transition of care, and when I say transition of care, I guess I'm thinking about it both in the sense of patients taking on their medical cares more fully, and the transition perhaps from a pediatric to an adult provider. So first of all, we want to give teens opportunities for independence. So certainly this can happen early on, even before teen years, and thinking about how to include a child or preteen in some decision making. So for example, can a 10-year-old have a say in what time of day they do their flush? This gives them opportunities for control. It also helps them to think about how to weave it into their schedule. As Cindy mentioned, it's also really important for providers to give teens in particular an opportunity to meet with them individually. It may be that an adolescent has questions about their body, whether it's related to puberty or intimacy, that they're just not going to ask in front of their parent or caregiver. So we always want to give kids an opportunity to ask those questions on their own. We also want to give kids an opportunity to take an active role in their medical care. So how can we structure things that so over time they're able to do their flush more independently, for example, or maybe they're even able to keep track of their medication and notice when they need to refill it. Secondly, it's very important to help think about how to help kids develop and maintain social relationships. Cindy and I have the opportunity to lead several groups, both for patients as well as parents, and it is so powerful to see how neat it is for the kids to meet each other and really kind of light up when they see that they're meeting someone else, either CATS or has a bowel program that they do, or perhaps both. And research really shows us that being able to meet someone who gets it, who understands your perspective, is really powerful and helpful for children's self-esteem. We also want to think about self-advocacy. So it's so important that teens are familiar with their medical conditions and learn about their treatments. Again, as Cindy mentioned, this can be done through educational videos. This can be done through maybe them reading their after visit summaries, having those discussions with their providers. But the more that teens are able to understand their medical condition and treatment, that will help them in that transition to be doing some of those things more independently. Because ideally, as they're getting close to 18, they would be able to advocate for themselves as they transition to adult care. And then finally, when we're thinking about this idea of transition, specifically in that maybe transitioning from a pediatric to adult provider, it's really important to consider the developmental level and then the mental health kind of status of patients. First, when I mean development, we know that some patients maybe have a different chronologic age than their developmental age. And so it's helpful to think through if there's any medical conditions or intellectual disabilities that might impact their ability to transition at the quote unquote typical age. It would be important to take that into consideration and think about what supports might be needed to put into place to support that transition. And then finally, mental health. Research shows us that it's important that mental health is assessed sometime during puberty to kind of think about how a child is doing from a depression and anxiety and kind of global psychosocial perspective to make sure that they're ready for some of the decisions that go along with transition. I wish those working in the healthcare field had told me there were many others like me. I wish they would have directed me to any resources that were available. I wish they had asked me about my mental health. So here at Children's, my social work colleague and I provide several psychosocial supports, and I felt like it would be helpful to share with all of you a little bit about the supports that we provide, because we feel like these different levels are certainly supportive and important for patients and families thinking about kind of transition and truly all ages. So as Cindy and I both mentioned, we do offer some support groups, both for patients and caregivers. There's opportunities for patients and families to meet with us individually, either with social work, who's often supporting the parent piece, or myself, the psychologist, who's often working directly with the child or adolescent. And then another big piece of what we do is share resources. So I've included a number of different psychosocial resources that are here that are related to various colorectal or urogenital conditions, because again, we feel like the more knowledge that a patient can have, both from an educational standpoint as well as the psychosocial support, the better their functioning will be. So there's a number of different groups through social media. There's a number of Facebook groups. Dr. Penny and Dr. Bishop have a group. There's a private support group that was started by several of our parents, and then the private IA or our Anorectal Malformation group that was run by Greg Ryan, which is the one we worked with for the survey. And then Dr. D has his own YouTube channel. So again, there's several options within social media. There's also a number of summer camps that are available for patients who have a condition that affects their bowel or bladder. Several of those are mentioned here, Youth Rally and the Serious Fun Network. I have seen numerous times the opportunity for either a preteen or a teen to attend a camp without a parent or caregiver. Obviously, a camp that has that appropriate medical support can be truly powerful and life-changing for them to gain the independence to take on their medical cares in a supportive setting, and really helps them both connect with others and gain that confidence that they can do a lot of these cares on their own. There's also a number of other organizations that are just present to provide support to patients and families of colorectal conditions. So this is one of my favorite quotes that was given by one of our adult anorectal malformation patients in our survey. A colorectal condition does not mean you can't have a wonderful life. Don't let it stop you, from following your dreams. So my contact information is here. I did also want to acknowledge and thank my colleague, Christina Matkins, our social worker, for sharing some of her slides with me. So we will transition now to Taylor. We're so excited to hear from the patient perspective from Taylor, so we'll let you take it away. Thank you.
Thank you so much, Drs. Buchanan and Jude Glossy. And it's our pleasure now to welcome Taylor Heap. I think we're all excited to hear you talk. So join us, please.
Well, thank you very much. Can everyone hear me? Awesome, perfect. Well, thank you for this opportunity to come and share some of my experience and some of the things that I have learned as both a patient and a patient advocate volunteer at Children's Hospital Colorado. So as it was mentioned, my name is Taylor Heap. I just recently graduated from Colorado State University and will be starting medical school here in just a month at the University of Colorado School of Medicine, which is super exciting to have that transition coming up. And my story and my experience today that I'm going to be sharing with you all is really talking about the multitude of transitions that I've experienced, just to kind of provide some semblance of a patient perspective. And obviously my experience is very minimal. It is just the one experience that I have. But in some of the conversations I've been able to have as a patient advocate volunteer and as just someone with a difference of sex development, I have been able to get some other experiences and perspectives that have really helped me, and I hope will provide some insight into the patient perspective for you all. So first, kind of talking about just my story and where it began. When I was 16, I was diagnosed with a difference of sex development. And so I do have a unique perspective in that, unlike a lot of other individuals, my experience with my condition and seeing a lot of specialized providers started when I was 16 and not at birth or even before for some individuals. And so that has allowed me to really start my experience with my condition as being able to advocate for myself, because I was at that point in my life where I was already doing that, and I was starting to take more control because it was just a few years before I was planning on going off to college. And my parents and I have always been very open about any medical things and any discussions that need to be had with providers or my pediatrician or anyone that I saw. And when I was diagnosed, something that was really, really beneficial is I had the immense support network of the SOAR clinic at Children's Hospital Colorado, which I'm now very fortunate to be a volunteer at. But within that clinic, it was really beneficial because all of the care providers talked to me and my parents as a team, and not just as my parents, and kind of either not acknowledging or just very minimally acknowledging me in the room. I felt that that gave me my voice and my power back, because when I was first diagnosed, I was met with a lot of resistance from my pediatrician and a lot of confusion from some specialists that I had initially seen that said that they had never seen my condition before and that I was some medical anomaly. And really having that power of advocacy from the care providers really helped me to be able to want to embrace my story and embrace my experience, which as I transitioned from my pediatrician to starting to see adult care providers when I turned 18, that was really beneficial to be able to have had such a large role in my medical experience and my story, as I understood what my diagnosis meant for me and the medications that I needed to take and some of the other care that I needed to seek out as I transitioned from pediatric care to full adult care. At Children's Hospital, I was able to stay in the pediatric care until I turned 21, which was beneficial because in the last few years alone, I can kind of just speak on all the different healthcare transitions I've had. So not only did I transition from a pediatric primary care provider or pediatrician to an adult primary care provider within my home network of insurance and physicians, that also meant trying to navigate the shift from pediatric specialties, which I have seen, I believe 5 or 6 specialties pretty regularly, and trying to find specialists that also fully understand the nuances of my condition, into adult healthcare and trying to navigate that with insurance, not being willing to provide coverage for that. I have also transitioned from the adult healthcare at, or where my parents live and where I grew up, to where I went to college for 4 years and having to navigate finding different providers there and what it meant if I needed to see someone for my condition, how I needed to be able to advocate for myself. And then now that I have graduated from college and I moved again, now navigating not only to postgrad, but also navigating changes in insurance that will also force me to see different providers. So I have experienced a lot of transitions within healthcare. And I think some of the things that I really want to speak on that have really helped me, first off, is the normalizing of my experience. So my parents, they never stopped me from discussing my condition with them. They never stopped me from if I asked questions, and they really empowered me to ask those questions. And if they didn't know the answers, either to look them up and we could work together to find those out, or to bring them directly to my care team. And this allowed me to directly take action and take initiative within my own healthcare, because I was able to satiate that curiosity while also learning more about my condition and learning about how to go about taking care of myself and seeking out those needs, because that transition in and of itself can be really, really stressful for a lot of children and teenagers and young adults, because for the first time, we are tasked generally with the responsibility of, you've had parents and caretakers take care of you for your entire life. And now not only are you switching to an adult provider, but you're expected to do that on your own. And so having that shift from, or with my parents, was really helpful. And that was really made beneficial and even more successful by the care team providers, because they encouraged those questions. And in some of the conversations, they did talk with my parents and I in the same room, but a lot of the time my parents stepped out of the room and I just talked with the care provider. So it really empowered me to be able to understand my story and ask the questions that maybe I even felt embarrassed about not knowing or feeling like I needed to ask. Because once I kind of got that embarrassment and those nerves out of the way, I realized just how important it is to be able to take control of that story and take control of that narrative, to be able to then later share that with other providers. Kind of the second thing is the idea of self-advocacy. So a lot of times as children in healthcare systems, especially seeing specialists or with very specialized conditions, the parents are the advocates, and the parents are the ones that know all about the condition and know who to contact if their child is not getting the care that they deserve or that they need. And also the care providers. So you all, or a lot of you that are on this call, you are also tasked with advocating for your patients, whether that be advocating for greater support resources or advocating for your patients with insurance companies to make sure that they can be seen and can get the care that they need to make sure that they have the best quality of life. But when transitioning from pediatric to adult, then that burden of advocacy shifts heavily onto the child. And especially when the child is also seeing, and like the teenager is being seen by new providers, then the burden of advocacy shifts almost fully from being on parents and pediatric providers onto the child to kind of be the middleman for as they navigate transitioning into adulthood and finding their own healthcare and being able to share their story. And again, I did mention this earlier, but with the SOAR clinic, having the advocacy from the providers not only allowed me to share my story, but it also allowed me to connect with other individuals with similar and even the same condition and diagnoses that I had. And that allowed me to really embrace my story and be able to advocate for myself and knowing like, I deserve better than to be treated by like that from a physician. I deserve to have this kind of care and I deserve to have these answers. And being able to have that view of self-advocacy was really powerful because when I transitioned into adult healthcare, some of my records transitioned over, but I mean, physicians right now are often very overworked and don't have the time to fully scan through a new patient's full medical record. And again, sometimes that burden of advocacy is placed back on the patient, which can be very difficult for a patient if they are not fully aware of all of the nuances of their medical conditions. I know for myself, I met with, I think 5 or 6 doctors within that first year of transitioning from pediatric care to adult care. And that was both with me almost shopping for primary care providers, while also being seen by just a variety of individuals at my college's healthcare meet or like institution thing that they had up there. And it was really powerful for me to be able to consolidate my experience and to be able to say, these are the things that I know I need. And if you need more explanations, I can explain why I need them. But you can look in my chart and these are the things that I know that I need to have the greatest quality of life. I need these expectations for care. And for the most part, I received very beneficial or very positive responses from the providers I saw. And for the few that didn't give me positive responses, I was like, okay, thank you very much. And I left. And I went to see a different provider because it's not my responsibility, or it's my responsibility to advocate for myself and to help educate and start that conversation with a lot of these new providers, but it's not my responsibility to fully change a physician's perspective. And because that burden can often be too much when I'm trying to navigate a lot of other changes and whatnot. And so that has been really powerful for me to have that self-advocacy. So I know that no matter where I go, I will be able to share my story and share my experience to be able to find someone that can provide for me adequately. And then the final thing that I want to touch on is mental health in that transition, because I mean, as the saying goes, change is the only constant in life. But regardless, it doesn't make change any easier, especially when it comes to navigating healthcare transitions and transitioning from not feeling like you have a lot of knowledge or control over a situation as a child and a teenager to then being what feels like given full knowledge and transition over your healthcare decisions. The mental health toll of that is really critical to look at and to consider. I know for myself, it took a long time for me to come to terms with my own mental health and where I was at in regards to my condition. Because when I was first diagnosed, I put up a facade, and I didn't really realize it until several years later, but I put up a facade like, oh yeah, I'm fine. Like, it's okay. Like, I'm good. I don't need to worry about this. I don't need to see any specific provider. Like, I'm fine. And it wasn't until a few years later that I really realized that I was able to come to terms with my diagnosis and my story and being able to advocate for myself by also acknowledging the toll that a specialized diagnosis or feeling like you are one of the only people in the world with a certain condition or aspect of your healthcare, that can feel very isolating, and it can feel really difficult to try and navigate that. And so seeking out and providing, as providers, healthcare resources and opportunities for patients to discuss their concerns and to have an open and honest conversation about those things is really powerful. Obviously, mental health in that landscape is constantly changing. And that is why it's so critical to rely on psychologists and psychiatrists and other individuals within care teams to really help provide that mental health support. But regardless, it's really important that as a care team in general, that mental health is a part of that discussion. Because if it's not, then that can make it really difficult and almost stigmatizing for those individuals if they feel like they can't discuss their mental health needs with any of their providers. Then that can feel like, oh, well, if I can't even discuss it with the doctor that knows exactly what I'm dealing with, how in the world am I going to be able to discuss it with a partner or with friends or with anyone that I meet in the future? And so really working on destigmatizing and normalizing those experiences for me has been incredibly powerful. And I mentioned this earlier, my experience is not a one size fits all, or what I've experienced can help anyone or help everyone. But I do think that some of the main takeaways that I've been able to share with other groups and physician groups and parents and patients is the power of having those conversations and normalizing it and allowing the child and teenager and young adult into those conversations can really be life-changing in how a child or a teenager or young adult views themselves, views their value, views their worth. And that really starts with the healthcare that they receive and the treatment that they receive whenever they're navigating those transitions within the healthcare landscape.
Thank you so much, Taylor. I think you touched a lot of important points. One, I think that you just mentioned was about medical record. This is something, especially for patients that are operated during childhood. When they come to us as an adult, we don't have access to their medical records anymore. So I think this is something that we, the doctors, but also the patients, the families should all be aware of, because everybody thinks, oh, my records are safe, they will be there forever. And it's not true. And we don't even know what's going to happen with this new era of electronic medical records. So I think we're trying to create for our patients like medical identification cards or passport that at least have the key basic information. But we advise our families to always keep copies of operative reports, important images, because unfortunately, we cannot trust anyone. And since as the patient, you're the one that has the most interest in having this information. You also mentioned insurance, which I come from a different country, so insurance has been a whole different world for me. And many times I point the parents of my patients to parents of other patients that have already battled that, because they know what they have to fight, what it has to be done, so they can reach the hospital that has the experience. So that's another reason why support groups are so important. You can share your experience, what you have done, what has worked, how you have fought your battles for the next patient to come. And then transition of care. This is the whole purpose of this meeting. And many people may be wondering, why is this such a problem? But we have to remember that we all, in each specialty, we have what we call the bread and butter. That's the daily life of our practice. So when a child is born with a congenital condition, doctors that are in the pediatric side, they are extremely familiar with it. They're the ones that do the operation. And if you think about doctors that are in the adult side, they are not familiar with that. So it's not that they don't want to as a patient, it's that they are not familiar with this condition. And that's why, since medicine has evolved so much and patients are living well, we are seeing the birth out almost of a new specialty of adult providers that are taking care of patients that were born with congenital conditions and now are growing to adult life. So it has to be a lot of communication between us and the adult providers, but hopefully we will soon improve. Now, insurance, I don't know how we will improve that, but I think it will come from pressuring from patients and doctors. I think there are many questions for the panels. So Dr. Dan Wood, if you see some question, let me look through here and then we'll address them.
Yeah, there was a question right at the start of Cindy's talk, which I think was directed towards you, Cindy. But what age do you think it's right to start talking about transition?
When the baby leaves the hospital from the nursery to go home. I think it's something that we, want to be talking with parents of our school-age children about some tasks and roles that their child can take on in terms of the duties and responsibilities. We saw a wonderful thing in the chat from one caregiver that said, like, my child was 6 or 7 and I was working with them on cathing and understanding their medical supplies that they need and how to do this safely and effectively. So some of those, healthcare responsibilities, we can start when kids are, during that elementary and middle school age. But certainly by the time we get to middle school, we need to be talking about and fostering some of these strategies around independence and offering some opportunities for our emerging adolescents to meet independently with their healthcare team during their medical appointments. And then, I always tell parents, like, when you're calling to do the refills, put the phone on speaker and have your child sitting next to you. When you're pulling up the app to order your medical supplies, like, they don't have to be the ones that's doing it or responsible for making those orders, but they can see what that process is like. When you have questions, teaching your child to, hey, let's write these down so that we can take these in when we go for our visit. Hey, this is how I take notes after the visit, and this is where I store them. Like, starting to give them some of those tangible skills that can help foster some of that confidence when we get to a setting where maybe the teens are meeting more independently with their providers.
And one more comment from Taylor's talk that I love it. You're never stuck with one doctor. So I fully agree with your statement that you went there, you gave your best, you gave that chance for that relationship to develop, but understanding that certain relationships, they just don't work. And if that's the case, it's the time to switch and find a different doctor. I'm not advocating for moving. If you're moving every day, then the problem is you, but just you have to find someone. It's a relationship, so it has to be mutual. It has to be something that you feel the trust in that person that is taking care of you. So I love that comment.
We see a good chat from Dan that asks about, we always talk about the transition to adulthood, but what about other transitions? One of the reasons that we focus so much on this transition to adulthood is that, these are times when adolescents are particularly vulnerable to non-adherence, falling off from their connection with their healthcare team, having difficulty following through on some of their medical care needs, losing access to different resources. And so obviously the other physicians can talk a little bit more about the importance of this arena, but that's one of the reasons as psychologists is we know with their adolescent brain that there's some things that can happen that are difficult during this time. So we really want to put on supports around them at this time, but also in the context of our support groups, we talk about these different transitional stages, like going to a new school district or, starting school when you might need a health plan or an IEP, thinking about common social or peer stressors that we might encounter at different stages. And so, these are all important aspects of child development. And we try to focus on those pieces in a supportive and preventative model where we know we need to target with our adolescents to help them to be successful. We know we need to really prioritize and focus on this transitional stage to buffer up those supports so that their health outcomes continue to be just as great as they were when their parents were the ones that were managing things.
So thank you all for this amazing panel. Taylor, Dr. Judd Glossy, and Dr. Buchanan. If you have any other comments, please feel free to do it. Unfortunately, our next presenter, that is Dr. Pam Wilson. She is our coordinator for the spinal defect and spinal cord injury clinic. Somehow we're having trouble, and we'll try to give her talk at a later time. So we'll now invite Dr. Wood, that is just going to explain us a little bit more, generally speaking, what is transition of care. But Taylor, Dr. Judd Glossy, and Cindy Buchanan, if you have any comments, please do it.
So I hope you can now see my slides. And I hope they're on presentation view. Is that okay for everybody?
Like we are having duplicated slides, so we're not seeing just one screen, we're seeing.
Okay, let me just see if I can. That should do it.
There we go. Perfect.
Okay, all right. Good morning, everybody, and thank you so much for the extraordinary talks that we've had so far. I've been working in transitional urology, I suppose, for the last 15 years or so, both as a trainee and then a consultant or attending. And I feel like I've learned a huge amount already this morning with some really interesting and important, powerful perspectives. What I'm going to just try and do over the next 20, 30 minutes or so is talk about some principles around transition and some of the ethoses that I think are important. I feel rather humbled giving this talk because I think this is just a surgeon's perspective, and you know, we're just one cog in a huge number of cogs that are turning for patients that are going through all of this. So I think that Keith Fox made a really important point in the chat earlier, and Keith and I have spoken about this at length over the last few months or so. But it's really important that our terminology is on point with transition. So transition is often colloquially referred to as the move between healthcare providers. Transition is really about making sure that a young adult starts to develop their own independence. And in this setting, we're talking about the healthcare environment. But as Cindy quite rightly said a few moments ago, and Taylor was illustrating beautifully for us, there's a whole lot of other stuff that goes on around that. We tend to be healthcare and, in our situation, surgically focused. But this is really about teaching a young person to become independent in their healthcare environment and learning how to navigate that for themselves. I think that's fundamental. From the point of view of providers and what we need to do to get better, I think there are some important things to recognize. That it's truly important that providers understand that this is multidisciplinary work. No one can do this alone. And I think every speaker so far has illustrated that. But working alongside people, and I loved Taylor's point about the fact that if you don't get on well with one particular provider for any particular reason, then it's important that you have the choice to move beyond that if that's possible. But also I think it's important that providers themselves recognize that there are limits to what we know and can do as individuals, and that not being afraid to say, actually, I don't know the answer to that particular problem, recognizing that and engaging other people in a multidisciplinary team is just as powerful to a patient as having this immense knowledge, recognizing that both parties in this are human and that there are limitations to what anyone can do is really important. And so within an institution that creates a multidisciplinary team, we've already illustrated the importance of educating and bringing on adult providers to be able to provide the long-term care in an adult setting. But I think some of the cases that we encounter are really complex, and being able to pick up the phone, having a network of providers, and being able to ask questions of each other so that we can establish that need and that humility amongst ourselves and support each other when things are difficult is really important. I think that with time and with the growing interest in this work, that'll allow us to provide guidelines and standards of care and progressively to educate others in this field. I think those elements are really, really important. There is no right answer for how transition needs to be done. There are various models that we've talked about in a consultation that I was part of writing a couple of years ago. And it's perfectly reasonable, if everybody is competent and the network is there, that a pediatric surgeon, or in our case, a pediatric urologist, is involved in the long-term care of a patient. Of course, the lifespan of a patient is likely to outlive any one practitioner's career. So at some point, there'll be a move between providers, but that doesn't mean that that can't be provided in a single institution if the providers and the institution are geared up to do that. And I think those are important just sidelines or side thoughts to think about. It's possible that a pediatric urologist will follow their patient into an adult department, and that might be, again, a better setting for long-term care. Again, it depends on an institution, and it depends on the providers and the patient as to how that will work. My own model has been to be the provider who communicates directly with pediatric providers and then takes patients on in their adolescent, and then has a footprint in an adult setting too, so that we can move patients over to that. I think where we have a situation where patients end up feeling cast adrift from pediatric providers for all sorts of reasons, and some of them have been illustrated already this morning, that's a model that's most fraught with risk and danger, where they're cast off into an adult world and need to seek and find their own adult providers. I think that's difficult. So last week, actually, I was in conversation with some of our colleagues here, working very actively on the development of transition programs across our campus. And I came up with this idea of 3 Ps of transition. And I think it's just an easy way for us to understand some of the principles around what transition means and what, as a group of providers, we need to think about. So I think it's been really well illustrated that preparation needs to begin as early as possible in life. Because if it's done well and comprehensively, then the move between providers is far less traumatic, because a patient is well prepared, they're independent in their healthcare environment, and they know how to navigate that system for themselves. Providing a clear plan of care, I think, is also really important, because it overcomes some of the difficulties that we were talking about earlier with making sure that people understand their history, and providers in the future will understand that history. So whilst there may be details that need to be filled in, having a clear plan so that people know or have good expectations is really important. And I think trying to establish providers of the future for any one patient is really important, because again, that creates a security net. It allows people to see where they're going, and it establishes that communication and that trust across a network. I think we've all seen examples of where this can be difficult. And I think some of the difficulties in a pediatric environment, I've tried to illustrate in this slide. It's simply not possible in all realms for pediatric providers to provide everything in the future. And so it's about creating realistic expectations, bringing on board other people when expertise is necessary. Some of the harm that's done when pediatric providers suggest that only they can do it means that there is enormous trust in them, but anything beyond that seems like a dark unknown. And so it's important for everybody in this whole care pathway to recognize that this is a lifelong pathway, and to establish that and allow that. I think pediatric settings are not always the best place to talk about some of the adult themes that we need to recognize and talk about. And so again, allowing an environment that will happen to facilitate that is important. I've had patients turn up on my doorstep where they've been told by perhaps inexperienced pediatric providers that we'll fix whatever problem it is when they arrive with us. Making sure that there's contact and the problems can be solved and patients know who to call is important. And then adult providers who are confronted with some of these complexities, really not knowing what the background is, what the previous treatment has been, and then thinking about how they're going to do that, and making sure that there is an appropriate clinic space, an appropriate operating room, and so on, is really important. So I think that one of the challenges of providing this care in a pediatric setting is addressed in this slide. And it is absolutely right that we own this work and we look after patients appropriately. But if you've trained to be a pediatric nurse and you're looking after a 42-year-old patient 1 minute and a 3-year-old the next, is that the best way of delivering care? And it might be in certain specific circumstances. But I think that it's important to challenge current paradigms and think about whether we could look at things differently, because the ethos behind that is absolutely right, the ongoing care. But the current solution might be something that we could adapt. There are all sorts of elements in terms of how we can think about transition, how we can think about improving transition and so on, that might be important. One of the things that was illustrated is portable information, making sure people have their healthcare records accessible. Maybe a healthcare passport is a solution to that. There have been attempts to do that, but I don't know of anything that's been widely adopted. And overriding all of this is really thinking about how that affects our patients and their experience, because it's easy for us to get subsumed in what we know and our specialist knowledge and our ability to provide the specialist care that we are capable of giving. But thinking about a patient experience and really thinking about how we would walk in their shoes, how it would feel to us if we were in their situation, becomes a really important part of how we reflect on improving this service and delivering care in the long term. Because I think it's really humbling to listen to some of the things we've heard this morning, and it illustrates how important it is to recognize that everybody in this pathway may have very different ideas about the right way to deliver that. And some of those may be achievable, some of those may be really challenging to deliver, but having that as part of our reflection and our development, I think, is phenomenally important. In urology, there is now a growing literature. I think surgical specialties, for all the reasons that have been illustrated, and when Dr. Bischoff was talking a moment ago, and just saying that adult providers are less well informed in surgical specialties, it's really important that we start to provide a growing literature. And what I'm going to talk about over the next few slides really illustrates some of the importance of that. I think historically we were very phasic in our long-term urology care of congenital conditions. So there was pediatric urology, then there was the development of adolescent urology, and then people were passed on to adult urology. And I think that we've become much better at recognizing that this is a lifelong pathway, and facilitating that then becomes part of our long-term goal, and making sure that that's well done is really the objective overall. So preparation is key, and there are all sorts of models out there for doing that. And I completely agree with Cindy's suggestion that actually we should be beginning these conversations almost as the baby is born, and starting to think about how we integrate that into care throughout a patient's life becomes phenomenally important in terms of the development. In a urology clinic, these are some of the things that we see, and some of the conditions that we treat on a day-to-day basis. And that's just our snapshot of it. When we start to think about which aspects of these conditions are lifelong, these are again some examples, and the need to recognize that I can't do this alone, that I need the support of my psychologist, of my gynecologist, of my nephrologist, my colorectal surgeon, and so on, to deliver good care for these patients is truly important. So if we're going to spend the next 2 days talking about this type of work, then we need to think about why overall it's important. We've talked about some aspects of that, but when we're talking with insurance companies or our institutions and so on, then we need to be able to present them with data that allows them to hang their hat on it and say, okay, I recognize this is just important. This is just as important as any other aspect of healthcare. And what we see in other specialties outside of surgery is that there are very definitely improved healthcare outcomes by doing this well. So we can start to recognize that by delivering, in this case, good long-term care and well-delivered transition for diabetic patients, there were improved healthcare outcomes. And medical specialties, I think, are probably slightly ahead of the curve in terms of doing this. Surgical specialties, there are some additional challenges, and so it's been more difficult to deliver good transition care in a surgical space. But we don't want to be just about managing problems and complications. We do manage those, and we heard from Dr. Rink earlier some of the importance of being able to do that, and understanding and anticipating some of those complications and problems is really important in the type of work that we do. But we also need to look more globally at how we can help our pediatric providers with data that will support their practice and develop them in terms of how they deliver care in the long term. So if we look at, for instance, hypospadias, this slide shows us that the data that are out there for hypospadias historically have been really poor. You can see that if your graph ends below this bar here, your data is judged as low quality. And we're only looking at moderate quality at all on this graph here. So it's really important that we start to recognize that, start to think about how we can develop good data, and then inform both patients, parents, and providers as to how things might improve, or what the realistic data are. These conditions are complex, and it's not that people aren't doing their jobs well. It's about recognizing that these are realistic outcomes, and these can be explained to parents and other providers for the long term. So if we look at a summary of published outcomes relating to hypospadias, you can see here some examples relating to urinary tract function, cosmesis, psychosexual function, that are really important to patients as they grow up. And helping them and supporting them and giving them realistic expectations around this is just as important for them as it is for informing other providers. We've learned over time that short-term follow-up in these conditions is useful in terms of providing information about technical success of a procedure, but to a patient and to an adult patient, learning about what the long-term implications are become really, really important. So length of follow-up is key. And if you've done an operation in childhood, recognizing that things may change dramatically over puberty is important. If we think about posterior urethral valves, those that deal with patients with posterior urethral valves or look after them understand this is a pan-urological condition. It's not just a urethral condition or a bladder condition. It's a condition that infects the entire urinary tract. So we have started to develop, or we understand, this is from Christopher Woodhouse and Guy Neal's work, that there are some predictors in childhood of patients that are likely to need longer term care. And we can start to indicate those very early on and prepare patients for that. We can also start in our own network, start to think about how we might anticipate problems. So looking at these data that you see here and understanding that these predictors are important becomes really powerful in terms of how we can then shape our care for the future of a patient. And understanding that working alongside each other in a clinic is also really important, because we can engage in a to and fro discussion about what urological evaluations we might need, what urological education we might need, and then what nephrological components to care are important. That augments the care that we can give to a patient. And I think it really helps to improve their engagement. This is something we did for my entire consultant career in London. And it's something that we're looking to develop across in the adult realm here. There are some fantastic multidisciplinary clinics here at the Children's Hospital, but looking to develop that in an adult sphere can be challenging. It's important to get buy-in with people so that that can start to happen. And then when we start to measure outcomes, what I've talked about so far are really very medical outcomes. And it becomes a real challenge to us to start to think about how should we measure an outcome. If we talk about bladder exstrophy, well, we know that in bladder exstrophy, there's a pelvic anomaly with the bony part of the pelvis. We know that the urinary bladder is affected. So there are urinary outcomes we can think about. And we know that external genitalia are affected too. So there's implications in terms of sexual outcomes too. So there's a hugely diverse range of just medical outcomes that we could start to think about and measure. But when we really start to distill it down, those things matter and those things are important. But when we're dealing with the person sat in front of us, our patient, and thinking about what matters to them, how they get through the fundamentals of life, how they get through being in middle school, as we mentioned earlier, and dealing with locker room behavior, how they get changed in front of their peers, how do they deal with going to the bathroom if they need to catheterize, and managing how they might want to discuss this with their peers, their friends, and then extrapolating that into how that looks when they're starting to develop intimate relationships becomes really, really important. So what we measure, how we measure, and who measures it becomes really, really important, and actually very exciting in terms of the development of this specialty. So it's really, really important that I think we set sensible expectations as a group of specialists in this sphere. It's not realistic for every centre to become an expert centre in all of these conditions, because they are complex. And to deliver a multidisciplinary team in every centre that was expert in this would be a huge ask and would serve very small numbers of patients. There is some value in centralisation and developing that expertise, particularly with conditions that are relatively rare. But that doesn't mean that people can't be looked after well nearer their home. And I think what we need to be working towards is having specialist centres that develop that expertise, but also that support providers either in other specialties who might come across our patients in the same institution and allowing care with them, but also working very hard to establish relationships with providers closer to patients in terms of locality, and supporting those providers in delivering care where possible near a home for a patient. That doesn't mean we can't bring those patients in when complex elements of care are needed, and those need to be delivered in a hub centre or a centralised centre. But thinking creatively about how we can deliver those models, I think, is key to the development of any specialty who look after cores of transition patients or transitioning patients. So I think there are huge opportunities in this space and lots of work for us to do. I think that it's really important that we look at upholding our part of the bargain, if you like. I think there's a contract of care that develops when a young patient, an infant, has major reconstructive or surgical work in their infancy. I think that's a contract of care between the healthcare system and that patient, and that delivering excellent pediatric care is just one part of that contract, but making sure that patients have access to good care for their entire life is the more challenging and I think at the moment exciting part of this care to develop. I think supporting providers out with our own institutions so that patients can get care nearer to home where that's possible is really important. I think that improving data so that we can talk realistically about what outcomes we can expect and look to see whether there are areas in those outcomes that might be improved. I think trying to understand within ourselves what quality looks like is really important. And so trying to produce some form of metric that makes us understand what good transition and development of a young adult in healthcare looks like, and making sure that that's comprehensive, that it is about preparation, it is about providing a plan, and it is about making sure that they have good, well-qualified providers for the future. I think that one of the things that we're doing today is an educational program and trying to enhance interest in adult practitioners by educating them is phenomenally important. And the formulation of guidelines or optimal care pathways are good for us all because they allow a degree of standardization. It allows us to look back and understand what we were doing before and think about how we might provide better care going forward. So that supports providers, and it also allows us to educate those people that are paying the bills, insurers and so on, in terms of what good care might look like. So I'm going to finish my talk now. Thank you very much for listening. You can see from this slide that I've never shied away from a challenge, and that's part of why this element of care is so exciting, because I think we're seeing some real development, and I'm very excited to be part of this day. Thank you very much for listening.
Thank you so much, Dr. Wood. And I have good news that Dr. Pam Wilson was
Oh.
able to join, so we're gonna let her in. She leads the most impressive multidisciplinary clinic that we are lucky to participate for spinal cord injury or spina bifida. So I see Sarah there. So I hope she can share the slides and Dr. Wilson will be able to join. We cannot hear you. So I suspect we don't have microphone or something.
Did you check your volume button?
I think they are in clinic and some of those computers don't have it. So what we can do is we can have a 10 minutes break and then it's now 9:19. So we can be back at 9:30. And in this meantime, we'll make sure we connect Dr. Wilson. So let's take a 10 minutes break and I'll let Dr. Wilson work with Ray to try to connect. Thank you all. Let's take a 10 minutes break.
Now you can hear me, correct?
Oh, can you hear me now, Ray?
Yes, we can. Perfect.
Okay, sorry.
That's okay.
I'm so sorry, Ray. Dr. Wilson asked me to do this very last minute, and so I'm just not as prepared as I wish I would have been. I
That's okay.
apologize.
No, at least you're in now and we can hear you. And do you want to check your share screen while you're here? While we have you here
Yeah, let's.
during the break? Perfect.
Okay.
There you go.
Okay.
So we're all ready. Thank you
Okay.
very much for working that out. I appreciate it.
You're welcome.
So Pam and Sarah, we might just give people a couple more minutes to do what they need to do in a break, and then we'll launch straight into your talk. Is that okay?
I think that's perfect. Yep.
Okay. Okay, I hope everyone's had time to do all that they need to do in a short break. Well done. I've got the most important thing, and that's coffee. I'm delighted to welcome Pam, Sarah, and Tess, who run the most incredible multidisciplinary clinic for our spina bifida patients. And I'm really looking forward to their talk about the importance of that clinic in the ongoing and transition care of these patients. Thank you very much to you all.
Thank you, Dr. Wood. So Dr. Wilson got pulled away last minute to clinic. So this is Sarah. I'm the care coordinator of the clinic, and I'll be presenting. So it's very last minute, so be gentle with me. So we're presenting on the importance of multidisciplinary clinic and transition of care in spina bifida. So just a couple fun tidbits about our population. In 1652, Professor Nicholas Tulp of Amsterdam was studying this grouping of symptoms, and he gave us the term spina bifida. In 1761, Giovanni Battista Morcagni, in Italian, linked lower limb deformity and hydrocephalus. The shunt was developed in 1955 for Cassie, the child in the picture. 1970s, there was a discussion in 1970s actually whether to treat or not to treat this population. And a mom study found that fetal surgery greatly improved the outcomes in these children. The history of clinical care. In the 1940s and 1950s, when the prevalence of polio decreased, some of the multidisciplinary care model clinics funded by March of Dimes were converted to care for children affected by spina bifida using the same model. Neurosurgeons, orthopedists, neurologists, and physical therapists were part of these clinics. During the 1970s and 80s, multidisciplinary clinics that provided outpatient care for children with spina bifida had been established in almost every state in the U.S. We've been around for a while. Colorado developed its first clinic in the late 1970s at Colorado General and included pediatricians, orthopedics, neurosurgery, and urology. What is a multidisciplinary clinic? A multidisciplinary team is a group of healthcare professionals who specialize in different fields and work together to provide individualized attention from each team member. This unit collaborates on a detailed care plan to organize their services and optimize treatments. Medical care for people who are born with spina bifida is complex and challenging, but the goal of such care is to optimize health and function for people with this condition. Why use this approach? Multidisciplinary teams tackle many of these problems, making an increasingly complex and fragmented healthcare system more user-friendly for the patient. Using a one-stop shopping approach, patients can receive input from a multi-specialty group. Spina Bifida Association definition of a multidisciplinary clinic. The Spina Bifida Association supports and recommends that clinical care for people with spina bifida be provided in specialty clinics, of which the multidisciplinary care model is an example, that care be coordinated and that there be a plan for transitional care. The advantages of a multidisciplinary team for the patient and family. It gives the families a chance to see multiple providers in one visit. It reduces care duplication. It's more time efficient. It improves satisfaction with care provided. It improves outcomes and utilizations of clinical care guidelines and may be more cost effective. In summary, when teams are coordinated and communicating with patients, the patients spend less time waiting for providers, discussing their needs and going over the treatment plan. Tasks are delegated across the multidisciplinary healthcare team so that patients can spend as little time as possible in the facility and more time on things that are important for improving their care. Advantages of a multidisciplinary team for the team members. It may improve job satisfaction. It gives us a sense of community and common goals. It may decrease burnout. It can improve productivity. It gives us the ability to focus on an area of expertise. It gives us an opportunity to discuss patients and coordinate care. It gives us an opportunity to learn from experts in other areas. And it gives us the ability to use a clinic nurse for care coordination. Attributes that we think make a good working spina bifida team. We agree on a unifying philosophy centered on care of the spina bifida patient and family. We've developed a commitment to the common goal of collaboration. We learn about spina bifida from all the experts in the clinic to expand our knowledge base. We respect each other's skills and knowledge. We establish positive attitudes about the clinic and care provided. We develop trust among our members. We know the roles of each team member so you can focus on your specialty area. We establish a method for resolving conflicts among team members. We're flexible we are given the ability to be flexible and open to new ideas. And we use existing data to improve patient care, such as the Spina Bifida Association guidelines. Our team at Children's is made up of, the center is the patient and the family, and our team is made up is orthopedics, urology, a nurse care coordinator, the colorectal team, nutrition, social work, DME and braces, a vendor, physical therapist, neurosurgery, and rehab, and a nutritionist. Colorectal team we added about 2 years ago, and it's been a fantastic addition to the existing multidisciplinary clinic. Our family satisfaction and feedback was obtained, and all our families have felt having this specialty improved care in the clinic. Clinical team satisfaction is 100% with this new addition, someone to really focus on bowel care. So transition programs for spina bifida. Adolescence is a period of change physically, socially, and psychologically. Transitional care is the purposeful, planned graduation of adolescents in chronic conditions from child-centered to adult-oriented healthcare systems. It can be a period of angst for our spina bifida population. Unplanned transitions may result in a lapse in healthcare and deterioration of health status. Transition care. The biggest obstacle is finding adult providers with expertise and interest. Communication between the pediatric and adult providers provides for an optimal system. A survey showed providing educational material was a major strength, and assessing self-management skills. Only in 50% of the clinics surveyed made sure this was in place at time of transition. Models of care. There are 2 programs in the U.S. that provide a lifelong care model for individuals with spina bifida. Another model is to transfer care to an affiliated institution. We tried this multiple times in our clinic and it was not successful. We tried it with university and it just did not work. The no-show rates were high and there really wasn't buy-in from the providers either. We have established a community-based adult medical home, and this is our current model where the PCP is a huge part of their care when they transition. We make sure that they have a good adult primary care physician, and a lot of our children are actually going to the adult special care clinic as well when they are complex medically. University of Alabama, Birmingham is one of the models, or one of the 2 places that has the lifelong care model. As you can see, it go from prenatal all the way until adult care in one facility. Their adult spina bifida clinic is just made up of a couple providers, but it's nice for the families that they're able to stay there for their whole lifelong period. Transitional care. Some pediatric spina bifida clinics continue to provide care for their patients into adulthood. Most have age limits and patient must seek adult care elsewhere. A shift in care provision from a specialty focus to an adult care focus, and the primary goal of transition as outlined in the guidelines for the care of people with spina bifida is to maximize lifelong functioning through the provision of quality, developmentally appropriate health care that is uninterrupted from adolescence to adulthood. Transition. Today, there are 104 multidisciplinary spina bifida clinics in the U.S. It is the goal of the Spina Bifida Association to reduce the variability in care provided and resulting outcomes in spina bifida clinics, and to promote the inclusion of care processes recommended to improve outcomes for this costly, chronic, complex condition. They are very interested in care across the age spectrum. Care coordination links children and their family to services and resources that may be needed to optimize outcomes that have been expressed in a patient-centered care plan and that may address the social, emotional, and financial needs of the patient and family. Thoughts on transition. Transition is a process, not a single event, not kicking them out the door unprepared. The transition process should start as early as possible. Transition is individual-centered care and includes the family. Transition should compromise developmentally appropriate care. One shoe does not fit all. Transition planning is flexible and future-oriented, and transition is a natural part of growing up. Our program. So we are still developing our transition program. Our model is for the adult patient is a community-based program that I mentioned. Once in our clinic, once out of high school, 18, they graduate out of clinic unless they go on to do a transition program through their school, then we keep them to the age of 21. Our transition program right now, what we have established is that they have an adult PCP. We use urology. Dr. Wood is our transition urologist, which is fabulous. So we try and get them picked up with the adult urologist around 14, 15 years old to plan for that transition at 18. So they establish a relationship with him. The colorectal team, neurosurgery, ortho, and rehab continue to see them into adulthood as needed. The medically fragile patient, like I had mentioned, we have transitioned some to the adult special care clinic for their medical home. The Spina Bifida Association thoughts. Their mission is to enhance the lives of people with spina bifida. They feel like it's best supported through its collaborative work with spina bifida clinics to identify models of effective care coordination, participate in the development of consensus standards for care coordination services, and provide education to the professionals involved in these essential components of care. The comprehensive services offered in spina bifida clinics and the expertise of the providers, children with spina bifida often obtain all or most care from the spina bifida multidisciplinary care model and consider the spina bifida clinic to be the source of all their medical care. And in closing, the end of one journey is the beginning of another.
Thank you so much, Sarah. Sarah is the coordinator. She is the soul of the clinic. She keeps traffic, so she's the one that tells us where to go. And I have to say, every time I'm in that clinic, I am impressed. She prepares a summary for all the patients. So right before we start seeing patients, the entire team review all the patients, and then they all arrive at the same time. So it's a one aisle filled with rooms, and then the specialties rotate for each room. So she keeps the traffic, and we all know how the patient is doing in the other specialties. So this is very important because then Dr. Wilcox, that is the urology, and myself, we can determine when it's the right time, for example, to do the Malone or the Mitrofanov, or if it's an adolescent patient, then Dr. Wood and myself will be coordinating that. So it's a fantastic clinic, and I think it's a great example of how multidisciplinary can really improve patients. Thank you so much, Sarah. If there are any questions, please feel free to chat, and I'll let Dr. Wood introduce our next presenter. Thank you.
Thank you so much. Yeah, thank you so much, Sarah. I really enjoyed kind of listening to how that works. And I love being part of that clinic too. So our agenda is slightly out of sync just because Zoom has thrown up some unexpected problems for us this morning, which everybody has done very well in accommodating. So well done to everybody who's made it. We're going to move on and ask Dr. Oliver to give her talk now. And my talk will slot in sometime later in the program. That's fine. So Janine is one of my new colleagues over at the university. here in Colorado. And it's a real privilege to work amongst a group of new colleagues and learn from them about how they're working and develop my own practice alongside that. Janine's going to give us a talk on our care for pelvic pain in adult patients who were born with congenital anomalies. Janine, I'm very grateful for your time. Thank you very much.
Oh, no, thank you so much, Dr. Wood and Dr. Bischoff, for the invitation to talk. Let me know if anybody can't see or hear me. I'm Janine Oliver. Yeah, I'm a urologist. I practice mainly on I do practice on the adult side over at Anschutz as well as at Cherry Creek. And thank you so much for the opportunity to speak. This is certainly a topic without a lot of research. But hopefully I can share my experience and tips, at least as a reconstructive urologist. Technically female pelvic medicine and reconstructive surgery is my specialty here. Some tips on how I manage pelvic pain, both generally and specific to this patient population. All right, I have no disclosures. I hope this talk will help with you learn the definition of acute and chronic pelvic pain and identify potential causes of acute and chronic pelvic pain that may affect in particular the adult patient with a congenital pelvic anomaly. So what is pelvic pain? The definition is subjective, of course, as is other pain. It's pain perceived in structures related to the pelvis. This can occur in any gendered patient. It's chronic, or defined as chronic pelvic pain when it's been present for at least 6 months, either constant or intermittent in nature. So acute pelvic pain would be pain less than that duration. We reserve the term chronic pelvic pain syndrome for when there's no proven infection or other local pathologic condition that may account for the pain. So this is a diagnosis of exclusion. For example, the urologic chronic pelvic pain syndromes in men and women, those are a diagnosis of exclusion, such as chronic bladder pain in women are often referred to as interstitial cystitis. As you're likely familiar with, many of these patients present with associated symptoms suggestive of dysfunction in many other organ systems, lower urinary tract, sexual dysfunction, bowel, pelvic floor, or gynecologic dysfunction. And again, I'm preaching to the choir, I'm sure, but these patients often have significant negative cognitive, behavioral, sexual, and emotional consequences. The data on this patient population, when surveyed, many of these patients report impact in their health-related quality of life and psychosocial questionnaires. The impact is similar to significant chronic medical conditions such as Crohn's disease. It's often on par when these patients are surveyed. And there's unfortunately high rates of psychiatric troubles, suicide, etc. Many of these patients, unfortunately, the data would suggest that up to 50% or so never receive a proper diagnosis or treatment. So first, I wanted to touch on acute pelvic pain. Of course, this talk is not intended to be a comprehensive discussion of all the possible causes of pelvic pain, acute or chronic. That would be outside the scope. Here's some common causes I'm sure you're familiar with. So I thought I would focus on what acute causes in the patient population we're discussing here can you not miss. As you may know, this is a patient population that is particularly prone to stones. At least the population I see a lot of, those with prior lower urinary tract reconstruction or other congenital anomalies or neurologic lower urinary tract dysfunction, pyelonephritis and urosepsis, so infectious causes. Cancer, pregnancy, of course, can affect this population as well, and we don't want to miss that. It may present in a different manner. And then, of course, anatomic obstruction, typical causes of your acute abdomen, classically, such as a bowel obstruction or perforated urinary diversion. This patient population, of course, get increased risk. Urinary tract obstruction and obstructed reproductive organs. Here's an example of one of our typical patients who might show up after a prodrome of symptoms that may not be acute until it becomes an emergency, with an obstructing proximal ureteral stone and a stone in a urinary pouch. Of course, stones can affect any part of the urinary tract, and they're potentially a life-threatening emergency and certainly a source of significant risk of morbidity and mortality. Again, this is a patient population at high risk for infection, and that in combination with an obstruction can be a life-threatening emergency and require emergent urologist intervention or some form of intervention. It's also a patient population who may have solitary kidney or transplant kidney, and an obstructing stone in that population would, of course, be an emergency. Again, this population is high risk of stones and infection. They often are catheterizing or due to their reconstruction of urinary stasis, and they're particularly prone to these issues. So I suppose the point is to communicate, as of course, I'm sure you're more familiar with, but have a low threshold to work up for kidney stones. Malignancy, of course, can affect this patient population and their urinary diversions using bowel for the reconstruction, as has been discussed earlier. Currently, the Urologic Association guidelines do not recommend screening surveillance cystoscopy, somewhat of a controversial topic on the rates of malignancy, particularly as the length of time the patient has had the diversion increases. But certainly cystoscopy is always indicated for symptoms, and that may be just pain. Pain can be an indicator of cancer, stone, a harbinger of some serious issues. So cystoscopy, low threshold for symptoms. I threw this one in here, pelvic organ prolapse, because this is my bread and butter of my days here in FTMRS. But it's certainly worth mentioning because this is a high-risk group for pelvic organ prolapse. Females with history of exstrophy epispadias have, so it's not super well studied, but very high rates of prolapse. It tends to present on the severe end of the spectrum, and the data supports it. Usually most, approximately 80%, end up needing surgery to manage it. Spina bifida would be another population at risk. While you might not think of prolapse as a cause of acute pelvic pain, I'll show you in the next slide a patient who presented that way, and we certainly see that, but they could also present in the more typical chronic presentation. Maybe not pain, but discomfort, heaviness, many different symptoms. So here's a patient that presented to our ER at Anschutz earlier this spring. She's 43, G2, P2, 2 prior C-sections with history of spine bifida, has a VP shunt. Presents actually complaining of pelvic pain, right lower quadrant pelvic pain, and tells the ER, I think I have a VP shunt infection. Feels like my other VP shunt infection. So neurosurgery is initially consulted, and then on a CT scan shown on the left, they note she has severe pelvic organ prolapse, vaginal prolapse, as well as rectal prolapse. An exam, pelvic exam, confirms this. And on further questioning, she reports difficulty catheterizing, likely due to the severity of the prolapse and the kinking of her urethra and anatomy. And she has significant new bilateral hydronephrosis. So here's an example of a patient presenting with prolapse with acute pain, and a classic example of very severe prolapse, unfortunately, when it happens in this patient population. Okay, changing gears a little bit to talk about chronic pelvic pain. Of course, it can derive from many different organ systems, and it may and often does manifest in the setting of significant psychological and social confounders. This leads to it being a diagnostic and therapeutic challenge for physicians and providers. Often, once one organ system is involved and sensitized due to the nature of peripheral and central sensitization in the cycle of chronic pain, it triggers or leads to effects in related structures and organs, and that compounds this diagnostic and therapeutic challenge. Add in a congenital anomaly and a problem that already has limited access to skilled specialists. This is a real issue for access in our adult population, finding the right provider to help them. Again, this isn't a talk comprehensively on all the differential diagnosis of chronic pelvic pain, but as far as a few tips on how to approach it, some like to think of it by organ system and then think of potential explanations. Of course, many of these affect our congenitalism population, whether it's obstructive reproductive organs, pelvic floor muscle dysfunction, bowel dysfunction, constipation, secondary tethered cord. I'll show an example of that. We've seen that present as, in addition to the typical neurologic or voiding issues, bowel issues with a tethered cord can present as pain, chronic developing perineal and pelvic pain. And of course, the role of central sensitization and psychological associated comorbidities can make this a difficult to treat population. Here's an example of tethered cord, just mentioning. Another way to approach it is to go first identify the location of the pain and then develop your differential diagnosis from there. And again, you'll see many of these conditions, dysfunctional voiding or pelvic floor muscle dysfunction. For example, in my clinic, along with constipation and bowel dysfunction, are probably one of the most common things I see. Regardless, it is often best to address chronic pelvic pain as a multidisciplinary team. We're fortunate at Entrance, we don't have a formal in-person multi-D chronic pelvic pain patient, but we've developed a team, multi-D clinic, but we've developed a team of physicians, providers in most of the specialties here who have an interest in serving this patient population. And we meet regularly to discuss these challenging cases. For successful treatment and management regimen, it's often requires multiple folks on these specialties here. And if anybody's on, thank you so much for your help. If we've shared some patients, I'm extremely grateful for the work you do. So in the time I have left, I thought I would talk a bit more about pelvic floor muscle dysfunction and myofascial pelvic pain in the adult population. This is probably one of the most common things I see, both generally, but particularly in this patient population. As they're with the neurologic or musculoskeletal deficits that they often have, they're at particular risk for pelvic pain from this cause. The pain arises from resulting muscle spasm, overactivity, or increased muscle tension, or the imbalance and the muscle use or underuse that they are more predisposed to. The dysfunction then develops as a reaction to the pain or the stress of the imbalances. Again, are a lot of these conditions, it tends, even though it may start with a local trauma or a focal inciting event, it then quickly spreads to symptoms in other pelvic structures like the bladder, the GI tract, the hip, and the back. And this is really important to kind of help educate patients on why their back pain or their hip pain might be related to their voiding dysfunction and their dyspareunia and all of it, all related oftentimes. So again, they may report a variety of symptoms in related organ systems, pelvic pressure, dyspareunia, voiding symptoms, bowel movements, for example. It's a diagnosis that's based on physical exam. And of course, as with many of these pain diagnoses that we're discussing today, we need to exclude other causes, exclude anatomic, other anatomic abnormalities. There are wonderful videos, by the way, if anybody's interested in this particular topic or resources, happy to help. Didn't mean to do that. What is our therapy for myofascial pelvic pain? Pelvic floor physical therapy is the mainstay of treatment. We do have other therapies for them, the patients though, including trigger point injections, relaxation techniques are often very helpful, or even CBT type therapy, medical management, sometimes systemic, but often just local vaginal, pelvic, or rectal medications. But often it requires multimodal therapy. I could not do what I do without our wonderful pelvic floor physical therapists who are helpful for all genders who can develop this condition. They're really integral to this condition in particular. I always educate the patient that this often involves internal, either vaginal or rectal therapy, but it can be greatly beneficial even without this. As we discussed, it often involves related muscle systems. So they can do indirect stimulation from external abdominal, hip, lower back, core musculature, and it can still be greatly beneficial if you have a patient, whether it's from prior sexual trauma or otherwise, or surgical reasons that they can't have internal therapy or don't desire internal therapy. I still educate them how this may be beneficial. This can include biofeedback, and the research would show that earlier we address these issues, the better, the more we can break that cycle of central and peripheral sensitization. Particularly when folks are younger, take advantage of neuroplasticity, likely the better outcome. All this is an area of ongoing research. We do have options for when pain is refractory or plateaus with physical therapy, such as trigger point injections. This is common in our practice. This is thought to act by disrupting the reflex arcs within the muscles, release of endorphins, and leading to mechanical changes in these abnormally contracted pelvic floor muscle fibers or other muscle fibers. It's a simple procedure that can be done in the office or in the operating room for those patients who need a little sedation, and can have great short-term relief or augment being able to work with a pelvic floor physical therapist, for example. It also, so in addition to being therapeutic, can help diagnose the source of pain, help differentiate a pain source. There are other specialists, of course, like interventional pain management. If you're more suspicious of a particular nerve etiology, can be of assistance as well. So last, just a comment on chronification of pain, central and peripheral sensitization that I've been mentioning. Many patients with chronic pain have undergone changes in their neurophysiology. The pain can be amplified by psychosocial and psychologic factors and lead to further peripheral inflammation and sensitization, neuroplasticity, and central sensitization. And it's really important to acknowledge this. And again, try the earlier the better, hopefully can lessen this. So that was a whirlwind as best I could sum up, I think, what I feel are some important points on this topic. It can arise for virtually any organ system. The approach in the patient population we're talking about today with a congenital pelvic anomaly, of course, first, always important to rule out a life-threatening or potentially serious condition. And management of the chronic pelvic pain patient often requires a multidisciplinary team. So thank you so very much. I'd be happy to answer any questions either now or I can put up my email as well. Thank you again for the opportunity today.
Janine, thank you so much. Actually, that was a really comprehensive overview of some of the tricky issues around pain in this population. I'm really grateful for you bringing all that together. I'm going to suggest that we move straight on to Dr. Yasmin. Effie and I, this is a wonderful meeting. I'm so grateful on the chat to all the people across the world that are joining us, but this represents a true transition between new colleagues and former colleagues. So Effie and I work together in London. She does a lot of work with our population relating to fertility issues, and I gather that she's very kindly joining us from a little break in an English seaside, a seaside town. So Effie, thank you so much for your time.
Thank you very much. Real pleasure to be here. And as you said, you know, this honor is all mine for being invited. And so reliving old times, I learned so much from Dan Wood through our multidisciplinary team meetings and operating with him. Just going to share my screen and dive straight in. When preparing for this talk, of course, more than any time else, you're just faced with the issue of the lack of very good quality long-term data in this field. And most of our practice is often influenced or informed by the experience we have from the day-to-day working. So as Dan had said, I deal with the pediatric and adolescent gynae population, as well as do fertility medicine. And this is where I hope to share some insight from clinical practice, as well as the evidence, whatever evidence is out there. Now, the interface between fertility and Mullerian abnormalities is not difficult to appreciate when you are faced with issues such as a complete agenesis, either the uterus or the vagina. But Mullerian abnormalities do exist with quite wide diversity, and the changes can be sort of subtle variations, and at the other end of the spectrum you would have complete agenesis. And so depending on what type of problems we are faced with and the comorbidities that exist, we will have sort of different impacts of the condition on fertility. So in order to have a sort of successful implantation and the development of the fetus leading onto a full-term pregnancy and successful delivery, what we will need is a structurally and functionally normal uterus. Now, what do we mean by that? Because many of these variations indeed fulfill this sort of this criteria of being a structurally and functionally normal uterus. So for successful conception and normal conception, so through conceived naturally, we need the vagina with, it is not just about being of a certain length or depth, but being sort of functionally normal, such as having a normal pH that allows the sperm capacitation and allows the sperm to migrate up the tract and meet with the egg in the fallopian tube, then migration of the embryo into a very conducive endometrium and myometrium and the full uterine architecture that supports the growth of the fetus to hopefully term pregnancy. But I also wish to emphasize at this point that fertility goes beyond the sum of its parts. And in our conversation, I'm starting to move away from mentioning fertility or infertility, but discuss more about ways of family building that would be safe. A brief refresher of embryology to just help us appreciate all the differences in Mullerian abnormalities. So around 6 weeks of gestation, we know that we have the appearance of the genital ridge that will form the gonads. And this is actually very separate from the Mullerian ducts. So the development of the Mullerian ducts is very much influenced by the Wolffian or the mesonephric duct, and it happens around the same period of gestation, which is 6 weeks. At 7 weeks of gestation, the presence or the absence of the SRY gene will govern the differentiation of the pelvic organs. So in the absence of the SRY gene, what we will get is a bidirectional development of the Mullerian ducts. The proximal parts will remain unfused and form the fallopian tubes, and the distal part will fuse in the middle. There will naturally be a septum down the middle, which will then later need to be canalized and the septum completely regress. Part of the vagina we know is formed by the sinovaginal bulb and the Mullerian tubercle that forms the vaginal plate and subsequently the lower vagina. So with any interruptions in the process of the development, fusion, canalization, or resorption will lead to interruptions in the or the development of the Mullerian structures and the variations. As I said, and we are very, very familiar with this, that the Wolffian ducts are the sort of precursors to the development of the Mullerian ducts. So when you have any renal abnormality, it is always prudent to look for a uterine anomaly or variation. I would use the word variation to describe a lot of these kind of differences. And depending on the population you're looking at, you may have an association of Mullerian differences in about teens, up to 50% when you are dealing with cloacal anomalies. There have been various attempts made to get some sort of organization around all these differences. And this is now very old ESHRE, so the European sort of Society of sort of Reproductive Medicine, along with gynae endoscopy. They developed a sort of classification system, but that has now been superseded by the American classification, which is based on the older classification that had been kind of going on a very long time. So these 2021, the classification is actually extremely inclusive and really appreciates and brings to kind of into the picture the quite subtle but very important differences we get within each variety. So let's take a look at a few of them. If there was a failure of development of the Mullerian ducts, we will either get an absence of a functional uterus with complete absence of vagina, uterus, cervix, but often with some rudimentary uterus that would not be functional. Equally, we may also get just an absence of the cervix. And it is important to just get very familiar radiographically about the architecture of the cervix, because you may have partial length of the cervix still present, so it might be a complete absence or a partial absence. If one duct doesn't develop, we may get a unicornate uterus. But again, if we detect a unicornate uterus, it would be a very good idea. It would be very prudent to go and look for either a rudimentary horn, because it might be cavitated. So there might be some functional endometrium within a rudimentary horn with the risk of an ectopic pregnancy, for example. So if you have a failure of fusion, then you might get a separate canalization and differentiation leading to uterus didelphys. This might be accompanied with a single vaginal cavity or duplication with a septum that may be unobstructed or obstructed. Similarly, failure of fusion might also lead to bicornate uterus. So the key differentiation in bicornate uterus is that there is complete myometrium along both the uteruses in a didelphys, but there is a partial fusion of usually the distal part, and incomplete fusion of the proximal part. And this, again, can be easily sort of confused with a septum. So it's very, very important to detect this dimple here. If there was any failure of resorption of the midline, then we will get the different septate uteruses, again accompanied by other vaginal differences. And again, here are the other sort of more complex anomalies, just highlighting all the variations that you may encounter in practice. Imaging is often enough and will suffice to differentiate. And it is important to differentiate, not only because of what impact it might have on conception and the well-being of the pregnancy, but equally if there were issues, there were challenges, and you had to optimize either the progression to full-term pregnancy or increase the the possibility of natural conceptions, you might consider doing metroplasty in certain cases. And there it's so important to differentiate between a septate uterus, where this will be primarily made up of fibrous components, whereas a bicornate, on the other hand, will have normal myometrium. And you can appreciate that if we start dividing this, we will be at increased risk of an uterine perforation and severely compromising the integrity of the myometrium, leading to the risk of a uterine rupture. So coming to sort of the evidence and what information do we have in order to be able to inform our patients so they make informed choices for themselves. So this is a systematic review performed by some of my fertility colleagues. And essentially this systematic review comprised of 3 studies and with very small numbers. But if I may just draw your attention to these different components of either the conception rate, first trimester, second trimester, labor, and malpresentations and delivery. So what you would appreciate, by the way, arcuate uterus is just a normal uterus and is no longer considered an anomaly at all. And this is very much borne out by even this small systematic review. But with septate uterus, there are associations, not so much with conception delay, but with a higher probability of a first trimester, second trimester miscarriages, then goes on to increased risk of preterm labor and malpresentations. Again, this is perhaps because the area of implantation or successful implantation is diminished by the presence of a fibrous septum, and the shape of the uterus lends itself sort of more amenable to breech presentation. So there's increased operative deliveries, and preterm labor, again, with either bicornate uteruses or unicornate, that there might be some cervical weakness associated with the uterine anomaly. So here, this is to highlight these 3 studies. This is the septate uterus, and we can see that the systematic review did suggest a higher risk in terms of reproductive outcome in the resorption sort of defects. But in case of didelphys or unicornate uterus, you do get successful conceptions and deliveries. Again, with bicornate uterus, on the other hand, it's sort of the impact is not to the extent that septate uterus has, but again, you do see more associations with the miscarriages and preterm deliveries. And I just wanted to take home the message that most Mullerian anomalies, because the commonest anomalies you will see sort of through the urological practice, will be unicornate or bicornate uteruses, and they are very, very compatible with successful pregnancies. What could be the other reasons for conception delay in the background of Mullerian abnormalities? So I would particularly want to talk about obstructive anomalies. And if you believe in the theory of retrograde menstruation being a risk factor for the genesis of endometriosis, then it's not difficult to sort of join the dots. With a menstrual obstruction, there will be more retrograde periods with increased risk of both adenomyosis, which we do see even in rudimentary uteruses, and the risk of endometriosis. And we know that the correlation between severe endometriosis and conception delay or infertility is well recognized. But what we also observe in clinical practice is that when the obstruction is removed, then you may stall the progression of endometriosis. I wanted to talk a little bit more and about obstructed hemivagina, which often exists with ipsilateral renal agenesis and goes by the acronym OVIRA. This is because, unlike complete obstructions such as a transverse septum or imperforate hymen, where the presentation is quite dramatic and into A&E or into ER, this might actually, or often they may be detected late because the child will have revealed menstruation, but what you will see is increased pain and that is intractable to the usual sort of treatments such as analgesia or menstrual regulation and control like the pill. And you may then detect a pelvic mass as well. It is particularly difficult when this obstructing uterine septum has a microperforation, which still allows the flow of the menstrual blood, but there's always often a pooling, and typically this patient complains of intermittent bleeding or some sort of discharge occurring intermenstrually, and often not amenable to sort of usual treatments of antibiotics. So they get recurrent infections, which could even impact on sort of the urinary tract and lead to urinary tract infections. So the treatment is fairly simple. Often, well, I say simple, well, especially if it's a low obstruction and the level of the obstruction is not too far from the introitus, but could obviously be quite difficult when the obstruction is much higher up and then there isn't much to resect. But adequate resection is so important, because if we do resect and resect inadequately, then we leave them with stenosing or a microperforate sort of situation, leading to accumulation of menstrual blood and a chronic infection, which will definitely have sequelae for their future fertility in the form of causing, again, a very hostile environment for sperm, chronic endometritis leading to an impact on implantation, and of course, if infected, a ascending infection could even lead to pyosalpinx and pelvic abscesses. The same goes for transverse septums. Again, this could be complete obstruction and at various levels. And one of the more difficult ones, not featured here, is in a complete kind of distal agenesis. But I just wanted to highlight that transverse septums could also feature a microperforation, and the patient could present with difficulty in having sexual intercourse, or have a similar sort of symptom of having intermenstrual bleeding and discharge, and often kind of that could even show signs of infection. And obviously treatment is to relieve the obstruction. And I mean, some of the sort of the debates we are having with regards to the timing of surgery is very much like the debate around any vaginoplasty. When is a good time to operate on them? Because when done very early, or if they cannot do vaginal dilations, then the risk of stenosis is higher, with obviously the sequelae of kind of leading to infections. Because when they are fully contained, and if they just have good successful menstrual suppression, then they are in a sterile environment, and you don't get the risk of infection. But it's a fine balance about going in when the time is ideal, and I think it is something that we are learning and considering as we carry on with clinical practice. Just a brief mention of longitudinal septum. Generally, longitudinal septums, unless they interfere with penetrative sex, would not cause infertility. And if the sperm is deposited, say, on one side, it will allow pregnancy again to take place on either of the two horns. But if it was causing a problem with sexual intercourse, then they can easily be resected. Also, the access to cervix for cervical smears, it has to be considered within its when considering management, and also the risk of tear. So there have been a few times where I have been called to the labor ward, where a vaginal septum has been detected for the first time and has torn during the process of delivery. So when detected, they need to be addressed, and they do not quite cause infertility, but can still have an impact on the pregnancy outcome. So obviously the most important one, which is also the most challenging from the perspective of substantial impact on fertility and pregnancy outcome, are the anorectal malformations and cloacal anomalies. Again, long-term data is a bit sparse, and Dan Wood and his colleagues have done a bit of work in this, and I do highlight at least one of his studies. So this is a review, a literature review actually, of all sort of various case reports. So what you get in terms of long-term outcomes of either infertility or reproductive outcome in this group are sort of case reports. So they have been all collated together. So there have been a mix of these diagnoses, and there were 17 patients with 26 pregnancies. Now, we have to appreciate that these were already patients who had pregnancies. So what we do not know is how kind of the incidence of infertility or recurrent miscarriages in this population, because the long-term data is really, really very sparse. But it is important to acknowledge that natural conceptions are still very much possible, but it really depends what type of anomaly the individual has. And it is cloacal exstrophy that is the most challenging, where there have been very, very few case reports of successful pregnancies. Prematurity is, when pregnancies do occur, prematurity is going to be very common, and they almost always exclusively require cesarean section. And Dan, you have delivered or done cesarean sections, or assisted Pat with cesarean sections in several of these patients. What is also important to appreciate is that the pregnancy itself and post-delivery, or the sequelae of the intervention such as cesarean section, can have an impact on their renal function and the risk of UTI. So conception delay or infertility in anorectal malformations, so the causes are multifactorial. It could be the vaginal stenosis that you encounter, either as, due to kind of the scarring from surgery, leads to obviously queries around optimal time for vaginoplasty. Often they will have about 3 laparotomies, sort of on an average. So pelvic adhesions are very frequently encountered, and these could affect the fallopian tubes, leading to tubal factor infertility. And the functional consequences, such as the incontinence or the body image issues and the psychological consequences, may also be additional challenges to forming partnerships or thinking about conceiving and delivering. And we finally also appreciate the additional layer of Mullerian anomalies that will coexist in this group. So this is to highlight again this work done by Dan Wood and his team, that we need to do much more in terms of gathering long-term management and outcome of cloacal anomalies, such as their life course and their fertility and reproductive outcomes, so that we can have meaningful information that we can convey to our patients. We need, Dan, thank you for pointing out, looking at kind of outcome measures for surgery. Is it, should we just look at a return to sort of some structural normality or more functional normality? With regards to options for fertility, if infertility was encountered, medically assisted conception is very much feasible, because these patients often always will have good ovarian function, because they are often separate. The Mullerian abnormalities are separate. And in fact, We often do not diagnose conditions such as MRKH or Rokitansky unless we have established that they have normal ovarian function. But egg collection, there are different means of egg collection, vaginal, abdominal, and they can be collected. There are sort of assisted conception with surrogacy is a very successful form of treatment, although sort of fraught with other complexities such as access to care, finance and all that sort of, or even access to surrogates. But if there is access to uterus, then standard IVF is also kind of very much feasible. But this has to be done in the context of a multidisciplinary setting with information from urology colleagues, the psychologists, and obstetricians. So in summary, we appreciate that there is an association between conception delay and adverse reproductive outcome in women with uterine anomalies. But this association is clearer only in the more complex anomalies, that is when they are associated with other comorbidities and other structural anomalies. So timely and optimal management can reduce risk of infections and endometriosis and optimize the chances of successful pregnancies. Medically assisted conception can be considered and can be done. And we should think about core outcome measures so that we can put our heads together. And when we look at outcomes, we all look at the same parameters that then enables very high quality systematic reviews. Thank you very much.
Effia, thank you so much. In the interest of time, we're going to move straight on. In fact, I'm going to give my talk that we were going to give at the beginning of the session, if that's all right. If there is one question I think that was directed to Effia in the chat. I'm going to ask Ray to pass that directly on to you, Effia, so that you can answer that privately. Is that all right? There are thousands of questions that come out of both of those talks. I'm very grateful to both presenters for taking the time to give them for us today. Thank you so much. I'm going to move on now and just talk a little bit more generally about some of the challenges in this population related to important conversations that are necessary for these patients. I'm hoping you're about to see my slides now.
Yes, we are seeing all the presentation, not one specifically yet.
Okay, that's interesting. Right, why am I not seeing that here? That's interesting. Okay. Change my view. I should be able to trade screens, but it's not. Ah, there we go.
If you click there, that should do it, I think, but it doesn't.
Ah, there you go.
There we go.
So
now it's working.
You now got the right view. Okay, I apologize. Right. So one of the things that that becomes important in conversations with our patients as they become adults is really thinking about their sexual function. And there are lots of data out there that now show us that these conversations are often either not addressed or poorly addressed. So it's really to highlight the importance of that. We've heard about the importance of fertility from Effia, and we've heard about the importance of understanding pelvic pain from Dr. Oliver too. And really setting all of that context together becomes really important in terms of sexual function. And there are lots of aspects to this. So this is really a kind of skate over some of those issues, and it'll be followed up by some further talks really talking about pregnancy and delivery, vaginoplasty, and so on. So these patients have normal desires, and there are lots of difficulties that they encounter with providers around conveying that message. And so it seems like a really fundamental thing to say, but it's really important. They would like to be able to pee normally, whether that's sitting down to pee urethral or standing to pee as a man. That's really important to these patients. And so the fact that some of them can't is important. Dr. Rink made a reference earlier to the importance around continence, and having a conversation with patients about continence and how that affects them is really important. And they would like not to use catheters. Well, sometimes that's unavoidable, but making sure there's a context to that and understanding that is really important. But as they grow and become adults, all of these patients have thoughts the same as everybody else about their sexual function and reproductive function, and what will be achievable for them in that space. And it's important to open those conversations and begin them. It's also really important to remember that for many of these kids, just coming to hospital once a year is not something that their friends or their peers do. So giving them a value to that is really important. And I think this is really important. Just make no assumptions, no matter what or who you see in front of you and the challenges that that person has. Make no assumptions about their desires and what might be going on in their mind about this type of work. So we know that there are lots of difficulties. If we take a Spina Bifida population, we know that there are issues regarding sensation, erectile function, and ejaculatory dysfunction. We know that in females with Spina Bifida, they tend to be slightly older when they begin sexual debut, but their fertility and their menstrual patterns are very similar to an age-matched population. And thinking about managing that and making sure that conversations around contraception and so on are had is really important. Directing them towards non-latex contraception and thinking about some of the data that we saw earlier relating to urinary and fecal incontinence is really important, addressing that with all of these patients. So we have lots of different roles in this. One of them is education. So if you've had your bladder augmented with bowel, then there are good data out there that show us that there's greater than a 50% false positive rate in urinary pregnancy tests. So educating our patients about this, making sure they know that, and that if they become pregnant or they're trying to become pregnant, confirmation with a serum pregnancy test is important as part of their care. Educating them about when they want to start thinking about having a family, if they've got a neural tube defect, is really important. So telling them about proactive taking of folic acid is really important, as it dramatically reduces their risk of having an affected child. So thinking about that and being proactive with our patients is really important. Understanding that many patients that come through to us in transition are referred with anatomical questions relating to urology or gynecology, but actually behind all of that, there are often major psychological questions that need to be addressed, recognizing that and allowing that. That's already come out in some of the talks that we've heard this morning, but from a surgeon's perspective, having that on your radar and being prepared to initiate that conversation is important. There was a big consensus meeting around differences in sex development a number of years ago, and that showed us that there was a need to reduce some of the surgical interventions early in life, or at least there was a need to have that discussion about reducing those interventions. And what we've seen over that time until 2014, when this paper was published, was that there wasn't really a reduction in the interventions. There seemed to be a shift or an improvement in outcomes. But I suspect that actually if we did that survey today, because of the way things have changed in the last 8 years or so, we would see a significant difference in these data. But these conversations are ongoing and they're developing. Recognizing, this was a slide I showed earlier, I apologize for the duplication, but it fits in context with this talk. Recognizing the impact of those questions around a patient's perception of normality is really important. So thinking about in extrophy where they don't have a belly button, whether or not they want to have a belly button made for them, and thinking about how that influences some of the decisions I talked about earlier in terms of where they reveal themselves in a locker room, how they talk to friends about it is really important, and it impacts on sexual function. recognizing that patients with conditions that we've historically heard outcomes were really good and there weren't issues around this, but recognizing that underlying the data, when we look long term, there is more to that, and there is more that needs discussion around that. As surgeons, we're presented with challenges in terms of sexual and reproductive function. So there are lots of questions in some conditions around preservation of gonads or removal in relation to malignancy risks. And we have to be prepared to have those conversations and have answers. Modifying our techniques so that when we come to undertake clitoral surgery in patients who have an enlarged clitoris, that our techniques have adapted to make sure that we preserve sensation as possible, as far as possible. Thinking about new techniques in terms of reconstructed vaginoplasty, so where possible, thinking about alternatives to long-term use of bowel. Bowels are very useful means of augmenting the vagina, but it comes with its own consequences and difficulties. Sex of rearing decisions are really important, and we live in a different world where that context has changed. So being prepared to address that's important. And I mentioned earlier the significance of scarring and changing through puberty for these patients as they grow. I see a lot of patients who come through with questions about size of their penis and whether or not they're able to engage in sexual relationships as a result of the size of their penis. And these data are a collection of papers that were put together by my mentor, Christopher Woodhouse, that show us that sexual relationships are very possible no matter what the size of your penis. There are psychological issues associated with that, so recognizing that, addressing that, and having the conversation is really important. And it means that although there are procedures out there that we can use, so phalloplasty to reconstruct a penis, they're there and they're an important adjunct to the care that we have. But consideration from a patient about whether or not that's really a line that they want to go along is truly important. So in terms of sexual function, we need to think about whether there's a relationship with the disorder or whether it's just the surgery that's important. There are lots of data now about patients and their decisions that were made for them, and whether or not those are associated with decisional regret. And they're really useful in terms of opening the discussion. I think there are difficulties in terms of the way these data are presented, but I think that the discussion is nonetheless very important. So understanding that there may be some decisions that produce tension as patients get older is something that's important to address and discuss, because these are data relating to parental decisions. Seeing how they translate to a patient reflection on those will be important as time goes on. Again, surgical challenges that we confront relate to the need for revision surgery, so vaginal stenosis. We know that bowel vaginoplasty has a good success rate, but it has its issues associated with it too, in terms of complications and things that we may need to address in later life. So being aware of that and being able to manage that is important. Other forms of vaginoplasty can be really successful. So Davidos and Vecchietti, and the use of buccal mucosa is a new kid on the block. So developing that and understanding outcomes will become important with time. We know that these patients, and Dr. Yasmin mentioned this in her talk, need management through their pregnancies. So as they go on to become pregnant, we know that being present as a reconstructive urology at their birth and their delivery, particularly if they're having cesarean sections, is really important, and it affects survival of both the child and mum. We can see here that there were data showing significant difficulties if they weren't born in a center where that was offered. So in terms of what are the problems out there, I think thinking carefully about when surgery is done and how consent relates to the long-term sexual function is really important. These were outcomes relating to a group of patients who'd had clitoral surgery. And as I highlighted earlier, there's no control group in there. So we don't know whether these data and these alterations in sensation relate to the condition underlying it or the surgery that was performed for that condition. But it's a really important topic of conversation amongst medical professionals and with patients. We do know that these patients, as they go on, have definite links with impaired sexual function and sensation and orgasmic function. So having that conversation is really important. And if we look at that more widely, then understanding the impact on sexual function and sensation, and the potential impact on mental health as part of that is also phenomenally important. So that is a kind of whistle through some of the things that we need to think about in terms of sexual function for our patients as they grow older. But bearing in mind that these are often decisions that were borne by parents early in a child's life, because that was the context in which patients were being looked after and the parents were being asked to make decisions. That was what was done at the time. And decisions and the environment shift with time, and the timing is different, but being mindful of that and understanding that patients may have different views as they grow older is important. Looking at what happens when they're at school and thinking about the behavior of their peers around them is really important. Who they tell, how they tell them, and making sure that those conversations can be supported is really important. And our psychologists do an immense job in that. But most importantly, if you're looking after these patients, be prepared to open that conversation and begin the discussion with your patients. Thank you so much for listening.
Thank you so much, Dr. Wood. I feel this is an extremely important topic and should not be forgotten by any doctor taking care of those patients. I think bringing sex into the conversation, in my experience, I have felt that most of our patients, they have the general insecurities that all females and male patients have. But because they have the congenital disease, they feel that they have that because of the congenital disease. So we have a very important portion in their well-being in telling that in most cases, of course, there are some that there is, that those are just normal insecurities. And I always tell, for example, my female patients, I try to say that their genitalia looks exactly like any other woman because they have this doubt. Do I look different than other women? Will my partner perceive that I am different? And the other important portion is knowing that many of our patients will be able to conceive normally, is talking to them about safe sex to avoid an undesired pregnancy, because for some patients, this will be a high-risk pregnancy, and we want to make sure it's a decision that it's well made. So thank you very much. And I would advise everyone to bring this topic and let the patient be comfortable about talking about it. And if you are not comfortable, send to someone that is comfortable. I am frequently in a room with Dr. Wood and Dr. Alanis, and we are very comfortable talking about, we go into details and we go as deep as needed. So we feel it's very important. Thank you, Dr. Wood.
So we're going to move on now to two recorded talks. The first from Dr. O'Brien, one of my colleagues from London, and the second from Dr. Alanis, one of our colleagues here in Colorado. Dr. O'Brien, I worked very closely with in terms of managing high-risk pregnancies in lots of these patients and performing jointly the cesarean sections. So I'm delighted to hear his talk in terms of managing pregnancy in this group.
Hello, and thank you so much for inviting me to take part in your conference. I would love so much to be there in person. Over the next 15 or 20 minutes, I want to describe the management of pregnancy in these patients with congenital urological abnormalities. And what I'd like to cover is these various topics of preconception advice, fertility issues, the diagnosis of pregnancy, the management throughout pregnancy from both a urological and an obstetric perspective, and then the birth itself. So in terms of preconception advice, I mean, the ideal, of course, is if we get to meet these women before they become pregnant, before they start trying to fall pregnant, ideally with the urologist and obstetrician together, but at least seeing both beforehand. And of course, very often what happens is that these women will be seeing their urologist often throughout life, and never get to see the obstetrician until they actually fall pregnant. So that's my first appeal to you. My big ask is, please, if you're seeing teenage girls or women like this who may become pregnant at some stage, please send them to us so that we can see them beforehand. And one of the big issues is for anybody about to start trying to get pregnant is to start taking folic acid. Folic acid, as I'm sure you know, reduces the chances of getting a neural tube defect by around 2/3. And any woman who falls pregnant should already be taking folic acid at the time she falls pregnant and for the first 12 weeks of pregnancy. Usual dose is 0.4 milligrams or 400 micrograms a day. If the woman herself has had a history of neural tube defects, though, she actually needs to be taking a higher dose, which is 5 milligrams a day. And the ideal model of care is going to be shared care with urologists, clinical nurse specialists, obstetricians, and midwives in this country. The things that we need to explain to these women before pregnancy, preconception counseling, is everything really that I'm going to talk about in this over the next 15 minutes. But, we want to share with the fact that there will be an increased frequency of scans, and by which I mean scans both of her renal tract and of her baby, that she will have regular contact with the clinical nurse specialist about things like catheterization, urinary tract infections, and so on. And then, even before pregnancy, we need to consider comorbidities such as renal function, urinary tract abnormalities, and genital tract abnormalities. Why? Well, renal function is important during pregnancy. I'll come on to that in a second. Urinary tract infections are common in this group and become more common in pregnancy. And genital tract infections because they can make it more difficult to fall pregnant, but also they can have implications for the pregnancy itself. Now, this is a slightly weird thing, the fact that diagnosing pregnancy can be challenging in these women. And you know that we test for pregnancy with a urine pregnancy test. Women usually do it themselves at home. And what they're testing for, of course, is beta HCG, pregnancy hormone. And strangely, in some of these women, particularly those who have an enteroplasty with large bowel or ileum, but also reported in nephrotic syndrome and also in obstructive pyelonephritis, is the fact you can get false positive pregnancy tests. It's not entirely clear why this is the case, but possibly related to acidic bowel mucus that's been made. But the bottom line is that don't accept a diagnosis of positive pregnancy test in women like this on the basis of a urine pregnancy test. It's simple to do a serum beta HCG, so a blood test to check the same hormone to confirm. I'm not going to talk much about fertility because I know that Effie Yasmin was talking about this just a little earlier. But just to say that there's a whole range of issues in women like this that can affect their fertility. One is abnormalities of the reproductive tract, meaning that sexual intercourse can be challenging or impossible. Secondly, if they've had previous surgery around vaginoplasty, for example, then the vagina may not be fully functioning, sex may not be straightforward. If they've had previous surgery, then they may have scarring, and by which I mean scarring not just around the vagina and vulva, making sex difficult, but also intra-abdominal scarring affecting the fallopian tubes or the ovaries, making fertilization challenging or impossible. And then other sort of medical comorbidities, such as abnormal renal function, can also impair fertility. And even if you think that IVF is an easy way, an easy option, then often in these women, particularly if they've had a lot of pelvic surgery, then it may not be straightforward to do IVF either. Okay, so now the woman is pregnant. What are the various considerations that we need to take into account? Well, one is renal function. In pregnancy, the total blood volume increases by around 40 or 50%. And of course, the kidneys have to filter all of this blood. And in most women during pregnancy, glomerular filtration rate will increase by around 40%. So the kidneys have to work harder during pregnancy. So if you already have impaired renal function, or borderline renal function even before pregnancy, then that extra demand can really put the kidneys over the edge. Another issue in terms of the renal tract is the increased risk of urinary tract infections in pregnancy. And that's even in women who've never had any bladder or kidney problems in the past. And there's a range of reasons why this happens in pregnancy. One is that there's obstruction of the lower ureters. So as you know better than I do, the lower ureters usually pass just by the lateral aspect of the cervix. So normally in any woman, as the uterus and cervix get bigger, they squash, they press against the lower part of the ureters. and there's a degree of obstruction. So the ureters and renal collecting system can get dilated. So that's a certain degree of that is normal in any woman. So in these women, where there may already be a partial or more significant obstruction of the renal tract to start with, and then the uterus gets bigger, then it can really exacerbate that. So that's one thing. And of course, when the urine sits there longer, it's more likely to get infected. The second factor that increases the risk of urine infections is to do with the immune system. So in pregnancy, your immune system is suppressed. So you're more likely to pick up infections of any type. You're more likely to get flare-ups of, cold sores, etc. But there's a benefit to that. The reason the body is doing this is because the baby, or half the baby's genetic material, comes from the father, of course. And one of the miracles of pregnancy is that the mother's body, the mother's immune system, tolerates having the baby within her body for 9 months. And one of the ways that's achieved is by suppressing the immune system. But the trade-off for that is that the woman is at increased risk of infections of any type. And if she's already prone to urine infections, then that can be a particular issue. And the third issue that increases the risk of urine infections in pregnancy is due to the pregnancy hormone progesterone. So progesterone, one of the big pregnancy hormones, progesterone, so for or supporting pregnancy, and it relaxes smooth muscle everywhere in the body, and that includes in the renal tract. So ureters dilate, renal pelvis dilates as a result of the progesterone effect, and again, that means the urine sits there for longer, and therefore is more likely to become infected. And also, separate to the increased risk of getting a urine infection, we also know that if a woman does get a bladder infection during pregnancy, it's more likely to spread upwards into the kidneys and cause pyelonephritis. Okay, I just want to talk about Müllerian abnormalities, because you will know from your urology background that when a woman is a fetus in her own mother's uterus, then her genital tract, her uterus, is forming sort of alongside her kidneys. So it is not uncommon to find coexistence of renal tract abnormalities and Müllerian abnormalities of the uterus. What do I mean by Müllerian abnormalities? Well, I mean this whole range of abnormalities of the uterus here, ranging from just a kind of slightly heart-shaped uterus. So the uterus should normally be shaped like a balloon almost. So mildest form of this is just a heart-shaped uterus, stretching right across to double uterus with double cervix and sometimes even double vagina. You can have a situation where there's only one uterine horn, as it's called, so almost like half a uterus, or just a little heart-shaped uterus like this here, or a uterus with a septum, a dividing wall down the middle. So whole range of abnormalities. The catch-all term is Müllerian abnormalities. And in this group, this population, it's around half of women who could be affected by some degree of Müllerian abnormalities. And that compares with the general population of only 3%, although admittedly a bit higher in the infertile population, about 16%. And only about 0.5%, 1 in 200 of the entire female population, have a major abnormality of the sort of double uterus side, variety of the unicornate uterus. Now, what's the significance of that for pregnancy? Well, a couple of things really. The biggest issue is the risk of premature labor. So there is an increased risk of miscarriage. Why is that? Well, you can imagine if the fertilized egg arrives in the uterus, and instead of sort of sticking onto a nice thick wall here with a rich blood supply, if it happens to stick onto a thin membrane, a thin septum in the middle, which doesn't have a fantastic blood supply, then that's probably less able to support the pregnancy, and therefore the risk of miscarriage is higher. So that's one thing. But perhaps a bigger consideration is the risk of preterm labor, premature labor. And why is that? Well, there are two reasons behind that. One is that you can imagine if, let's say, you have a uterus like this one here, where a unicornate uterus, or let's say a bicornate uterus like this, and the pregnancy ends up in one horn, one side of the uterus. You can imagine that that side of the uterus probably cannot expand to carry a baby all the way to term, to 40 weeks. And if it stretches to its capacity and it can't stretch any longer, let's say the woman's 32 weeks, that she's 8 weeks premature, then that overstretched uterus will go into labor and start contracting, and the woman will deliver her baby early. with all the risks that might carry to the baby of prematurity. The other reason why premature labor and birth is a risk in these women is the association between Müllerian abnormalities and cervical incompetence. What does that mean? Well, it means a cervix that's weak. It's not as strong as it should be. And therefore, as the baby gets bigger and heavier, the cervix starts to open painlessly. In other words, no contractions, just painlessly starts to open under the weight of the baby. And that can happen at any stage from 18, 20, 22 weeks of pregnancy or further on. Can we do anything about that? Well, we got two options really, and we'll often employ both. One is to give the woman progesterone. Progesterone, we know, relaxes the uterus, and it makes it therefore less likely to go into early labor. And in women at increased risk of premature labor, progesterone may reduce the chances. The other option is to consider cervical length scanning. So, and we would always do that in women who have a known Müllerian abnormality. So we check with it using a transvaginal scan. We measure the length of the cervix, and ideally the cervix should be. Cervix is not like a circle, not like a ring. It's more like a tube, really, like a cylinder, and it should measure at least 20 millimeters from the outer opening, the external os, as it's called, to the inner opening or the internal os, and that tube should be closed to its entire length. So we can do cervical length scans, which are transvaginal scans, perhaps starting at 16 or 18 weeks of pregnancy. So at a stage when the baby's getting bigger and heavier, and looking for any signs that the cervix might be opening or shortening or funneling under the weight of that baby. And what do we do? Well, we can put a stitch in the cervix, and this is done vaginally, so it needs a proper anesthetic, like a general anesthetic or a spinal anesthetic, so that the stitch can be put in, and then the stitch is put in vaginally as high up on the cervix as possible. And it's called a purse string stitch, so it goes around the cervix and pulls tight, just like a stitch or a thread around the top of a purse. And then as the woman gets close to delivering the baby, the stitch can be removed vaginally. Doesn't need an anesthetic usually to remove it. Okay, so as this woman goes through pregnancy, what are we going to do from the urological point of view? Well, we need to watch renal function, as I said, because of that extra demand on the kidneys. And that means checking baseline creatinine. And of course, these women will often have baseline creatinine levels from before pregnancy, but check baseline creatinine once pregnancy is diagnosed. And then check renal function every 4 to 6 weeks throughout the pregnancy, just with simple blood tests for urea, electrolytes, creatinine. Secondly, need to look for any signs of obstruction of the urinary tract, hydronephrosis, and that means 4 to 6 weekly renal tract or renal and ureteric and bladder ultrasound scan with clinical review by urologist. Watching out for urinary tract infections, and that means asking the woman to watch out for symptoms, having a lower threshold for testing the urine and for culturing the urine. And then regular access to clinical nurse specialist teams. And this is critical, really. The woman will not be seeing a consultant urologist or consultant obstetrician all the time, but having regular access by phone, by message, by email, and directly seeing clinical nurse specialists to talk about practical issues in relation to self-catheterization and urinary tract infections, invaluable. If there's progressive hydronephrosis, nephrostomy, temporary nephrostomy during the pregnancy becomes necessary, and that nephrostomy tube can be removed usually a few weeks after the baby's born. You know that when a woman reaches 40 weeks of pregnancy, the uterus pretty much fills the abdomen. The minute the baby's born, I mean, literally a minute after the baby's born, the uterus will contract down to half its size. So the top of the uterus will be around the level of the umbilicus, and then it takes 6 weeks to go back to normal after that. So at some point after that, the nephrostomy tube can usually be removed. Also important to ensure good bladder emptying, because depending on the exact anatomy of this woman after her urologic abnormality and perhaps surgery, there may be obstruction of whatever drain, not just the ureter, but perhaps the route by which the urine escapes from the bladder or the reservoir. In that regard, those women who do intermittent self-catheterization, for example, through a Mitrofanoff, it's not uncommon towards the end of pregnancy that it becomes more difficult for them to self-catheterize. The channel becomes kinked or just obstructed. Here's an example of a small audit that we did of 19 women in this situation. And, 2/3 of them had significant urological problems. 9 of those were singletons, and all with twins, because of course with twins, the uterus is bigger and more likely to squash everything earlier. 6, for example, had prolonged indwelling catheters. 4 single pregnancies had upper urinary tract obstruction and required nephrostomies or stents, and all 3 twin pregnancies required nephrostomy or stents. We need to keep an eye on the baby because of the risk of fetal growth restriction, and that's because we know that can be caused by recurrent urinary tract infections, Müllerian abnormalities if the blood supply to that part of the uterus where the placenta is adherent is less good than it should be. And impaired renal function can impair the growth of the baby. So regular ultrasound scan of the baby every 4 weeks. Checking uterine artery Doppler, so that's looking at blood flow resistance in the uterine artery, so the mother's blood vessels at 22 to 24 weeks. If there's an increased resistance in those blood vessels at that stage, it tells you that there's an increased risk of growth restriction of the baby later on. And then from 26 weeks on, fetal Dopplers, that means looking at blood flow or resistance to blood flow through the umbilical artery, which is part of the baby's circulation, and the baby's middle cerebral artery, because those change if the placenta is not functioning as well as it should, if the baby's not growing very well. Okay, that brings us to delivery, and the timing and mode of delivery, I guess, is primarily an obstetric decision, but again, the best practice is shared decision-making, urologist, obstetrician, and the woman herself. There are various indications for a planned cesarean section. One is depending on the anatomy of the woman, let's say vaginoplasty, for example, where you just do not want that vaginoplasty damaged by a vaginal birth. So various conditions where bladder, neck, or perineum or vagina needs to be protected, then cesarean section is the better option. Somebody's had a major pelvic anomaly, such as bladder exstrophy. And then the challenging decision really comes in this group of women, those who've had multiple laparotomies, where you know that, from previous laparotomies, what they've seen there, or even just you can imagine that it's likely that she has multiple pelvic and abdominal adhesions. And it's a difficult decision because of this, because in some of these women, vaginal birth is feasible, and vaginal birth, in fact, would probably be more straightforward than a cesarean section, given the difficult anatomy and multiple adhesions. The problem is, what you really want to avoid is an emergency cesarean section, or a situation at 4 o'clock in the morning, less experienced surgeon, less experienced anesthetist, where there's a rush to get the baby out because the baby is distressed and short of oxygen. And that's the situation where there's a really much more significant risk of damage to the bladder, the reservoir, the metrophenoph, the bowel, whatever. So on the one hand, in some of these women, vaginal birth would be the ideal, but emergency cesarean section would absolutely be the worst. So we have quite a considered discussion with these women. So urologist, obstetrician, and the woman together to discuss the pros and cons. And very often the agreement and the mother's preference will be to go for a planned cesarean section, where even though we know it might be a difficult operation, at least it can be done in the cold light of day with an expert urological surgeon, an expert obstetric surgeon, and no rush whatsoever to get the baby out. What sort of skin incision do we make? Well, it's a difficult decision again, often. The usual type of abdominal incision for cesarean section, as you know, is this lower transverse abdominal incision. It heals well, cosmetically, less pain compared to a lower midline incision. The issue is, if you make a lower transverse abdominal incision and then come across really bad pelvic adhesions, so for example, the uterus stuck to bladder, stuck to abdominal wall, it can be really difficult getting above where everything is stuck and getting to the uterus higher up. On the other hand, if you make a midline incision, then cosmetically not so good, more pain during recovery, but it does have the real advantage that if everything is really stuck low down, you can just bring the incision a bit higher and get to the top of the uterus and gain better access that way. So quite a challenge. And again, this is a discussion we have with the women, but if we feel there's a significant risk of bad adhesions, then we have a lower threshold for going for a midline incision. And then finally, the incision on the uterus. And the bottom line is, well, wherever we can manage to do it. Again, you know that the usual incision on the uterus for cesarean section is this lower transverse or lower segment incision. And that's good. That's quite a strong incision. So a woman could go through a labor in a future pregnancy with this sort of incision. Having said that, if the woman's having a cesarean section this time for various urological reasons, then it's likely that that's what will happen next time as well. So that becomes less relevant. And to be honest, what we do is that when a urologist like Dan Wood and myself are doing the cesarean section, there are times where we just get or expose whatever bit of the uterus we can. And once I feel that I've got enough access, then I'll bring the baby out through there. The relevance, as I say, of this type, this vertical or classical type of incision, as we call it, on the uterus, it doesn't have any effect on the recovery after the cesarean section. The only implication is that it means this woman must have cesarean section for future births, but that's generally been the case anyway. And just to give you a sense of this is an audit of 57 pregnancies, and you can see that most were live births. 21 miscarriages, which is higher. I mean, the background rate of miscarriage in the general population is around 25%. So this is possibly a bit higher than that. Although remember what I was talking about, the false positives with the urinary pregnancy test. So that might impact the apparent first trimester miscarriage rate. All had cesarean sections in this cohort. 3 emergency associated with 2 neonatal deaths, and that's because of prematurity. We were talking about that a minute ago. And that gives a perinatal mortality. So 3 there. There's the 2 neonatal deaths and 1 stillbirth out of 57. So about 7 per 100. And that's high compared to the national perinatal mortality rate, which is 8 per 1,000. So it's about a tenth of that. And the prematurity is the biggest issue, really. So in summary, where possible, plan ahead. Get to see these women, urologist, obstetrician, get to see these women before they fall pregnant. Diagnosis of pregnancy, confirm it with a serum, with a blood HCG, not just a urine HCG. Regular follow-up during the pregnancy, by which I mean follow-up of the mother, the baby, and the urinary tract. Regular and ongoing communication between urologists, obstetric team, clinical nurse specialist, and ongoing shared care. And then delivery, usually surgically, ideally with the senior urologist and senior obstetrician. Thank you very much indeed.
That's a great talk from Dr. O'Brien, who I worked closely with in London. We're going to move straight on to a second recorded talk from Dr. Alanis here in Colorado. Ray, are you able to start that for us? Thank you.
Hi, my name is Veronica Alanis. I'm a pediatric and adolescent gynecologist here at Children's Hospital Colorado, and I'm going to be presenting on the assessment and management of vaginal stenosis in patients with anorectal malformations. So we know that gynecologic concerns can really arise during all stages of life in our patients with anorectal malformations. We can see issues arise during infancy with the hydrocolpos, during puberty with menstruation or absence of menstruation, with sexual intimacy, and then with fertility and pregnancy. And patients with anorectal malformation may undergo a vaginoplasty. So in cases of a rectovestibular fistula with vaginal agenesis, if they just have distal vaginal agenesis, the vagina can usually be mobilized to the perineum during the initial reconstruction. But in cases of complete vaginal agenesis, they may need a vaginal replacement. And similarly with cloaca, if it's a short common channel, the vagina is typically mobilized to the perineum. But in cases of a long common channel cloaca, these girls may need a vaginal replacement or a vaginal switch procedure to create the vagina. And we know that the anorectal plasty can create some scarring in the perineum. So typically, vaginal replacement is recommended during the initial reconstruction in cases of vaginal agenesis. And there are a few options for vaginal replacement. If the sacral ratio indicates likely fecal incontinence, then the distal rectum can be left in place as a neovagina. But if the patient is expected to have good bowel control, then typically a descending colon is used as a graft. And descending colon is chosen because it's easier to mobilize and has a good blood supply. So the segment is harvested and taken down to the perineum with its mesenteric blood supply. And in these cases, post-op dilation is not recommended because of young age, but these patients are at risk for stenosis and should be evaluated for patency. And the first evaluation can be done at the time of the colostomy closure. So vaginal stenosis is an acquired condition in which the vagina either becomes closed, shortened, or narrowed from tissue scarring. And this is a known consequence of any vaginal surgery and a known risk with vaginoplasty. So we can see some scarring or stenosis at the introitus for those patients who had like a vaginal pull-through procedure. If a patient had a graft place, we can see stenosis at the introitus or at the site of the anastomosis with the native vagina. And then we can see cases also of segmental stenosis, like if there's any sort of inflammation in the vagina that can cause the vaginal walls to become a little denuded and then kind of stick together and cause some scarring. And this can have significant gynecologic implications related to menstruation, specifically menstrual obstruction, sexual function, if there's narrowing, that can certainly cause pain with intimacy, and then fertility. So vaginal stenosis can be complete if the vagina is completely stenosed and there is a uterus present. That can lead to menstrual obstruction, significant pain, and endometriosis. Vaginal stenosis can also be partial, and that can lead to dyspareunia or painful intercourse, and then difficult pelvic exams, in which case the cervix is hard to identify during vaginoscopy or an office pelvic exam. And the prevalence of vaginal stenosis in our patients who undergo vaginal surgery for anorectal malformation is definitely ranges in the literature. So in the study by Warren et al. In 2003, they reported 15% of their cases who had a UG sinus repaired at birth ultimately had vaginal stenosis, compared to 42% who had it repaired during adolescence. And then higher rates of vaginal stenosis, 41% for patients who had a reconstructed cloaca with a common channel length greater than 3 centimeters, as opposed to 8% for those with a common channel of less than 3 centimeters. In this study by Couchman et al. In 2015, 56% of those who underwent vaginoplasty in the first year of life had vaginal stenosis. And then in this recent study by Blythe et al. In 2021, they reported that 100% of their reconstructed cloacal anomalies had vaginal stenosis, although only 33% of them needed revision vaginal surgery. So during puberty, really the focus is on ensuring that the patient has patency for menstruation, and if they don't have menstruation, figuring out why. So we can see amenorrhea in 20 to 30% of patients due to underdeveloped or hypoplastic Müllerian structures, or structures that were removed during the initial reconstruction. And then in studies, obstructed menstruation is reported in up to 41% of cases. And this, can really happen can happen because of congenital causes and then acquired causes. So congenital causes, the patient may have like uterine remnants that are not fully developed that lead to obstructed menstruation, or obstructing vaginal septa can also lead to obstructed menstruation. And then acquired causes like vaginal stenosis. And in either of these cases, the obstruction leads to retrograde flow, which can cause significant abdominal pain from the hematometrocopos, and then hematosalpinx and endometriosis. These are just a couple pictures of endometriosis from obstructed menstruation, and you can see this like thick, dark blood kind of lining the peritoneal surfaces and along the bowel as well. These are 2 MRIs of patients who had hematometrocopos. So here on the left, this is a patient with a didelphys uterus, and you can see she has a hematometria with hematosalpinx as well. And then this is a patient on the right with a with stenosis of the vagina, and you can almost kind of appreciate this double bubble. The top is the uterus that has obstructed menses, and then it narrows at the cervix, and then a dilated vagina as well. So it's really important to assess the reproductive structures in our patients who have anorectal malformations and who have had any sort of vaginal surgery. So we do this, we can utilize various techniques to assess reproductive structures, certainly ultrasound, MRI, vaginoscopy, saline perturbation of the fallopian tube. So if the patient is undergoing an abdominal procedure or an exploratory laparotomy, using that opportunity to look inside, evaluate the fallopian tubes, and then retrograde fill the fallopian tubes to see if they're patent with the rest of the reproductive anatomy, and then examining the introitus, especially for those girls who had any sort of pull-through procedure, to make sure that the introitus is adequate, as well as the perineal body. We assess reproductive structures certainly at the initial repair, just to get a sense of what the anatomy is, and then using any surgery as an opportunity to assess again, and definitely during puberty. So most girls follow a very predictable pubertal sequence that starts with breastfeeding around the age of 10, and then 2 years later, girls will usually have their first period. So evaluating reproductive structures about 6 to 12 months after start of breastfeeding is a good time point. And then definitely with any pelvic pain, that should be evaluated. When menstrual obstruction is identified, there are different preoperative strategies that can be considered, as well as definitive surgical management. So preoperatively, using hormonal therapy to suppress any further menstruation. We can use our colleagues in interventional radiology to perform ultrasound-guided drainage of the hematometrocolpos, or you can consider a surgical vaginostomy tube. Definitive surgical management usually involves redo vaginoplasty, although you want to consider the age of the patient, and if there's a risk for recurrent vaginal stenosis, these patients may need to dilate postoperatively, so you want to make sure that they're at an appropriate age where they can engage in that postoperative care. If there's scar tissue or septum, that can be resected. And then in very rare cases, we consider hysterectomy. So this would be considered in consultation with our ethics committee, especially for patients under the age of 18, and really only in cases where there's no potential for future fertility. So ultrasound guided drainage is typically performed by our colleagues in interventional radiology, and a percutaneous abdominal approach is preferred. If the needle is placed through the vagina, there's just increased risk of infection. So here's a sequence of images on the left side where a patient has a hematometra. You can see the needle being advanced through the muscle of the uterus into the cavity, and then applying it to suction to remove that obstructed menstruation. And if the menstrual blood has been there for a while, it can be very thick and coagulated. So we can use things like TPA to break up the clot and help facilitate removal of the blood. Introital or vaginal stenosis can be managed in different ways. So if the stenosis is mild and the tissue is flexible, you can consider starting with vaginal dilation. If the stenosis is just at the introitus, then an introitoplasty. In cases where there's some segmental vaginal stenosis or it's really thick, patient may need a distal vaginal replacement. Or if there's like a small area that you want to open up, utilizing things like a buccal graft can help alleviate the vaginal stenosis. And repeat vaginal surgery is common. So in studies, studies have shown that 20 to 50% of patients who've had a vaginoplasty need a second or sometimes even a third vaginal surgery during adolescence or adulthood to manage vaginal stenosis. So with vaginal dilation, like I mentioned, this can be considered for mild stenosis, and patients use serial dilators. So this is an example of the dilators that I typically recommend for my patients. They're Syracuse dilators. They're inexpensive, about $10 a dilator. Very important that the patient can engage in this post-op or engage in vaginal dilation so they're at an appropriate age for it. We recommend doing it for about 20 to 30 minutes per day. They must have privacy, and they they have to be motivated to do it. Like, it's not going to work if the patient is not motivated. You can also consider utilizing our colleagues in physical therapy to help with vaginal dilation efforts. Here are just some photos of what a revision introitoplasty might look like. So you can see scarring here at the perineum that is then opened up with the introitoplasty. So patients that are at risk for post-operative, so patients who undergo a vaginoplasty have vaginal stenosis. The vaginal stenosis is managed with a revision surgery. They may be at risk for recurrent vaginal stenosis. And there are no clear guidelines for use of stents or dilators after vaginal surgery, but certainly if you think that the patient is at risk for recurrent vaginal stenosis, you want to think about having them dilate or at least place something in the vagina so that they don't stenose again. A variety of medical devices are used and described in the literature for the prevention of vaginal stenosis. This ranges from Foley balloons to tracheobronchial stents to filling a condom with foam and then placing that as a stent. And then there are some custom molds. So this picture here that's third from the bottom is the Allura stent. So there are some custom molds that can be considered, but they are not readily available, and in the pediatric world usually have to be customized to fit our patients. And then there are some adjunctive treatments that we can think about. So with tissue scarring that is recurrent, there are case reports of using dilute steroids at the site of the tissue scarring to kind of help soften up the scar. So you can inject dilute triamcinolone at the scar tissue. And then if the scarring is from something like inflammation or diversion colitis, utilizing some adjunctive treatments like short chain fatty acid douches to minimize inflammation, steroid enemas, and then in rare cases also neovaginectomy. Other things just to think about when patients present with vaginal stenosis, there are cases of dysplasia and adenocarcinoma that are reported in the literature. So any bleeding, pain, nodules, or stenosis definitely needs to be evaluated with exam, vaginoscopy, and then sometimes a biopsy. And this is a case report from a patient that we took care of. There was a patient that presented with a stricture or stenosis of the neovagina, and she ultimately was found to have high-grade dysplasia at the site of stenosis. She had a history of a cloaca and ulcerative colitis of her neovagina. All right, thank you. I'm not live to take any questions, but if you think of any questions, please feel free to email me. My email is veronica.alanis@cuanschutz.edu.
So I think you'll agree, two really great talks in terms of the management of some of the long-term conditions that we see in this congenital group of patients, taking us through how we manage pregnancy, and then some of the more complex issues around vaginal stenosis in adult life. I'm delighted to introduce my colleague, Dr. Bischoff, who's going to talk to us about some of the complexities and tips and tricks around vaginoplasty. This has been a wonderful conference to put together with you, Andrea, and I've really enjoyed working on it. I'm looking forward to hearing your talk. Thank you so much.
Thank you very much, Dan. And Dr. Alanis is not live with us because she recorded this lecture a few hours before she delivered, and she's now enjoying her maternity leave. So we are all very happy for her. So as most of you know, my experience on vaginoplasty comes mainly from reconstruction in patients with anorectal malformation. But when we are seeing an adult patient with anorectal malformation, if I could give you an advice, the first one would be determine if the patient has bowel control or not before you think about what type of tissue you're going to offer for vaginal reconstruction. Of course, in adult patients, this is a very easy task because the patient will be able to tell you if she has bowel control or not. Now, in children, it's a little more difficult, but depending on the type of malformation, quality of the sacrum, we can determine the prognosis. And then if you're considering using the colon, I always recommend getting a contrast enema, because this will give you hints of the shape of the colon, of redundancy of the colon, or that will help you plan for your vaginoplasty. So I know Dr. Alanis showed this picture before, and I put it for two purposes. One, to remind why we think in anorectal malformation, we are dealing with a different disease than, for example, Mayer-Rokitansky. There is a lot of discussion about reconstruction and making the vagina later in life, but I just want to give you an example of patients that are born with what we call rectal vestibular fistula and absent vagina. If we try to repair the rectum only, we will dissect exactly this area where the vagina will be in the future. So this is the perfect opportunity. You will never have such a good exposure as during the primary repair. And if you try to reconstruct later in life, you're going to find a lot of fibrosis, and it will not be an easy surgery. So for this, I have encountered an adult patient that had this malformation and was unrepaired. She did not have a bowel control. She had a poor sacrum. So when that's the scenario, no bowel control, no good chances for bowel control, then this is a very easy operation, because the rectum was by accident already placed where the vagina should be. So in this case, you can just leave the distal rectum as the neovagina and then pull through a more proximal colon to serve as the neoanus. But again, this operation is only indicated if the patient has poor prognosis for bowel control. Now, most of the reconstructions that we do are for patients with cloacal anomaly. They have a long common channel. Why we cannot delay repairing those patients? Because many of them suffer from kidney damage, and we need to have this urethra catheterized to protect the kidneys. So again, as we separate the rectum, that will be the ideal time to separate the vagina from the urinary tract and reconstruct the vagina as needed. So I'm going to show you a few options. And again, depending on the anatomy that we have, we will choose one way or the other. Sometimes we have patients that have a very dilated rectum. In this case, we are able to divide the rectum longitudinally and keep the blood supply for the future vagina from the mesentery, and then the intramural blood supply will be sufficient for this rectum. Beauty of this operation, it does not affect bowel control. Danger of this operation, you will have two lines of sutures. You want to make sure, especially in this area, that you don't have a stricture. And if you're doing this operation, I would probably recommend a protective stoma until the area is healed and you confirm that there is no fistula formation. But it works, and it's a good alternative in these patients. Now, again, if the patient does not have bowel control, you can use the distal rectum as a neovagina. Big advantage is already there. It's very easy to mobilize to the location of the vagina, and then you will bring more proximal bowel down. For that operation, you don't necessarily need a stoma, but I'm very conservative. I would do bowel prep, and I will let the incision heal completely before I feed the patient, so between 5 and 7 days. And then you bring more proximal colon as the neorectum. And you always have to know what's the internal anatomy, especially when you're reconstructing an older patient. If there is Müllerian structures, you have to anastomose the uterus or the proximal vagina to this partial vaginal replacement. Now, sometimes you have a redundant sigmoid. And in the case that the patient has bowel control, you want to preserve rectum as rectum, and then you can select sigmoid for your vaginal replacement. Now, the key when using colon for neovagina is having good visualization of the blood supply. You really have to understand the blood supply to assure that your graft will be well vascularized. Great advantage of bowel neovaginas. When we do them in young girls or in babies, we do not do any dilation. If you have good blood supply, you don't have to worry about it. They will be working later in life. You will have a ring-like stricture at the introitus, but that is because you cannot make an introitus that is adequate for sexual intercourse in a baby. You don't even have space in the perineum. So, but that's an introitoplasty like Dr. Alanis showed. But for older patients, when we do a vaginoplasty, then we'll make the introitus already adequate for sexual intercourse. If we do with a good piece of bowel, those patients will not need dilation. So here's an example of what type of visualization you need before you decide about your graft. What we do is usually we have those OR lights and we put them aside so we can really see the blood supply. So in this case, if I'm selecting this segment and I need a little more length to reach the perineum, I know, for example, that I can cut this vessel because this arcade will provide the blood supply. So in this case, I can cut this vessel, this arcade will preserve, but then I have to preserve this Y. So I can cut the bowel here, but this arcade has to be preserved. So seeing the blood supply is key when you're performing vaginoplasty. Now, the other portion that in older patients, we sometimes don't have access to their operative reports, but we have to think that they had a colostomy, and during the colostomy, some vessels may have been ligated. So again, that's why it's so important to have good visualization of the entire blood supply before deciding on which segment you're going to use. When the colon is not available, then our second option is the small bowel. We like to use the ileum, and the reason is because if you touch the cecum, you will see that about 10 to 15 centimeters from the cecum, proximal to the cecum, is the longest pedicle of the ileum. So if urology is not using that for bladder augmentation, we can use that for vaginal replacement, and it reaches the perineum very well. The reason why this is not our preferable option is because the blood supply for the small bowel is way more sensitive than the blood supply of the colon, and the tissue of the small bowel is also more sensitive than the tissue of the colon. So here is just showing that we select, and this is going to be our vaginal replacement. Again, seeing the blood supply is key. Assuring that your graft is well vascularized is key. And you always need to know what's your anatomy and if you have to connect this to a proximal vagina and uterus. Now, for older patients that come to us, they had a vaginal reconstruction and now that vagina is there, but it's stricture and it's almost like a narrow stricture. We use, if the patient does not have bowel control, we can use this technique that we use a rectal patch to enlarge the vagina. So we mobilize the distal rectum, we preserve the blood supply, we open that segment and we patch it behind, and then you will have an adequate vagina for intercourse. Now, when we are operating on older patients making anastomosis in the middle of the vagina or patching, those are patients that are motivated because they are already trying intercourse, those are the ones that we will recommend dilation after the operation, but for babies, never. So this is an adult patient that came with an obstructed vagina. She had a distal vagina, but they were not communicating. She had a history of anorectal malformation and did not have bowel control. So in this case, I felt safe to mobilize the rectum to access well these two vaginas and connect them well. So here you can see her anatomy. She's in prone position. This is the anus. You can see that she had what appeared to be a normal vagina, but it was only 4 centimeters in length. And then again, she's in prone position. We mobilized the rectum. And then since we had a catheter in the proximal vagina, we were able to inject solution during the operation and identify that proximal vagina. So here we open that proximal vagina. And here you can see the proximal vagina open, and there was the distal vagina, and we were able to connect both. Again, we are having a circular anastomosis in the middle of the vagina. So this is a patient that we asked to dilate, and she is doing fantastic. And we reconstruct the anus. Now, this is another patient. I would say it's almost an atypical presentation because it looks like she has a vagina, but she did not have it. She had the urethra, she had the anus, and she had just this distal portion. Those are the cases that when we have to reconstruct, currently we are using buccal mucosa as our first option. We always have a Foley catheter, and we know in this case that we have that space between the rectum and vagina, but if it's a patient that has been reconstructed before, I always do bowel prep. I always have a Hager dilator inside the rectum and a urethral catheter inside, Foley catheter inside the urethra, so I preserve and I'm safe with that dissection. Once we open that, we can put buccal mucosa. I don't know how much is the buccal mucosa itself or just opening the space and doing dilations. And then one of the complications from bowel neovaginas is that sometimes there is a prolapse. So this is a case that we had reconstructed and she came back with this prolapse. This is a very easy thing to fix. So you just resect that tissue that it's prolapsing, and she had a very good cosmetic result. I don't have pictures after the repair, but I hope you trust me. And this was a patient, it was an unfortunate case. She was born with a urogenital sinus and had complication after the complication, and she came to me with a vaginal rectal fistula. Remember, this is a patient that had normal anus. So for this patient, we have the lacrimal duct probe here going from the vagina to the rectum, and we did a transanorectal approach. We opened the rectum in the midline, we unroofed this communication, and then we were able to mobilize the anterior rectal wall and take care of the rectovaginal fistula. Now, when we're dealing with a patient that has normal anus, normal sphincter, when we do a transanorectal approach, we open a protective colostomy because you have to think that the sphincter almost acts as a distal obstruction. So if we don't open the stoma, this patient will be high risk for fistula formation. And then with this procedure, we took care of the rectal vaginal fistula. And I think that's mainly what I had to say today. I'll be happy to answer questions, and I will stop sharing for now so I can share Dr. Peña's presentation that will be talking after me. But if there is any question, Dr. Wood, if you can tell me, I'll be happy to answer.
For sure. Yeah, there are 2 questions that have come up in the chat. Well, hold on, the chat's just disappeared. Okay, the first was, after a bowel vaginoplasty, do you use regular flushing for the vagina?
That's a very good question. Yes, some bowel neovaginas produce mucus. So what we do, if they produce mucus, we teach, when it's an adult, it's easy. We teach the adult how to do it. But if it's a baby, we teach the mom how to do it. From our case, it has not been a serious problem. In some patients, we don't know why more than others, but usually with once a week cleaning or with a Foley catheter and small amounts of saline solution, that takes care of the problem.
And then there's a second question, which is slightly more challenging, I think. Have you ever tried to put a bowel segment in preservative solution and make an anastomosis with the iliac vessels, like an autograft, if you don't have good blood supply to bring down to the perineum?
I didn't understand, but I'm suspecting the person is asking if I have used other vessels for blood supply.
So yeah, have you ever transposed bowel and taken the blood supply from bowel and plumbed that into iliac vessels, I think is the question.
Oh, no.
I've not seen that.
I've done that. I don't have this experience. Okay, so it's my pleasure now to introduce Dr. Pena. I think all my experience comes from him, and he will talk to us about reoperations in adult patients. We'll just switch places.
Ya. ¿Cómo se pasó la? Good morning, good afternoon, everybody. It's my pleasure to be part of this selected group of experienced physicians discussing a subject that is that very important nowadays, the transition of care. I'm sure my colleagues and friends that have been talking in this meeting already emphasized the relevance and importance of this subject, transition of care. When I started working in colorectal 42 years ago, I did not expect, I was not thinking that my patients would become adults and they will follow me, and I am always happy to talk to them and treat them. And based on that experience of adults coming to us, I'm going to make a short presentation. This is reoperation in male adult patients that came to us. So the most common reason why adults come to us after having born with an anorectal malformation is rectal prolapse. And rectal prolapse, as you know, is something that happens very often after an operation for anorectal malformation. And it is more common in patients that have poor sphincters, a poor sacrum, and those patients have more chances to suffer from prolapse. Lately, with the advent of the minimal invasive procedures, we started seeing more prolapse than in the old times, because in laparoscopic repairs of anorectal malformations, the surgeons divide all the natural attachments of the rectum to including the peritoneum, and therefore that makes the prolapse more common. And the operation for prolapse is relatively easy. And when Dr. Luis de la Torre came to join us, we learned from him a better technique. And for many years, what we did is simply put a lot of, as you can see during the operation, put a lot of stitches at the mucocutaneous junction, and then make a circumferential incision all around away from the stitches. And we pulled the bowel until we estimated that we resected the prolapsed portion and re-anastomosed the bowel in 2 layers to the skin. And that gave reasonable good results. But now Dr. de la Torre came with another technique that perhaps he will be able to describe for you, and we published recently. So, and this is after the resection of part of that, and when we release the tension that you see in the skin of the buttocks, the external appearance looks better. But all these patients with prolapse usually have what we call patulous anus. We cannot cure the patulous anus. We just resect the excessive tissue. The prolapse produces very inconvenient signs and symptoms to the patient, because sometimes it produces a lot of mucus, and that mucus goes through the underwear and sometimes the pants of the patient, and that's why they are very unhappy about that. Another thing that we started seeing more than 30 years ago is the posterior urethral diverticulum. And so these are patients that were born with an anorectal malformation, and the surgeon left a piece of rectum attached to the urethra and pulled the rectum, frequently mislocated. The rectum belongs here, and frequently we found it out of place. And we saw this particularly in patients that were born with rectourethral bulbar fistula. And the patients in the past, for those who are young, in the past, there were two types of treatment for anorectal malformations: perineal approach or a laparotomy. And patients that have a urinary fistula, all of them were operated via abdominal. So when the surgeons coming through the abdomen try to reach this point, the junction of the rectum with the urethra, it was extremely difficult, particularly in babies, for the surgeon to visualize and reach this point. And therefore, to play it safe, they amputated the rectum here and put the rectum down here. So this piece of rectum provokes significant symptoms. It produces mucus, number one, and number two, produces pseudo-urinary incontinence. In other words, every time the patient goes to empty the bladder, part of the urine goes out and the other part of the urine goes into the diverticulum. And then he finishes voiding his bladder and goes playing and keeps leaking urine from the diverticulum. And I had one particular patient that came to me when he was 33 years old, and he was born with anorectal malformation and suffered from pelvic pain. And several urologists saw him and studied him in different ways, and they concluded that he was having perhaps he was having anal sex. This poor man was very upset with that kind of diagnosis because he was a very puritanical, nice young man. I operated on him. This is the MRI, and you can see that this is the bladder, and the diverticulum was larger than the bladder, actually, hard to believe. And then obviously I offered him an operation. And this is the transverse section of the MRI. And we saw something very, very unusual. This is the rectum, and this is the diverticulum. So look like a donut. How could we explain something like this? We went ahead to operate and see what we found. The contrast enema showed the rectum compressed here by that donut. So, and during the operation, this is what we found. Don't ask me how this happened, but the surgeons left a giant piece of rectum attached to the urethra and then managed to put the rectum through that pouch. And these started growing, accumulating urine and mucus. And then the next question, why the patient only had symptoms when he was over 30 years old? And the answer was, I found during the operation that there was an adenocarcinoma right here. The passing of urine into this bowel mucosa through the years provokes an adenocarcinoma. Fortunately, we got it on time. We cured the diverticulum and the adenocarcinoma, and he's very happy nowadays. Then some years ago, I saw a patient that was born with anorectal malformation, was repaired, was having partial fecal incontinence, but otherwise was doing well. But then suddenly started having urinary incontinence, urinary tract infections, and went to a urologist, and studies show this. This is the bladder of the patient, and this is a mass. This is the sacrum right here, and this is a mega ureter this is an anterior meningocele. This is the dural space right here. So, and also had mega ureters. So this patient was born with anorectal malformation. Somebody repaired the malformation, but they never got an X-ray film of the sacrum. We consider mandatory to always take an X-ray film of the sacrum in all patients with anorectal malformations. Number one, to be able to predict the functional prognosis, And number two, to rule out a condition that is very serious, which is hemisacrum and the presence of a presacral mass. So this patient had a presacral mass and anterior meningocele. He was like, I think 40 something years old. And I operated on him at the University Hospital in Denver, Colorado. And then when you see a patient that has a sacral defect and anorectal malformations, we are obligated to take an X-ray film, not only in the brothers of the siblings of the patient, but also the children of the patient. So several members of this family had also hemisacrum. But sometimes the defect is very small and the patients only suffer from constipation, but others suffer from severe neurogenic bladder or fecal incontinence. Here you see during the operation, the patient is in prone position. The head of the patient is here and the genitalia are here. So this is a midline incision. And then this is the mass. And I left a drain because there was a very large dead space in that area. The patient symptoms improved significantly. Another very common reason why we have to deal with adults, sometimes old people, is because they suffer from fecal incontinence. And the first thing we offer them is our bowel management program. We are very proud of our bowel management program because we believe that we were able to improve significantly the quality of life of hundreds of individuals in a very significant way, and more than with any kind of surgical procedure. So we have been doing bowel management, giving enemas through the rectum for years, but then came the Malone procedure. Dr. Malone in England used the appendix for the administration of enemas. So free patients come here, the enemas are working, but it's very uncomfortable for an adult giving himself the enema. So we offer them the Malone procedure and we use the appendix, of course, you can see here. And we introduced several modifications to the original Malone procedure. For instance, you see here the appendiceal artery and you see the branches of the appendix here. And what we decided is to make windows between the vessels of the appendix. But through those windows, we can put stitches because when you plicate the colon around the appendix to make it continent, you are compressing also the appendiceal vessels. So if you put the stitches through these windows, you preserve the blood supply of the appendix in a beautiful manner. You see, now you see here the plication of the cecum around the appendix, but these stitches go through this is one window of the mesentery, this is another window of the mesentery. So we have done several of these Malone procedures in adults and they really love it. And say you see the administration of enemas through the appendix, but sometimes the patients have no appendix, and for that we published a long time ago the creation of an appendix. In other words, a continent neo-appendicostomy. So there's a few tricks that I will show you how to make an appendix. Actually, sometimes we make neo-appendix that are more beautiful than the normal appendix. If you look at the blood supply of the colon, and this is the cecum, this is the ileocecal valve, the patient has no appendix. So you will see that the vessels come perpendicular to the main axis of the colon. This is the main axis of the colon, and the vessels reach like that, perpendicular. And they go in front, some set of vessels go behind, other set of vessels go in front. So the vessels from behind go like that, like that, like that, like that, and in front come like that. So you select one particular vessel here, and that's going to be blood supply to this flap. And it's very interesting that you can make a very long flap like the one that you see here. And behind this flap is the vessel that gives nutrition to all this. So we tubularize this like that. We close the cecum, and then with the tubularized vessels, here is the already tubularized. This is the new appendix. And you will be surprised how good blood supply it has, provided you meticulously look at the vessels in that area and select what part to use. And then you have to lay down the new appendix on the anterior wall of the cecum. We try not to put the new appendix here in front of this suture. We never like to put sutures in front of a suture. So the new appendix will lay down in front of a normal colonic wall and not against this suture line. Like here you see, and this gives continence to the new appendicostomy. So we are very proud and very happy of that procedure. Another thing, other case in females, but we have seen a series of females. In the main problem in females that we see are patients that were born with a perineal fistula or a vestibular fistula that was not detected, because frequently the neonatologists or the obstetricians, even when they examine the baby, sometimes they are not meticulous enough to separate the little labia of the baby and see exactly the anatomy of the baby. So that's why many babies with vestibular fistulas or perineal fistulas are born and they are discharged home without diagnosis. Later, and the baby is pooping and the mother doesn't look there, and the pediatrician is not meticulous enough to see it in detail that, and the patients grow up having sometimes constipation and eventually have problems. Sometimes they get married, and when they get married, they finally confess that they are very unhappy about the fact that the rectum is attached to the vagina, and they suffer from different degrees of fecal incontinence. This is a patient, 54-year-old lady. This is the rectum, this is the vagina, and they sometimes they remain silent because they consider this kind of secret and dirty. And they finally came out of the closet, and we tell them this, we can fix this. And when they see the result of the operation, they are really fascinated. We had patients that had a rectovestibular fistula, and they got married, and they feel shame because of the malformation. They are unhappy about having intercourse with the husband, and finally they come and we tell them what they had. Some of these patients were seen by adult colorectal surgeons, and they didn't do anything because that's the main reason why we emphasize the importance of transitional care. And so this is a vestibular fistula, and this is the treatment that we do in more than 200 cases of vestibular fistula in girls, and put the rectum in the right position and be sure that we leave as a very normal looking perineal body. And we do exactly the same operation in adults. It's more bloody, it's more spectacular, but technically is the same except that magnified. And here you see this patient that I show you. This is the vagina, and the anus was here. There was no perineal body. I already separated the rectum and put it in the right position using the electrical stimulator, and this is the perineal body, and the patients are very happy after that. This is another patient this is your patient. This is the vagina, and this is the rectum. It was a 19 years. It was a teenager, and Dr. Bishop repaired the malformation. Look at the result. The anus now is here, and the vagina is here. 25-year-old with an undetected rectovestibular fistula was left untouched since birth. And for those who are not familiar with the sphincters in the perineum, we have learned that this is the normal color of the skin, and this dark or reddish discoloration here happens to be the sphincter. So if you don't have an electrical stimulator, you double check when you have the opportunity, you will see that all this is a sphincter. So this rectum should be located in the center of the sphincter right here. If you have the electrical stimulator, you will confirm what I'm telling you, that this for sure is the sphincter. This is the rectum, this is the vagina, and this is the urethra. That's the repair of the malformation. The rectum is completely separated and repositioned within the limits of the sphincter. That's the anoplasty. And after we remove the tension and stitches, that's the way the patient looks like. I'm very happy. Perineal fistulas are more common, missed by the neonatologists and pediatricians. So the rectum is not attached to the vagina, but is located anterior to the center of the sphincter, but is most of the time is a stricture. And those patients come to us with a huge megacolon, severe constipation that many doctors try to control and were not successful. And so we repair the malformation, but first we have to clean the bowel completely. We keep the patient 1 week with nothing by mouth. Nowadays, it's fashionable to say, particularly between adult colorectal surgeons, to operate without bowel preparation and to feed the patients very early. And some publications demonstrate that it's feasible. Demonstrating that something is feasible doesn't mean that that is mandatory or that should be that way. If you operate on 5 patients and they do well, but this number 6 patient has a complete dehiscence full of stool, and the patient will need a colostomy, another repair, with that single procedure, you will never forget that. It's a very, very bad experience, particularly because these patients are born with a benign malformation. These patients should have 100% bowel control if you do the right operation. And if you control the constipation, because all of them suffer from constipation, and that's another discussion that we could have about the aggressive management of constipation. So we repair this malformation. Here's a 45-year-old with rectoperineal fistula. This is the vagina, the clitoris, very short perineal body, and a stricture anus, and these are the limits of the sphincter again. So this rectum belongs here. And we have, and then in dealing with cloacas, patients that were born with a cloacas before 1980, there was basically no treatment. And then some surgeons started trying to repair cloacas, and the only thing that they actually repaired was the rectum. So they pulled the rectum down and they left the patient with a urogenital sinus. So this is this is an adult patient. This is the urogenital sinus, and this is the rectum. But they did not touch the vagina. So, and now with the advent of laparoscopy, now surgeons again are doing that, repairing the rectum and leaving the patient with urogenital sinus, which we consider a mistake, because when you repair a cloaca, you are there. This is the gold opportunity to repair the rectum and repair the vagina and repair the urethra. And if you don't do it at that time, the repair of the vagina later in life is much more complicated. So the patients come to us, many patients come to us with a urogenital sinus and a rectum. And look at another patient. There's the rectum was successfully repaired, a little mislocated because actually the rectum belongs here, and a urogenital sinus left untouched. And so the most common reoperation that we do in cloacas is the repair of a urogenital sinus in a patient that was born with a cloaca, underwent a procedure in which the surgeon only repaired the rectum and left the urogenital sinus, like you can see here. So those patients need a full reoperation for a cloaca, and we all frequently the rectum is mislocated, particularly when the surgeons don't pay attention to the anatomy of the sphincter. We have seen patients that come with a anterior mislocated rectum and prolapse, or posterior mislocated rectum, and we have to reoperate on them. Or even lateral mislocation of the rectum we have seen. And we have a series of patients, female patients, that come to us with cystic masses in the in pelvic cystic masses. Could be, frequently are ovarian masses, but also sometimes we've found something very interesting. As you know, a significant number of patients with cloacas are born with 2 hemivaginas, but sometimes they have an atresia of the cervix in one of the hemivaginas, not in the other. Here, the uterus, when they produce blood, they drain very easily. But in this case, there is an atresia of the cervix, so when the patients have menstruation, they menstruate through the fallopian tubes into the peritoneal cavity. So this is characteristically when the patient has no symptoms when he's a little girl, but when they reach puberty and starts having signs of puberty, and then you expect them to have the first menstruation, they start having abdominal pain, severe abdominal pain with monthly exacerbations at the time of so they menstruate with one side, but not with the other. And there are different variants of this problem. So this only represents the lack of index of suspicion in surgeons who operate in these patients and did not know or forgot that these patients have high chances to have 2 hemiuterus and 2 hemivaginas, and have to be sure that they are patent. So when we operate on this patient, and this is a laparotomy finding in a patient that has retained blood in the urine, hematometra, and because of atresia of the cervix. So this is all what I have to say for the time being. I really appreciate the opportunity. I feel very honored from the organizers to invite me to participate. And I look forward to see that the concept of transitional care become more and more popular all over the world, not only for anorectal and colorectal and urological malformations, but all other congenital malformations. It's a similar drama in the other congenital malformations, and we have not been taking good care of our adult patients, patients that we operated. And we, pediatric surgeons and pediatric urologists, are obligated to promote this because these are our patients. Thank you very much.
That's an amazing presentation. Thank you so much, Dr. Pena, and a consolidation of immense experience. There are some questions that have come up on the chat. I'm going to try and get through those. Is MRI something that you use in all your patients with anorectal malformation, or do you just focus that on specific groups?
Yes, for these patients that already had an operation, and we always do an MRI of the pelvis, an MRI of the abdomen, and an MRI of the sacrolumbar spine to rule out the presence of tether cord, because in the old times, pediatric surgeons did not suspect it and would pay no attention to the presence of tether cord, and now we are seeing those patients.
Thank you. And then in patients with rectovestibular fistula, adult patients that is, do they all need a colostomy?
Oh, not all of them. For vestibular fistula patients, we discuss with the patients, and sometimes we operate without a colostomy, but we are extremely conservative. First of all, the cleaning of the colon is very meticulous. We ask the patients to drink an enormous amount of golightly until the liquid that comes through the rectum is transparent, and our fellow voluntarily drinks that to demonstrate that it's clean. That's when we consider it clean. Now, in adult colorectal surgeons, though they don't pay much attention to the cleaning of the colon, because they have demonstrated that the incidence of dehiscence of bowel anastomosis of bowel surgery is the same with or without cleaning the colon. But what they don't mention in the papers is what happens when you have a dehiscence, a retraction in a patient with a colon full of stool. They don't talk about that. And that's really catastrophic, and it's really tragic when you see that. So we first clean the bowel completely, and then do the operation, insert the central line, and give parenteral nutrition for 8 to 10 days, because if the patients have a dehiscence, that will happen within the first 10 days. After 10 days, we start feeding the patient. Also, that's very politically incorrect, because administrators want our patients out of the hospital, but we like to sleep comfortable, and we never had a dehiscence in those cases.
And then just a couple of questions in relation to dilatation. With anal dilatation, is there a cutoff in terms of time that you would dilate in terms of the age of the child?
Dilations, if it's the same in adult and children, and when do you stop with dilations?
No, it is the same. It is the same, but when the patients have a very patulous anus because they have no sphincter, it's an anus permanently open. Frequently, we don't do dilatation because they will never stricture because it's a patulous anus. So, but when the patients have a good sphincter, we repair the malformation, and as you saw in some of my photographs, at the end of the operation, the anus is closed, and it's closed because there's a sphincter. In those patients, we indicate dilatation like in children. So for those surgeons that claim that dilatations are not necessary in anorectal malformations, they are talking about horrible anoplasties that look like colostomies. These patients don't need dilatations.
And then I'm going to take one final question. Just in terms of after vaginoplasty, do you recommend a topical estrogen to prevent stenosis?
Do you recommend estrogen in vaginoplasties?
I have no experience using estrogens. I wanted to say something about when Dr. Andrea Bishop presented that some of the patients in whom we use bowel for vaginal replacement, some patients with the large production of mucus, we know that the colon reacts to irritation, producing a lot of mucus. And therefore, the irrigation, in addition with saline solution, sometimes we recommend the non-steroid anti-inflammatories that some colorectal surgeons use in inflammatory bowel disease. And that decreases the amount of mucus in the vagina. And also we have seen diversion colitis in a piece of vagina. So that's a bad complication.
Thank you so much. I'm going to wrap up the questions there. Two wonderful lectures. We're now going to move into the final session of today's meeting, which is a series of case presentations. I'd like to welcome back Dr. Bischoff and also welcome Naomi Crouch from Bristol in the United Kingdom, who I've had the pleasure with working together with in London. I'm delighted to see you, Naomi. Thank you for joining us. And Dr. Alessandra Gassio, who I'm also delighted to see. Thank you very much for joining us. So I think that, do you both have cases that you're keen to share with us? Excellent. Do you have any objection if we go in alphabetical order and we take Dr. Crouch first?
Wonderful, that's fine by me. Thank you. Let me just do my best to share my screen. Now, is this sharing and can you see me still?
It is sharing, but we're not on your presenter view. We're on your kind of slide deck view.
That's not very helpful, is it?
Display.
If you switch displays at the top
it.
right of your screen, then you should be able to show us your presenter view.
Screen sharing. Sorry, this always takes me a little bit of time.
You just come over the bottom, 3 more icons that should open up the whole screen.
I'm sorry, say that again.
At the very bottom of your frame where it's yellow now, if you go over 3 more icons, the third icon over there, it should do the full screen at that point.
The slideshow, yeah.
I'm really sorry, I'm not seeing that.
There you are. That's it.
Has that worked?
No. It's still showing your slide deck view.
I've got a complete. It's showing it all to me. Let me see if there is something else on.
I think it's okay if you just move your slides as you go. We can see you well. You don't have to worry much.
It'll work.
I'm really sorry. It works nicely for me. I had the odd animation. Is that any better for you guys?
No.
It's it's to do with Zoom. There is a way of changing your displays. I think the buttons at the top of your screen.
I have done it before. Maybe if I stop the share, and maybe if I start the share again. I'm so sorry. This will take a presentation.
For display view, and that should open it up completely also.
Now, this is my final little approach, and then I will get on with it. Is that any better?
There you go.
Perfect.
Yes, perfect.
Hooray. Thank you very much. I'm sorry I've just displayed across the Atlantic my incompetence in managing to work that. But thank you very much to Dan Wood and to the organisers for inviting me. It's a real pleasure to join in this meeting. As Dan said, I'm a consultant gynecologist. I work in Bristol now in the UK. It might just be worth me clarifying for this audience, I'm not a paediatrician and I'm not a paediatric surgeon. So I'm an adult clinician. I'm trained as an obstetrician and gynecologist, but I reach down to the pediatric and adolescent age group. But my role is very much that in transition and transitioning through to the care of adult patients. Bristol's a city in the southwest of England. We have the largest children's hospital in the southwest England, and we're also commissioned for congenital complex gynecology procedures as well. So that's just sort of a little bit of background just to share with you. So the case I wanted to present today, I've called it To Block or Not to Block, that is the question. So this was a 15-year-old girl who presented to us with a 2-year history of clitoral enlargement and of primary amenorrhea. She'd noticed that her voice was deepening. She'd noticed that she had some chest and some abdominal hair growth. And then she gave a history of these possible lumps in her groin. They came and they went, but when she stood up, she was aware of something. She was originally referred in to the Pediatric Endocrinology Service at University Hospitals Bristol and came in through that into our DSD MDT. Now, a few clues in her history. At the age of 12 years, she had a right inguinal hernia repair. This was at a hospital elsewhere, and she was advised at the time this was an ovary and this was part of fallopian tube, but no histology was taken and no further investigations happened. I think probably in this audience, a 12-year-old girl having an unexpected hernia might start to raise a few eyebrows and wonder why this was happened. But she had a perfectly good, very competent hernia repair, and then she went home and went on her sweet way. She was otherwise fit and well. She had been born via normal vaginal delivery, and she had 2 older sisters who were fine, had started their periods at early teenage years, and there were no other health concerns. There was no significant family history of note, no significant stories of an aunt who couldn't have children or anything like that. So on examination, she was tall and she was 171 centimeters tall and with a normal BMI, and the maternal height, interestingly, her mum was quite short at 155, although dad had a height of 178. On standing up, then there were palpable gonads in the groin when she was standing, and they were a bit fluctuant when she was lying down. There was evidence of hirsutism, which was beginning to bother her, a little bit on her chest, a little bit on her tummy. And she did have notable clitoromegaly, but there was no apparent vagina. The most interesting thing as well that she commented on is that she had really quite marked muscle development over her abdomen, and she found this really entertaining because she said, I do absolutely no exercise, I'm a bit of a lazy lump, but actually I seem to have a 6-pack, and this is the envy of all of my friends. So the investigation showed that she had a raised androstenedione and a raised testosterone, and of course this would account for her virilization. And the genetic karyotype went on to confirm that she had 46XY chromosomes, and a mutation was found, giving a diagnosis of 17-beta hydroxysteroid dehydrogenase deficiency. So we were clear that there would be a DSD, and it confirmed that it was this. As expected, an ultrasound had also shown the absence of a uterus, and she had an MRI, and this showed that both her testes were really quite low down in the inguinal canals. And of course, these were the lumps that were being palpated. So far, so good. The GnRH analog blockers were started to prevent further virilization. And she was given estrogen patches sort of as a matter of routine, partly to prevent menopausal symptoms and partly to proceed down a more female pattern of development. And then there was a pause for thought. But she was then discussed at the MDT. She was followed up in our DSD transition clinic, and as part of that, she was having separate and parallel appointments in psychology. And really, the psychological aspects of this are the areas that I just wanted to think about today, because there's nothing particularly unusual nowadays about her presentation or her diagnosis.
But the blockers gave her a chance to pause, and she had wondered if there was something different about her. She has a memory, age 12, that she'd been doing biology lessons, she'd learnt about difference between boys and girls, and she just thought that her genital appearance was different. And if you remember, it was 12 when she had that hernia procedure, but those little thoughts and those threads were never really followed through. She wanted to take this time now, age 15, just to think about what her gender identity was, thinking partly about her sexual orientation, thinking nowadays as well about that sense of fluidity. Did she really want to stick with one gender or the other? Did she see things in a binary way? And just understanding variation in sex development. And the GnRH blockers allowed her time to explore these issues. And so I think, in contrast perhaps to previous management, the sense of gonadectomy and a female identity and estrogen replacement therapy was not at all seen as a given, even though she'd been reared as a girl all of her life to this point. So a decision was arrived at by her on psychological work that actually she thought, on balance, yeah, she did identify as a female. That was her gender identity, and she would like to go ahead and have a gonadectomy with her estrogen replacement therapy. So this will probably be very familiar to this audience, but for me, this was a new thing. So the fact that she had her gonads as hernias, well, I'm a gynecologist, and so operating in the inguinal canal or sort of inguinal triangles would fill me with horror. This is not an area where I would work in. So I spoke to my surgical colleagues and we planned it as a joint procedure. But rather than just doing standard groin incisions and hernias, then my colleague said, aha, we can take the total extraperitoneal approach. Now, again, this is nothing terribly new. This has been around for 30 odd years and is commonly used for hernia operations. But to a gynecologist, this was new territory and this was exciting stuff. Now, my understanding was that there was a reduced chance of injury, but actually I was interested in the fact that she would have the avoidance of groin incision scars, which might be a reminder in years to come of the differences that she'd been born with. So we performed this as a joint procedure. My surgical colleague came and joined me in theatre. She had a day case procedure. She had this total extraperitoneal approach, had the testes removed, and she went home the same day. She recovered very well physically from the procedure, and the histology confirmed normal testicular tissue. So as a further update, well, she's had ongoing care through the Transition clinic and through our MDT meetings. She's aged 18 now. She's well established on transdermal estrogen. It's suiting her very well, and we're happy with the levels. She was keen to move forward with vaginal dilation therapy. She commenced this and fairly rapidly developed a 7-centimeter vagina. The clitoris had reduced down in size. It had a little bit less kind of width to it with the estrogen therapy and presumably from taking the testes around. And overall, she was pretty happy with her body image. And she was also pretty happy with her genital difference and said, well, this is me. I'm very happy with this. She was sexually active. She had a male partner who'd sort of been supporting her through much of this and with the surgery, and had no concerns at all, and just said, yes, this is me. And things are a little bit different, but all is good and everything's working as I would like it to work. Until the relationship ended. And like most young people nowadays, she was then moving online, doing dating and dating apps and things, and wanted to move forward to think about future partners. And at this stage, she became a little bit less happy with her body image and genital difference, and now wishes to consider clitoral reduction surgery. And this case is really just to illustrate that sense of people thinking about their bodies and what they feel they want to accept. And I wondered if there was a continuum, as we've had one or two other cases like this as well. So from people very much just having standard treatments to going on to having quite different treatments. So over on the left of the screen here is our patient with 17 beta who was given GnRH blockers, and she was given estrogen, sort of pretty standard. And she chose to pause and to have a think and to do some psychological work and think where she was at. And then in the middle, about a year, 18 months ago, we had a patient with 5-alpha reductase deficiency who was given GnRH blockers, but didn't want any estrogen add back at all, and said, no, I really just want to block things, and then think and pause. and became, as expected, had menopausal symptoms, so wanted her estrogen for ADVAC at that stage. And then in the last 3 months or so, we've had another patient diagnosed with 17 beta who has said, well, actually, again, I want to explore who I am. I want to understand my gender identity and how I see myself. I don't want any GnRH blockers at all, thank you very much. I know I've got a raised testosterone compared with typical female levels, and I'd like to try a bit of estrogen and see what that's like. But actually, I want that just on top of my native testosterone. I don't want it switched off, and I don't want it blocked, thank you very much. And it just feels as though we're getting a continuum of people wishing to explore how they might adjust their hormones and how they might see their identities in the future. And it is likely that this is driven by a societal tolerance to sex and to gender diversity. And I don't know how things are in the States, but certainly if I wander around our university campus in Bristol, this is an example of a poster I might see. It's pretty standard, and really just saying, well, people may have differences that may not match your expected norms, but do you know what? Don't worry about it. They're in a better position. So it's a question of what is changing and what is not. Now, this paper is a paper which I quote a lot, is extremely useful in terms of just looking. The recording has stopped. The needs analysis of transitional care. And this is about 10 years old, so this is not a new thing. And it identified the needs on transition for those with a DSD into medical, surgical, and psychological. And consistently, the most pressing issues were psychological, and consistently, those were the ones where the needs were less likely to be met. So, are these changes representing that psychological work is now becoming more prominent and having acceptance, perhaps by patients, perhaps by families, and perhaps by clinicians? And is there a change in attitude to time taking and reflection? And this is just an update as well as what's happening in Europe regarding some of these issues regarding DSD. So this is the Council of Europe, which was set up in 1949 by 10 member countries initially. And it was predominantly, it's a human rights organization, and it's looking at the respect of human dignity, and particularly those who may have limited decision-making capability. There are 46 member states currently. It's not the EU, but all 27 member states of the EU are members of the Council of Europe. So it's very wide-ranging, and it's lots of different attitudes and thoughts coming together. And in 2017, then the Parliament of the Council of Europe passed a resolution ordering member states to prohibit medically unnecessary sex normalizing surgery, sterilization, and other treatments practiced on intersex children without their informed consent. So in other words, the idea of any sort of irreversible treatments without people having a clear time to think about it and to give their informed consent. And we're also seeing some legal rulings for trans children is influencing our DSD debates. And so the Royal Courts of Justice is the highest court in the land, and this is based in London, otherwise known as the Old Bailey. And when they're not involved in judging what happened in the marriages of Hollywood actors and actresses, then it's also looking at other areas, including trans children. And a case in December 2020 was the case of Child Bell versus the Tavistock Clinic. And the issue that was brought was, could puberty blockers be used on a child under the age of 18, and whether that was appropriate or not. So Child Bell had come along as a child with gender dysphoria and had wished to have puberty blockers and wished to have testosterone to become a trans man, and had this, of course, had some irreversible changes, and subsequently as a young adult had transitioned back to their original sex of rearing. And the challenge was that as a child under the age of 18, they were not in a position to give consent. And the English High Court judgment was that, yes, a child under 16 does not have capacity to consent to these irreversible changes. And those aged 16 to 17 may have capacity, but they can't have treatment without application to the court. So this was really wide ranging and had a knock-on effect to DSD debates and decisions about treatments and what can be offered and what can be agreed to. A subsequent different case found that parents could consent for their children if it was in line with the child's wishes. And there was a multi-agency appeal by the Tavistock Clinic and by others against the original ruling of Bell versus Tavistock in September last year. And that found the original case from December was overturned, saying actually no, healthcare professionals can work with the child and they can give consent. So this is having a big impact on DSD. So DSD and trans are dealt with in different services. They're not common pathways, but they are often sort of looked at together and conflated in terms of legal and parliamentary proceedings. So what does this mean for DSD services? Well, there is arguably a widening of options for those with a DSD. So our sense of moving forward with surgery, with medications, there can be a pause, and that pause could be really quite pronounced and for a long time. So that is promoting and validating a clear non-surgical pathway for care. But of course, in some ways, it's providing more choice. But as clinicians, we don't really have any clear answers or long-term outcomes for those individuals. And I'm really interested as to whether other people are seeing this as well in transition services and what their thoughts and views are on that too. So many thanks indeed for inviting me to present, and it's been a pleasure to join in. Thank you.
Naomi, thank you so much. I mean, that's a kind of fascinating case that opens all kinds of important questions. But just in terms of two practical questions. First of all, in this kind of changing environment that you've referred to and that kind of came up in one or two conversations earlier, how does your MDT manage those difficult decisions with a patient or with their family or with their family? And secondly, who leads your MDT? So I think that's in terms of how we balance those meetings and those discussions, I think that's quite important.
Thank you. So I think the first question is actually who leads our MDT, and it's led largely by our psychologist, and then pediatric endocrinology as well, because they're often the people bringing the patients to the transition clinic, and then we're sort of transitioning them into adult services. And in terms of how we balance them, I think, again, that's very much the psychological role. So as well as being discussed medically, in a way, the medical things are almost fairly straightforward. We've got an accurate genetic diagnosis, we've got good knowledge and understanding of some of those conditions, but the psychology is hugely lagging behind. And we're finding our patients are questioning and asking us things, and we don't have the answers, as they're saying. So to me, it was quite new, the concept that you'd have estrogen replacement therapy, but not block your testosterone if you've got 17 beta. You know, I don't know what that effect would be. So in terms of managing it, it is a transition and working with the families and working with the individuals. But we've realized that there isn't a time limit on using GnRH blockers. It is about those individuals making very clear decisions. And the idea of gender fluidity or things changing just feels as though it's very new. It's, I think, being very influenced by a lot of the trans debates, but we're finding as clinicians that actually our patients are often the ones leading the way in what they might want to do.
I think that's a fantastic discussion and a very hard topic. In a personal opinion, I think the law should just supervise that there is no paternalistic decisions, but it should not mandate one day or the other, because we also harm patients by not intervening. And for some patients, that fluidity or that non-characterization may be hard for them to grow. Yes, some societies are more accepting that than others, but I don't think it's necessarily easier to live without a gender determination in a young age when you're not mature enough. And to think about the relationship between the child and the parents and how much can be determined by the parents, it's also a very hard topic. We all know that when children, we depend on our parents, and we are fortunate to have good parents, good families, and we know and we witness children that are not in that similar situation. So I think we have to individualize treatment based on the family, the child, how mature the child is, what are the family wishes. But I hope that the law also does not determine, because I'm afraid that will damage some patients too.
It's quite a blunt tool, isn't it? These decisions, black and white, and having a law saying, right, you can do this or you can't do this. And you might think, well, I work in DSD, why have I put things about trans? But we find that often in parliamentary proceedings and in legal things, people very much confuse DSD and trans or use the same laws, whereas I'm not sure either community are speaking for each other. And also very much, I think that echoes your point that some of the communities that the families that we see come from will have very variant views within Bristol. You know, we've got a wide range of communities. We have lots of migrant communities as well. And absolutely, it's not a one size fits all. I wonder if in the past it almost was, and we almost in some ways fell into saying, well, we recommend gonadectomy, we recommend replacement. We are just getting more questioning, and challenge is perhaps the wrong word, but I think to be unaware of the high profile cases that are happening in parallel areas, and it's often they will be put together, certainly in commissioning services, certainly in NHS England, it's really useful and helpful for us to be aware of these debates. Just in May at the Council of Europe, there was a big DSD meeting across Europe, very much looking at human rights. So it's high profile, and the work that we're doing in DSD and transition, whether we like it or not, people are watching and are scrutinizing what we're doing.
Absolutely. Dr. Bischoff, would you be kind enough to introduce Dr. Gacier, and then we can, in the interest of time, move on to, I think, probably what will be our final case of the day.
Yes, wonderful. So it's my pleasure to introduce Dr. Gacier. She is those rare jewels because she is trained in pediatric colorectal surgery and adult colorectal surgery. So I would say there are very few people in the world, few surgeons in the world with this specialty that truly understands one world and the other world. So that's why we wanted her to join this meeting, and she can go ahead and present her case. Welcome, Dr. Gacier.
Thank you for having me. I have 3 screens and I'm trying to give myself the right one. I
think we're seeing 2. We are seeing the presentation mode. So we see 2 slides, your first and the next.
Correct. Let me see if I can undo that. Just one moment. Thank you for being patient with me.
You want to hit the display mode.
Yep. Yeah, let's see if it'll let me do it better here now. That's still not the right one.
It's perfect, I think. There's nothing. That's the one we wanted, I think.
That was perfect, yes.
All right.
Yeah, that one was
Sorry.
perfect.
It looked different on my screen. It did not look like the right one on my screen, but let me try that again. Hold on. Sorry, it's usually, I have no trouble with this usually, but of course. Okay. How about there? Is that better?
Yep.
Okay, very good. Well, thank you for that kind introduction, Dr. Bischoff. My name is Ali Gacier. I am dual trained in Pediatric Colorectal Fellowship as well as Adult Colorectal Fellowship. And my purpose of this journey with both pediatric and adult colorectal surgery came about in my pediatric colorectal fellowship days, treating adult patients in our pediatric clinic and hearing very similar stories to what have been presented about the adult colorectal community in the United States, just not having a good understanding of our patient population. And so I took it upon myself to do an adult colorectal fellowship so I could bridge the gap for the care for those patients, but also to educate our adult societies. So I have a very active role in our ASCARS, or our Academic Society for Adult Colorectal Surgery, to help educate and bridge that gap between the two groups. So thank you again for this distinguished honor to present today. I have a case study that I hope you guys will find interesting. Okay, very good. So this patient is a 26-year-old female with a history of anorectal malformation. She had a colostomy in 1994, followed by a Pena procedure, anoplasty with urethroplasty in 1995, followed by a neovagina with ileum, appendicostomy with bilateral salpingectomy in 1995, and then the colostomy takedown subsequently. When she presented to our clinic, she complained of having this small bowel neovagina with pinpoint stenosis and a urethral diverticulum. She was voiding via urethra with recurrent urinary tract infections, having urgency, urinary incontinence with 3 pads per day incontinence, mucus leakage from the neovagina, and amenorrhea. She also had severe constipation. The way that she had gone about her life managing this, as she was not followed by anyone since about 1995, is that she would take several laxatives every other weekend and none during the week. She would only stool during these laxative weekends, and she would have to stay home during this period so she could make it to the bathroom in time. She had occasional accidents outside this period with fecal urgency. Of note, she works full-time outside of the home. However, because of these long-standing medical issues, she had a lot of depression and anxiety surrounding her medical diagnosis and medical trauma. On her physical exam, she had what appeared to be a normal labia, a perineal body about 2 to 3 centimeters, with a less than 1 centimeter introitus that was very small. When probed with a Q-tip, we were able to insert it about 3 centimeters, then meeting resistance. Her anoplasty was slightly posterior with external accessory muscles, with augmentation of her sphincter tone, with otherwise poor resting tone, appropriate pelvic floor relaxation with Valsalva. She had no rectocele, no prolapse, and no stricture. Imaging that was done included the renal ultrasound with normal appearing kidneys. A pelvic ultrasound showed no uterus, no cervix, bilateral ovaries. Her urodynamic study, we were unable to place a catheter due to urinary stricture at the proximal and mid-urethra. We also had a pelvic MRI that showed post-surgical changes consistent with the given history of repair of complex cloaca. There were 2 cystic foci adjacent to the urethra measuring 4 millimeters, representing likely a small urethral diverticula or less likely post-surgical changes. And this is a picture of her contrast study done via the rectum that demonstrated no evidence of stricture or twist, some dilation of the right colon. So we took her for an EUA vaginoscopy and cystoscopy. We found that she had a hole in her right labia. There was introital stenosis and an 11 centimeter stenotic bowel neovagina with a stricture at about 5 centimeters. The anoplasty had mild posterior and right lateral mislocation. A Hagar size 18 easily passed without evidence of a stricture. Muscle stimulation revealed little or no muscle activity, with slight on the right side, however, slight muscle activity on the right side, but really nothing of significance. She did have prominent right-sided bulbocavernosus stimulation and no evidence of prolapse. She had a normal bladder with good capacity, a small urethral diverticulum, and a urethral polyp that could be inflammatory, as well as the stenotic vaginal introitus with 1 area of stricture within the neovagina. So in discussion with our multidisciplinary team at the adult side at Ohio State, the urology plan was for urethral diverticular repair in the same setting as the neovagina reconstruction. From the gynecology side, neovaginogram was done to assess the neovagina dimensions, and then decide if the proximal neovagina could be preserved. From the colorectal plan, an anoplasty with posterior and lateral, right lateral mislocation was found. However, the muscle nerve stimulation had little or no muscle activity. The right side had very little, however, nothing significant. Clinically, the patient was fecally incontinent about once per month, currently on a bowel regimen every other weekend with laxatives. So our plan was to try a Peristine enema program to improve independence and quality of life, as well as pelvic floor physical therapy to improve the muscle that was present. So the vaginogram, cystogram, again showed the stenotic neomeatus with the vaginal stricture at about 4 to 5 centimeters proximal to the introitus, with a patent urethra with no stricture and no demonstrable stress incontinence. So then we took her to the OR, and we did an exam under anesthesia with neovagina, small bowel mobilization, with neovagina introitoplasty and complex neovagina small bowel reconstruction, with a vaginoscopy of the neovagina and right labioplasty. The small bowel neovagina initially had that pinpoint opening. We were able to pass the cystoscope to visualize the patent open neovagina and healthy bowel tissue. Again, there's no evidence of a urethral fistula. The small stricture was noted, approximately 3 to 4 centimeters proximal to the introitus and dilated easily. At the end of the case, the neovaginal introitus easily accommodated 2 examining digits. With that, there was the perineal dissection, as well as from the urology aspect, the female urethral diverticulectomy. And we did a perineoplasty using a local flap that was about 5 by 5 centimeters. And this is a technique that's often used in DSD patients. Postoperatively, the patient appeared to have a vaginal exam separation of the posterior aspect of the neovaginal mobilization. Circumferential mucosa was seen, and the area immediately post-op was very edematous, however, no erythema, but she did have good resolution of her urinary symptoms. She underwent a bowel management program with Peristine. She was using daily Peristine with a regimen of 500 mLs of saline and 25 mLs of glycerin, being clean and continent in between. However, with this dehiscence postoperatively, we planned for a second operation. And this second operation, we underwent a vaginal introitoplasty, this time with buccal mucosal flap. And this is her preoperative image. During the procedure, we did mobilization of the bowel neovagina with introitoplasty and urethroplasty. The starting vaginal introitus was a size 3 Hagar opening. At the end of the case, we were able to pass a size 18 with 2 examiner width digits at the end. Her follow-up exam under anesthesia showed 90% take of the buccal mucosal flap. The vaginal introitus accepted at 18 Hagar easily, and the Foley catheter was removed, and this is about a week after surgery. In her post-op visit a month later, we were easily able to pass the examiner's index digit as well as the Hagar 10, passes depth of 7 inches and 90% graft intake at that time. At that point, we then recommended her to do Hagar dilations, and she slowly ramped up her dilations about every week and a half or so as she was able to. At her 3-month follow-up, an 18 Hagar passed easily in the clinic, and she was participating in pelvic floor physical therapy and able to participate in intercourse. So that was my case presentation. I'm happy to take any questions.
Thank you so much. I think what I like about this case is just that it represents, unfortunately, a familiar situation that patients that are born with an anorectal malformation, if they are not properly followed, they reach adult life and they follow this pattern. They don't eat during the day, and then they will eat at home, so they have accidents at home, and then during the weekend they do this bowel clean out. So hopefully they will reach good centers, and like this one, I can only imagine how much her life was improved after she had the reoperation and was placed on proper bowel management.
Yes, absolutely. I mean, I don't know how many patients I've had with a similar story that come to our office, and I'm sure you guys have seen the same, and they're so grateful. They're so frustrated, but grateful to have found us, and frustrated with their previous care that they've seen. And after we're able to reestablish their quality of life and get them to be continent and get them to have a functioning neovagina and resolve their urinary issues, it does give them a new lease on life. Some of my patients have become on disability. Some of them are able to go back to work, but they all share the same amount of gratitude that is so heartfelt and so rewarding, and makes all the all the time and effort we put in as providers so worthwhile.
Wonderful. Thank you so much, Dr. Gaisior. We want to try to stay in time. So if there are any questions, please type in the chat. If not, I would like to thank all the presenters from today and everyone that joined with your good questions. I think this has been a wonderful meeting. I have learned a lot, and I think there's so much more than we all can do as a community to improve transition of care for the benefit of our patients. So we look forward to see you all tomorrow. We're gonna start again at 7 a.m. Hopefully Zoom will not give us problems, but I'm happy that we were able to manage everything. So thank you, everyone, and we'll see you all tomorrow. Dr. Wood, do you wanna say goodbye too?
Yeah, exactly. Thank you so much to everybody. A thoroughly enjoyable day. I've learned lots. I hope you all have too.